Good morning, everyone. Welcome to the 6th Annual Cancer Health Disparity Symposium. Dr. Sally Fu is going to begin the symposium with some welcome remarks, followed by Dean Brunicardi and Dr. David Tuvison.
Good morning to everyone, and thank you for coming. I wish we all had the chance to be together as we did in the last 5 years, but the pandemic is not easing up that fast, so we have resorted to technology to get these conferences going. So I appreciate your time and commitment to the conference and making the all efforts to participate. As you know, pancreatic cancer and colon cancer are big problems in the United States. African Americans and mostly minority patients are dying at a very alarming rate, usually in their earlier ages and more advanced diseases. So there has been a very large outcry in the country to try to bring people together from the NIH perspective to study why these events are happening and to figure out what we can do to remove these kinds of disparities from GI cancers. So in 2015, I got the chance to collaborate with SUNY Stony Brook, our sister campus at Stony Brook, and Cold Spring Harbor Labs. We applied to the state of New York to give us small seed funding to test whether we can actually create a partnership. We tested the partnership and it was actually good. We saw that we could actually work together and begin to formulate a plan towards reducing cancer health disparities in this area. Then in 2015, we were lucky enough to use the seed funding from the state of New York to apply to the NIH, and we got funded through a P20 mechanism. That mechanism allowed us to actually formalize the partnership. We worked together so hard in creating biobanks of African American samples that were collected at SUNY Downstate, and also Caucasian patients collected at Stony Brook. And Cold Spring Harbor Labs was the scientific basis for the grant. They then conducted some of the very innovative, fancy work that allowed us to complete the project. Now, after the 5-year project was ended, NIH funding ended in 5 years, we were lucky enough to get continued funding from the New York Genome Project, that is Polyethnic 1000. So I think this partnership has really flourished, coming from seeking funding from the state of New York to getting NIH funding to getting continued funding from the New York Genome Project is really remarkable, and it's a testament to what can be done when people actually want to address a particular issue. So today we would have very good speakers line up to give you more information on this subject. We aim to inform everyone, clinicians, trainees, students, and anyone in the public health sector who's interested in the subject on some of the advances in these two cancer areas. We have a keynote speaker, Dr. Otis Browley from Johns Hopkins University, and many talks from highly distinguished panel members who will be sharing similar topics. On behalf of SUNY Downstate Health Sciences University and the Brooklyn Health Disparity Center, Cold Spring Harbor Labs, and Stony Brook University, we want to welcome you and thank you for being part of this exciting program. I would like to call upon my dean, Dean of the College of Medicine at the State University of New York Health Sciences University in Brooklyn, to give us some opening remarks. Dr. Brunicardi is an accomplished surgeon. He was actually a resident of SUNY Downstate Health Sciences University many moons or years ago. He made his career, all the way to becoming the editor, the lead editor of the Schwartz textbook of surgery. I mean, this is an accomplishment that only one person can do it at a time in the world, and he is the one. So we're so proud to have him come back to SUNY Downstate to lead the academic mission. And so I invite Dr. Brunicardi to give us some opening remarks.
Thank you, Dr. Salafu, for that kind introduction. I'm honored to have been asked to give the opening remarks for the 6th Annual Cancer Health Disparity Symposium, a virtual symposium. I welcome our sister institutions, Stony Brook and Cold Spring Harbor Laboratories, and we're delighted that the project is funded by the New York Genome Project. I welcome all the distinguished speakers from anchor institutions all over the nation, from Kansas to Puerto Rico. And I'm really excited about the topics that will be discussed. What I'd like to do is give a little historical background on where we're at. And one of my great areas of interest is in precision cancer therapy. So the humans have been on Earth for 7 million years. Civilization's been around for 100,000 years, and yet the golden era of medicine is really the last 170 years, since 1845. We now enter into the age of precision medicine in the 21st century. If you go back to the 1860s, Gregor Mendel was an Australian monk that did gardening experiments. He came from a gardening family, and he discovered that in pea plants that there were Mendelian genetics. He wrote a paper, and the paper was largely ignored till about 50 years later, when a prominent scientist came upon the same finding and rightfully gave Gregor Mendel credit for Mendelian genetics. About the same time in the 1860s, Friedrich Miescher pulled out a stringy substance from pus, and it was found to be DNA. And the race was on to find out the structure of the DNA. So the race was on, and on your left is James Watson, who came from Illinois and got his PhD in Indiana, and he went to Cambridge to join Francis Crick in their research studies to find out the structure of DNA. And then Maurice Wilkins and Rosalind Franklin were at another institution in London who are also working on the same thing and doing X-ray crystallography. And in 1953, Dr. Watson and Dr. Crick discovered the DNA structure, but they would not have been able to do that without Maurice Wilkins and Rosalind Franklin.
Hey, Dr. McCarty?
Yes?
I like this story a lot, but your slides aren't showing.
It's okay.
Okay.
I'm just talking from the top.
Okay. All right.
So,
keep going.
so they would not have been able to, so the three gentlemen on the left won the Nobel Prize. Rosalind Franklin did not win the Nobel Prize because she died of ovarian cancer in 1957 to the Nobel Prize. And certainly she would have been the fourth person to win the Nobel Prize had she survived ovarian cancer. That takes us 50 years later to the Human Genome Project, which the sequencing took 10 years and cost $3 billion. If we then flash forward to 7 years later, the Baylor College of Medicine and Richard Gibbs sequenced James Watson's entire DNA using 454 pyro sequencing, which took 2 months and cost $1 million in 2007. Now, that represents a 10,000-fold increase in speed of sequencing and a 10,000-fold decrease in cost. So that leads us to 2010, when Francis Collins said it is fair that the Human Genome Project has not yet directly affected the healthcare of most individuals. So what we now need to do is to figure out, we need to figure out how to connect the sequencing to the care of the patients. And that includes the disparities of health as well as social determinants of health, and figure out how we can have excellent outcomes for patients with cancer for all of our patients. And so the way I see that happening at connecting the genomic sequencing with clinical care is finding targeted genes for cancer. And so we did a study in Toledo, Ohio, where we looked at nearly 200 patients who were on targeted therapy based on foundation medicine genomic sequencing compared to those who are on standard chemotherapy. And we saw that there was a significant decrease in hospitalizations, a significant decrease in ER visits, and improved quality of life. And we were verging on showing a prolonged survival with targeted therapy. So I think that's the future of how we will find better outcomes for patients with cancer, is through precision cancer therapy. So I look forward to today's talks, and I want to thank Dr. Salifu for inviting me to give the opening remarks. It'll be a very, very exciting symposium today. So thank you, everyone. Dr. Salifu.
Thank you very much for that wisdom. We always appreciate that from you. We would remember all that stuff and in the context of our symposium. All right, so the next person to give opening remarks is Dr. Tuvison. I don't think I really need to introduce him because he is omnipresent. He's very omnipresent, and we've introduced him so many times that I would just say just a few things. He's currently director at the Cold Spring Harbor Lab. His lab is actually named after him, the Tuvison Lab, because of what it does. I have, encountered so many, PhDs and postdocs work in his lab, and just amazing things. And just to connect with what Dr. Burkhardt said, he is actually the master in this area. He is, looking into precision medicine, exactly what Dr. Burkhardt said, looking at pharmacotyping and all those novel, approaches to, making sure that cancers get nicely typed. We know exactly what they respond to, and bring it to clinical medicine. So it's my pleasure to introduce Dr. Tuvison to give opening remarks. I'll be introducing him again later on as a session moderator, but for now, it is to ask him to give opening remarks.
Thank you so much, Dr. Salufo, and good morning, everybody, and Dean Brunicardi. So this symposium represents a collective effort by multiple medical and research centers on Long Island and in Manhattan. It's around a topic that is very germane in the understanding of human disease and human cancer. How is it that cancer is different across populations, across races, ethnicities, geographic locations? I want to just put in one thinking point early on, though. To me, the term disparities potentially is being used incorrectly. To me, it's really differences that occur across populations, not necessarily worse, could be better, that you see cancer in certain populations, and I'll explain what I mean. So it's easy to think that cancer is worse, for example, in certain populations, but it's harder to think that cancer actually outcomes are better. But in fact, that is the case. So when you think about glioblastoma multiforme or lower esophageal cancer, these are cancers that are very uncommon in African Americans. And they're much more common in European ancestry folks. And that knowledge helped identify a gene which was broken in European ancestry individuals in GSTT2, which is a glutathione transferase gene, and explains why Barrett's esophagus is rare in African Americans and much more common in European ancestry. I apply that same logic to pancreas and colon cancer, that even though the numbers in the States suggest that more African Americans get pancreas cancer or do worse than European ancestry, and we are all looking for genes, be they germline or somatic, we may actually find that there are multiple alleles involved in these diseases that modify the core pathways. That's most likely what we're going to find, is modifier alleles that are African, modifier alleles that are European, modifier alleles that are Hispanic, Native Pacific Islander, Native American, et cetera. And this genetic investigation adventure that we heard about from Dr. Brunicardi is going to yield insights if we can compare populations. So it's really comparative medicine that we're trying to do in efforts to ask, is there something about the genome, or is it something about the way people live? Is it in their environment that would explain differences in cancer incidence and outcomes? So this is a topic that is age old. It's only starting, I think, to reveal fruits. But what we're learning in one population helps us understand the disease in other populations. And it only happens if there's a community effort. And Dr. Salufo, with Laura Martello Rooney, the organizer of this meeting, really started this project all those years ago with Ellen Lee and Jenny Williams at Stony Brook. And I think they invited me last to their discussions. And I was obviously very intrigued by this, and we've worked on it carefully and slowly, and have achieved some measures of success in getting that first NIH grant, and then the more recent New York Genome Center support. But this is a community effort. That's, to me, the key thing here. It takes physicians and community hospitals and trainees, as well as research scientists at both at all of our sites and the New York Genome Center to do this properly, because we have to do it on scale. We need lots of samples to look into the genome, and we need lots of folks to talk about how do people live, what do they eat, how much do they weigh, and then that even leaves out these issues about the microbiome, which probably play a role in both of these GI cancers, and both from the mutagen carcinogen standpoint as well as from the inflammation standpoint. And then the final shout out I'm going to give, I think there's a science behind something called stress. And I don't mean you're nervous about the test you're taking tomorrow. I mean chronic stress. And this is something that sociologists have studied for a long time, the premature aging that occurs in folks that live in a scenario where they live more crowded and they don't get a good night's sleep and they're working 3 jobs. These are processes that age the body and stimulate all kinds of diseases, including cancer. Now, our projects haven't been about that. Our projects have been about what Dr. Bernicardi is talking about. Can we find a gene? Because that's something, you start with a hypothesis, you can answer the question. And we haven't even finished that question. But I think as we keep working together and looking for measures where we can help, we will spill over into these other areas. And so we will always be looking for people who have ideas along these lines to become trainees, to work in any of the 4 institutes, which Dr. Salufo and Laura had on that first slide. We will certainly be looking at any new way to look at the genome and transcriptome at Cold Spring Harbor using tissue models and pharmacologic perturbations, et cetera. But Laura and her colleagues at Downstate will be doing sort of an analogous approach to look for pathways and drug targets in these diseases. And as Dr. Bernicardi says, his job is to make sure that every patient who walks into Downstate Medical Center gets an individualized cancer care path and plan for them. Well, that'll be possible if we can actually do the work that's in front of us. It's a tremendous opportunity that our patients are enabling us to take. So again, I want to thank the speakers who I invited with Laura, who accepted this invitation. I want to thank Dr. Salufo for continuing to support us as he looks for us to land our first big paper and first truly big grant. And Dean Bernicardi, who's sort of inherited all of this, but fortunately speaks this language and understands where we're trying to go with it. This is a community question that require expertise at multiple campuses and an endless stream of trainees who will actually listen to our ideas and test them. And so again, thank you for all of you, and to the New York Genome Center you're going to hear from for basically being our sponsor right now for many of our projects. And then finally, there's one health system that hasn't been mentioned, which is a big one on Long Island and the boroughs, Northwell Health, who we've started to work with at Cold Spring Harbor, who also are interested in this topic. And so I'm hoping that they will, come to the table soon and be an equal participant. So again, thank you all for coming to this today. I turn this back to Dr. Salufo and look forward to a fun and informative day.
Wonderful. Thank you very much for those wonderful remarks. I just wanted to give a heads up to people who don't understand the terminology Cold Spring Harbor Labs. You've heard about Watson and Crick discovering the DNA. The lab is now called Cold Spring Harbor Lab. So that work is now continuing in a campus, an institute called the Cold Spring Harbor Labs. So Watson and Crick are basically alive in terms of intellectual capacity. Okay, so I want to introduce one of our newest members, the Chief of Oncology at SUNY Downstate, briefly, Dr. Cl Lim. He joined last year. He's going to be playing a major role in our cancer efforts. Dr. Lim, you want to show your face for 1 second?
How do I show my face?
All right, we heard your voice. If Edlin can make it happen, that would be nice. If not, we would move on, and then during the break, we can show you.
Yeah.
All right, no worries. During the break, we'll figure out a way to show your face. And the last, but not the least in terms of acknowledgements, we have an external advisory committee that has been advising how we move forward with this effort. The external advisory committee was made up of 2 people, 2 nationally recognized people. One of them is Dr. John Carruthers. He's the chair of medicine at University of Michigan at Ann Arbor. He is an amazing gastroenterologist. His passion is the genetics of inherited colon cancer. I'll be introducing him later on. He's been spectacular in guiding our efforts from 2015 all the way to our current program. So we really want to thank him. The other external advisory committee member is Antonia Baines from the Central University in North Carolina. He is an amazing, accomplished pharmacologist who has in-depth knowledge on pancreatic cancer. He's also been part of the program for the last 5 years, and wanted to just acknowledge his efforts and thank him for guiding us through this time. So now we have 3 sessions, right? The first session is going to focus on colon cancer. Second session is going to focus on pancreatic cancer. And the third session is going to focus on machine learning. I'm looking forward to the machine learning, AI, and cancer health disparities session. That is new in the program, so we hope to hear some new things. We would have small breaks in between, 10-minute breaks in between. But for lunch, we have 1 hour. But please, because we're on Zoom and there might be technical difficulties when it's time, just please be prompt so that we can start the session promptly. So I would like to introduce Dr. Jenna Williams from our sister campus, Stony Brook, to moderate the first session on colon cancer. Dr. Williams is a native of Georgia, but she lives in New York and has had a brilliant career in New York. She went to Savannah State University for her bachelor's and Tuskegee University for her master's, then received a PhD from Purdue University and postdoc work at Harvard. This is all brilliant. She then made a career in how NSAIDs can be used for chemo protection when they are, when they are coupled with nitric oxide. I think that was just brilliant science. Right now, she's working on microRNAs and aberrant DNA methylation techniques in cancer and other areas. But her main interest really is trying to use to tie the basic science and the clinical science in terms of health disparities. So that translational medicine side of her is so attractive, trying to see, okay, we now know what is happening with the science. How do we translate that to the bedside? So we are so happy to always have her with us. And I would like to, I'd like to introduce her to moderate the first session on colon cancer. So Jenny, it's yours.
Okay, thank you very much. Nice introduction. Hi, today I would like to introduce first our first speaker, Dr. Maria Cruz Correa. Dr. Cruz completed her BS in biology and her medical degree at the University of Puerto Rico. She completed residency in internal medicine at the University of Puerto Rico and a fellowship in gastroenterology and hepatology at the Johns Hopkins University. She completed a doctorate degree in clinical investigation and genetic epidemiology at Johns Hopkins Bloomberg School of Public Health. She's professor of medicine at the University of Puerto Rico, adjunct associate professor of medicine at Johns Hopkins in Baltimore, Maryland, and adjunct professor of surgical oncology at MD Anderson Cancer Center in Houston, Texas. Dr. Cruz is the Executive Director of the University of Puerto Rico Comprehensive Cancer Center and leads the gastrointestinal oncology research program. She's the lead investigator of the Hispanic Alliance for Clinical and Translational Research, an IGMS-funded research infrastructure and career development grant. Her multidisciplinary research program is aimed at understanding the etiology and genetics of gastrointestinal cancer. Furthermore, the program explores multiple agents to prevent, intercept, or treat cancer using early phase clinical trials. She's the Chief Medical Officer of Pan American Center for Oncology Trials, a research organization for development and conducting clinical trials in oncology. Dr. Cruz is a physician scientist with strong focus in chemoprevention, hereditary cancer, and health disparity. Dr. Cruz has been continuously funded by the NIH for over 18 years and leads several institutional networks and was the inaugural dean for research at the University of Puerto Rico Medical Sciences campus. She's actively involved in several national professional organizations, including American Association for Cancer Research, governing board member, as is past chair of the AACR Minorities in Cancer Research Council and Women in Cancer Research. She's governing board member of the PR Colorectal Cancer Coalition and past board member of the NCI National Cancer Advisory Board and the American Gastroenterology Association. She's also editor of several prestigious medical journals, including Gastroenterology and AACR Cancer Prevention Research. Dr. Cruz has over 100 peer-reviewed scientific articles and has mentored over 50 graduate students as thesis research advisor. I present to you Dr. Marie Correa.
Thank you. What an honor to be here. Thank you, Dr. Williams. Thank you, Dr. Salifu, and all the prestigious members of these organizations. It's an honor to be here with you. I'm going to be sharing our presentation. Let's do this. And today is actually a very important day for all of us. And, you know, we're dressed in blue, and interesting, I don't know if you guys planned this, if Dr. Salifu and the team planned this, but today is Colorectal Cancer Awareness Day, dressed in blue. So you'll see many ads out there and many people dressing in blue to really commemorate this important day to increase awareness of this disease, which is preventable in a significant number of patients that are diagnosed with this disease. And it's the reason why we're here today. And I have the privilege of sharing with you a few of the concepts that have already been mentioned by some of the previous speakers, including Dr. Bruni Carty and Dr. Tubesan. Why it's so important to understand the interplay between disparities and whether or not the role is genetic or environmental. And in the next few minutes, I'm hoping in the next 10 minutes or so, I want to discuss with you the three aspects that are very important to try to understand the interplay between genes and environment. So I'm going to briefly give you an epidemiology introduction. Then we're going to move to some of the data that we have on environmental factors. And then I'm going to finalize by putting some of the concepts that we have been discussing and looking at from my own laboratory, looking at molecular and somatic mutations. So let's put us into context. Of course, you guys are very much aware, and many of the patients that you take care of come from different ethnic and racial backgrounds, including Hispanics. And it is estimated by the year 2050, 1 out of every 4 citizens in the US, in North America, will be from a Hispanic background. And you can see in dark blue the areas where we're going to have more of those patients living. And to put us in context, right, colorectal cancer is a disease that affects men and women from all racial and ethnic backgrounds. However, there is a disproportional presentation of more advanced disease in several ethnic and racial groups, including African Americans and certain Hispanic groups, like those from the Caribbean, including Puerto Rico. Worldwide is the second most common the third most common cause of cancer, is the second most common cancer in US Hispanics, and is the fourth most common cause of cancer death in the world. And when you think about a disease, and we need to understand why are there differences, right? And I think Dr. Topison was briefly alluding to the fact that differences and disparities is a term that we use interchangeably. However, when we look at a disease, and I want to show you data on an incidence rate, this is data from the US, where you have the African Americans, Hispanics from Puerto Rico, all races, and some other groups, and also Hispanics from the US. And notice that there are differences, right? With a higher percentage of Black communities being affected by this disease, followed by Caribbean Hispanics, specifically Puerto Rico, and so forth and so on. So even groups of patients that are classified within a specific ethnic group might have differences across the different subpopulations. And the question is why? And I found this article very interesting, where we see that the rates of patients that are Hispanics, and I'm focusing in Hispanics during this presentation, the incidence of colorectal cancer changes when the patient, a Hispanic patient, is in their native country and when they move to the US. And this happens in a short period of time, which really make us think about whether or not, the environment is really modulating, some potential genetic or risk factors or predispositions. So looking at, this table specifically, you see the incidence in blue, in light blue, Mexico, when they were, the Mexicans in Mexico, and how it goes up when they move to the US. And the same thing for Puerto Ricans, you can see, and this is in a period of 10 years or so, the same thing for Cubans, and you can compare that with the Hispanics with the Floridians. So there must be something that it's driving this in such a small period of times. And similarly, this data comes from Marianne Stern and her group at the University of Southern California, and they look at disparities in colorectal cancer incidence among Latinos in California. California is a melting pot, and you have Hispanics that come from all over the Latin American countries. And in this particular study, they were able to identify that close to 1 out of every 5 Latinos in California presented with colorectal cancer before the age of 50. That's a huge number. And that was present for Puerto Rican Hispanics and also for Mexican Hispanics. And more troublesome for all of us is that close to 50% of all those Hispanics that presented with colorectal cancer had advanced disease upon presentation. And you can hypothesize that there could be many potential factors that influence both the incidence and also the advanced disease, including limited access to health resources. But definitely there's something going on that goes beyond the ethnic group. And we have published as well data demonstrating that US Hispanics that present with colorectal cancer before the age of 50 have a worse survival. So this is a group of patients that we need to understand what are the drivers of the disease. And now I want to move gears, right? I show you already the epidemiological data. Let's look at some of the environmental factors. And the first one I want to highlight is that we know that there are environmental and colorectal cancer environmental factors that increase the risk of carcinogenesis, including sedentary lifestyles, obesity, the diet. In fact, diet was classified as a carcinogenic class 1 by the World Health Organization in 2015 because it increased the risk of development in colorectal cancer. And later on, and we've all been alluding to this before, the microbiome has been front and center for the last 10 years or so, where we started to understand what is the role between that gut microbiome and really the risk of developing inflammation and subsequent cancer. And in fact, our group and others have looked at the differences in the type of bacteria and type of organisms that we have in our bowel. And this comes from the work from the University of Pittsburgh, where they look at different type of bacteria and, the African Americans compared to the individuals that were in native Africa. And you can see, even without doing statistics, that the type of bacteria that was present among the African Americans from Pittsburgh versus the the Africans native in Africa was extraordinarily different. And we actually started looking into what particular genes that are produced by the bacterial could be drivers for, cancer. And this list that I put here are bacteria, are toxins that are produced by bacteria that have a very important role in DNA damage, in modulating the pro-inflammation, in promoting cell growth. And we actually performed a study that was published a few years ago in 2019, where we look at the gene copy number per milligram of stool for bacterial genes, and we look at different bacterial genes. And we were able to identify that for some of the genes, like including the USP, there were more of these bacteria that was more of this gene present among patients with colorectal cancer. Still, data is preliminary, and we are undergoing additional studies to help us understand the interplay between the gut microbiome and the risk of cancer. We cannot forget that people are part of the society, and access to care is important. And in fact, some of the work that we have done is to try to understand the role of the health insurance as a surrogate marker for access to care. And this was published a few years ago, where we identified that patients that were in the public or the government Medicaid insurance had a worse outcome compared to patients that were in private insurance. In fact, here you can see on the graph the relative survival at different time points for patients that were diagnosed with colorectal cancer. And you can see that the line that belonged to those patients that were in the public health care system, had a worse survival compared to those that were in the private sector. We adjusted this for many confounders, and of course there could be more, but it again tells you that access to care is key, continues to be key. I want to finalize talking briefly about the role of molecular aberrancies. And in order for us to be able to understand what are the drivers of disease in cancer, in this case, in colorectal cancer, we need to understand the molecular biology. And this was alluded before by the previous speakers. This data comes from the Cancer Genome Atlas Network. And you can see that this was published several years ago, where we have tumors that have hypermutation and then those that are non-hypermutated. But when you look at how many of those patients that were evaluated in this large TCGA came from Black, Hispanic, and other diverse populations, you can see the numbers. Less than 5%. In fact, 3% of all those samples were from Hispanics, and only 12 were from Black. So this is a barrier that we need to break. And now there are being more groups that are starting to evaluate other diverse group, including Hispanics and African Americans. And this is key because the new frontier, right? The precision oncology of 2021 requires understanding of the specific molecular signature of patients with cancer. If we don't do the test, we cannot offer the patients the new targeted therapy that will change the survival and the outcomes of our patients. And we all have seen how targeted therapy is the way of now and the way of the future, and how patients from different backgrounds, specifically diverse backgrounds, are less likely to have their tumor tested and less likely to receive therapies that are targeted. We need to change that. And in fact, there's already approved and available medications that are great, that will help patients to benefit from targeted therapies. And I just mentioned some of them that are available for colorectal cancer in particular. So we started looking into our database, and we made an alliance with the Precision Oncology group, where we evaluated Hispanics, a total of 931 Hispanic individuals with colorectal cancer. You can see the distribution and the age distribution of this cohort. And we look and compare our Hispanics with those of non-Hispanic whites of the TCGA, right, that large database. And you can see in this graph in green and blue, this data will be presented at AACR 2021. You can see here how there were some differences. All these genes where you see the asterisks, where we saw statistically significant difference with more mutations in the APC, in the P53, in the K-Ras, as compared to non-Hispanics among using data from the TCGA. And when we focus on the actionable genes, where we have therapies that we can provide for patients with cancer, we realize, and our data supported the fact that there were important differences that will have an impact in the treatment of patients with colorectal cancer, and so forth will have an impact in the survivalship. So this data is starting to come out, ours and others. Hopefully we can share on the next meeting more of the data, but it's important that we are aware that we need to test tumors. We need to evaluate the interplay of the gut microbiome, the genome from where it comes from each patient, and then the outcomes. And I want to finalize with this study that actually tried to start going deeper and trying to understand whether or not is where we're coming from, where our genes are coming from, where is the ancestry, and whether or not that has a factor in our risk of developing colorectal cancer. And we published recently this association between genetic ancestry and colorectal cancer in Puerto Rican Latinos. And what we were able to identify was that African ancestry, which is so prevalent among Hispanics from the Caribbean, was associated with proximal colorectal cancer location and poor tumor differentiation. 3 times more likely, those patients with colorectal cancer that had African ancestry had poor tumor differentiation, and that will correlate with poor outcomes. So to summarize, it's important that we are aware of these disparities, these differences that we see in incidence and also survivalship among colorectal cancers from US Hispanic backgrounds. We need to understand the subpopulations. It's not a one-size-fits-all. Hispanics as a category, they have very different genomic ancestry, and this is key to start to incorporate, just like we incorporate gender or age. There are significant differences in the molecular signature among Hispanic patients with colorectal cancer. They have less microsatellite instability. They have more mutations in K-Ras and BRAF. Non-European ancestry, again, was associated with worse outcomes. And nutrition is a driver of gut microbiome dysbiosis. It's one of the aspects that we need to also examine, and whether or not that particular diet that changes our microbiome will then increase the risk of particular ethnic or racial groups like what we're discussing today. I want to finalize reminding everyone that the best treatment is always prevention. So it's today's Colorectal Cancer Awareness Day, and we're all dressed in blue. Thank you for the opportunity for being here with you.
Thank you very much.
Thank you.
Everyone, please hold your questions for the panel discussion. And you can type your question in the chat and we'll read it later. Our next speaker is Dr. Dina Baptiste. Dr. Baptiste is the Director of Guideline Development Process at the American Cancer Society. Dr. Baptiste joined the American Cancer Society in 2013 and currently serves as epidemiologist and the Director of Cancer Screening Guideline Development in the Department of Cancer Prevention and Early Detection. In addition to her primary role as the methodologist for the development of American Cancer Society's cancer screening guidelines, she also supports the American Cancer Society Cancer Screening and Prevention and Control Initiative. I'll give you Dr. Baptiste.
Good morning, everyone. I was on mute there for a minute. Good morning. I apologize for not being live. I am not having some technical difficulties with my video this morning. Thank you for inviting the American Cancer Society, and it's my pleasure to be a representative. I am going to give an overview this morning. So this morning I will give a brief overview of the impact of the COVID-19 pandemic on cancer screening, more specifically colorectal cancer screening. And I will also briefly review the work that the American Cancer Society is engaged in to promote cancer screening as we continue to work to address disparities in colorectal cancer screening and care. Just a quick overview and a reminder that the American Cancer Society updated recommendations for colorectal cancer screening in 2018. Currently, adults at average risk for colorectal cancer are encouraged to start screening with either of 6 available screening modalities at the age of 45. As the previous speaker mentioned, that we have been noticing an uptick in colorectal cancer screening in adults under the age of 50 for some time now, and the recommendation to initiate cancer screening at age 45 was partly from that piece of epidemiology. Important for us to make a note of and emphasize is that the guideline includes 6 screening options for patients to screen for colorectal cancer. We should ensure that patients are aware that the recommended strategies include these 6 options, because we believe that the best screening test is one that gets done. Patients should be aware that there are 3 stool-based tests that are available: FIT, GWAG, and stool DNA, and also 3 structural exams, colonoscopy being the most popular, but there's also FLEXIG and CT colonography that are available for screening. Equally important is that persons who are at a higher risk for developing colorectal cancer follow other screening guidelines. Unfortunately, due to time constraints, I will not go into details of all the different categories of high-risk individuals, but just to note that in the discussion of cancer screening with patients, that it is important for us to identify persons who are at higher risk, and those persons should start screening earlier, and screening for these persons should be done with colonoscopy. So before 2020, we were making some progress in colorectal cancer screening uptake in the United States. There was some success with the 80 by 18 campaign through the National Colorectal Cancer Roundtable that is partly supported by the American Cancer Society. And that continued with the 80% in every community campaign. And I believe during that time, we've gotten colorectal cancer screening up to about the 70% uptake range, depending on which national database you're looking at. Then last year in March 13, 2020, we all remember the COVID-19 was officially declared a pandemic, and shortly after, the CDC recommended suspension of non-urgent healthcare, in part to mitigate the spread of the virus. Shortly after, the American Cancer Society and other organizations supported this. The mitigation of non-urgent healthcare, which included cancer screening. So what effect did this halt in non-urgent healthcare and cancer screening have? In a very short period of time, the pandemic shifted healthcare demand, delivery, and preventative care utilization. One of the earliest reports on this change in the healthcare landscape due to the COVID-19 pandemic came from the IQVIA Institute for Human Data Science. And on this slide, from their early report, actually this was their first report using medical claims data up to April of 2020, which is about 6 weeks after the shelter in place began. They reported colonoscopy during this short window of time declining by about 90% compared to the previous 3-year averages. So if we're using colonoscopy as a surrogate for cancer screening, colorectal cancer screening, you can see that this is a drastic decline in cancer screening. And also, the report emphasized that this backlog will pose significant challenges to the healthcare system going forward. To support their findings, this is also another report from the Komodo Health Data Analysis. And they track patients' journey associated with over 3 million individuals in the United States, and their report on the volume of colonoscopy screening before and after shelter-in-place orders tracked weekly volumes and compare them to 2019 rates. And as you can see here, that there was a drop-off in screening in mid-March, right after the shelter-in-place began. And should a point to note here is that only visits prior to April 13, 2020 were included. So to ensure that volume changes were not attributed to backlog. So the same analysis also looked at new colon cancer diagnosis, biopsies and colon surgeries before and after the shelter-in-place order. And their report showed that about 32% fewer colorectal cancer cases were diagnosed in early April 2020 versus around the same time in 2019. To further support this point, this is a cross-sectional data analysis from Kaufman and colleagues focusing on diagnosis of cancer. And they track the weekly count starting with the full calendar week of the year through April 18th of 2020. And they found that there was about a 50% decline in colorectal cancer diagnosis during that time period. So we have no reason to believe that something drastic happened to colorectal cancer development to result in this drastic change in the numbers diagnosed, other than the reality of delayed diagnosis. And unfortunately, delays in screening will result in delays in cancer diagnosis, and delays in cancer diagnosis will likely result in cancers being diagnosed at a later stage. So what effect could this have? These are modeled estimates using the IQVIA database I mentioned earlier. And they estimated that over 18,000 delayed colorectal cancer cancers could be a result of delayed diagnosis due to the shelter-in-place orders. So the takeaway here is that the pandemic had a significant impact on preventive care that could translate to a crisis downstream. And just how big a crisis could this be? These are other model estimates looking at long-term impact of delay in colorectal cancer screening and diagnosis. And this particular publication estimates over 4,500 excess deaths from colorectal cancer over the next 10 years. That's by 2030. So that is the bad news. And this of course is just national data, just to briefly show you where we are from the short period of time that we had a lockdown and we had a total suspension in service. So in the early summer of 2020, as areas throughout the country began to reopen, I believe some areas started reopening in mid to late May, others later on in the summer. The ACS began to get calls, and individuals, partners, stakeholders, and constituents, members of the public, began to reach out to us for support. And so we quickly recognized that there was a need for us to be proactive if we were to return to the pre-pandemic levels of cancer screening. We started with the established infrastructure that we have through the National Colorectal Cancer roundtable and began to work on resources for action-oriented approaches to be adopted to continue colorectal cancer screening throughout the pandemic. This effort was completed in July and published and promoted through the roundtable. And we expanded this to develop a more comprehensive document, return to cancer, a more comprehensive document to focus on returning to screening for other cancer sites. So over the next few minutes, I will quickly do a high-level review of the topics and messaging included in this work, as time does not permit for a deep dive into the documents. But I encourage everyone who is working in the area of cancer screening and would like to promote cancer screening to please access these resources. So first, resuming cancer screening has challenges, and I say resuming, speaking in the present, because there's still areas of the country where, the pandemic is ebbing and flowing. There's still areas where there are challenges in terms of reopening for cancer screening and in patient having access to healthcare. There is an unprecedented backlog of cancer screening. Health systems had to adapt to new processes and protocols as they reopened. So capacity was affected, this including, the new cleaning and social distancing protocols that had to be put in place. So of course, where you before may be able to have 10 patients in a waiting room, you may now only be able to have 4 or 5. This pandemic is still with us, as I mentioned before, so patients may still be reluctant to enter healthcare settings. And there are also complexities as some healthcare providers shift to telehealth and others changes in the healthcare system. And some patients do not have access and resources to participate in telehealth, which of course further disparities. There's also the loss of employment and employer-sponsored health insurance faced by many. And all of these factors could exacerbate the longstanding inequities we have in healthcare and also the consequences of cancer screening going forward. So the first message the American Cancer Society is using to promote cancer screening is to remind all that despite the challenges we faced during the pandemic and will face shortly after, cancer screening remains a public health priority, and we must provide the public with safe opportunities to detect and prevent cancer. Colorectal cancer is very unique due to the availability of multiple screening options. This is a unique opportunity if there is limitations posed by the pandemic, especially in terms of access to colonoscopy or structural exam. Excuse me. We can address these inequities that the patients might face by offering stool-based testing. There is the option for us to encourage the use of these non-invasive screening modalities as appropriate, especially in patients who are not high risk. So we encourage everyone to increase the use of stool-based testing for patients as your situation permits. And this should also be extended to mail-in FIT outreach. Also equally important is to recognize that in many areas, because we open the doors doesn't mean that patients will come. So this has to be a collaborative effort with primary care, community partnership, and the GI community. We are working on extending colorectal cancer awareness year-round, and also seeking timely and innovative opportunities to serve the medically underserved. And equally important is confidentially reassuring patients of the importance of colorectal cancer screening, even though we are preoccupied, excuse me, with the pandemic at this time. So, you know, the COVID pandemic placed a spotlight on health inequities, as evident by the disparities in COVID-related deaths. And the effect of the COVID-19 on social determinants of health is being felt disproportionately by certain individuals in our community, such as those affected by insurance, a lot with loss of insurance. Then there is housing, food insecurity, and of course, many of us here are familiar with is access to care. One study estimated that at least 5 million Blacks and Hispanics may have lost their health insurance as a result of the pandemic. And also in early as April 2020, there was an estimated 42% of US adults in families who lost income and reported being unable to pay their rent, mortgage, or utilities. And of course, this results in food insecurities and going without medical care. So this disproportionate impact among the medically underserved and ethnic minorities will filter over going forward and should be recognized. We are more likely to see increases in cancer disparities, unfortunately, after the pandemic. Loss of resources and access to providers who serve the medically underserved, such as federally qualified healthcare centers and community health centers, have, you know, really been stretched. We have gotten a lot of have a lot of interaction with these systems, and they're really being stretched during this time. Also, the loss of employment and employer sponsor insurance is going to have an impact, or is having an impact. And so we will need organized approaches as we go forward to make sure that we don't further these disparities in cancer screening. So disparities in one of the message summaries that we are putting forth is to remind everyone that screening disparities are already evident. This was before the pandemic, and without deliberate focus, we are likely to increase these disparities as a result of the COVID-19 pandemic. We are encouraging everyone to accelerate the adoption of health equity principles. And these are outlined on the American Cancer Society's website. And these include identifying groups in your communities who are historically have low access to cancer screening. And you should benchmark your success for cancer screening uptake based on how well you do in these communities. And also help and work with community partners who are really affiliated with supporting these communities in decision-making going forward, and how you can promote cancer screening in your community. I want to emphasize that there's a need more than ever for us to identify and focus on the persons who are at high risk. We have to ensure and promote that colonoscopy remains safe. It is a good option for screening, and as facilities quickly reopen around the country, we are challenged to identify persons who should be classified as high risk for them to receive high priority for colonoscopy. And so though colonoscopy is widely used for cancer screening, patients with a family history and others classified at higher risk should be prioritize. And this does not mean rationing or in any ways. It's just that as we transition during this time, that we should focus on those who are at higher risk when we are making decisions about colonoscopy, especially where there are limitations in capacity. So focusing on patient education is going to be very important as we move forward. I know a lot of us are preoccupied with COVID-19 as patients now and focus on the pandemic. And, you know, preventive healthcare is not, may not be high on everyone's list. So we have to be proactive in educating patients, especially in letting patients know that colorectal cancer can be prevented with screening. Also, we can assume that because the doors are open, patients will come in. So this has to be an active approach that includes healthcare providers, as well as our insurance providers, community partners, to make sure that the public get engaged with cancer screening. Also, reassuring patients about safety. Facilities have new precautions in place to keep both patients and staff safe. But as earlier was reported earlier in the pandemic, there was some confusing messaging on whether or not it was safe to visit healthcare facilities. And unfortunately, some of this is still persisting or lingering in the community. So some of these such as checking temperatures, social distancing, wearing masks. We encourage everyone to communicate this to patients at the time that they're making appointments for visits. If you are participating in telehealth, and if you have patients who have access to telehealth, you may use that as an opportunity to discuss cancer screening and to encourage your patients, especially those who may be of high risk. Actually, telehealth is a great time for an opportunity to do some form of risk assessment to out if you do have a patient who may be at higher than average risk for colorectal cancer, and try to get them in for colonoscopy. So again, my slides are sticking and I'm not able to move forward for some reason. However, I want to emphasize that the main message that we want to get across is that cancer, our situation is different, but our cancer risk is not. A couple weeks ago, the American Cancer Society published the 2021 messaging guidebook, effectively messaging cancer screening during the COVID-19 pandemic. It includes information on both old and new barriers to cancer screening and delivers updated findings on how the pandemic has impacted cancer care. And it also shares tested messages to use and a companion brief and additional communication materials to support your organization's return to cancer screening outreach effort. I apologize, my slides are not advancing, but I think I should be on my last slide that gives information. Oh, there we go. There we go. So I encourage everyone to access these resources online for messaging to use both for clinician and for the general public in returning to cancer screening. There are letters on the page. There's also some examples for social media posts, etc., in promoting cancer screening. Also, you may visit the American Cancer Society's webpage on coronavirus and COVID. And I will stop sharing.
Okay, thank you very much. That was very, very informative and well received. Our next speaker is Ms. Diane Nathaniel. Ms. Nathaniel is a native New Yorker, born, raised, and resides in Bedford-Stuyvesant, Brooklyn. Ms. Nathaniel received her bachelor's degree in social science from the College of New Rochelle, School of New Resources, and a master's degree in school counseling from the College of New Rochelle. Ms. Nathaniel is employed by the New York Department of Education as a school counselor. She serves 865 students pre-K through 5th grade at the Purvis J. Behan Elementary School, Public School 11, located in Clinton Hills, Brooklyn. She has been with PS 11 for 13 years. Ms. Nathaniel also received an advanced certificate in family and mental health counseling from Long Island University, Brooklyn campus. She holds a certificate from the Harvard School of Mental Health in treating students K through 12. Ms. Nathaniel is the proud CEO of CDN Educational Counseling. She aspires to open a private practice that focuses on healing and restoration of all families. Excuse me? Sorry. Ms. Nathaniel also is a member of the following professional organization: American School Counselors Association, New York State School Counselors Association, and American Mental Health Counselors Association. In 2020, Ms. Nathaniel received her advanced certificate in public health from SUNY Downstate and would like to pursue a doctorate in public health in the near future. Most importantly, Ms. Nathaniel is a stage 3 colon cancer survivor. She was diagnosed on March 7, 2014. Today, she stands strong and has turned her experience with cancer into an opportunity to help spread awareness and the importance of cancer screening. After having cancer, she created and co-founded Beat Stage 3 with her best and oldest friend, Helen Colin. Beat Stage 3 is an image conscious campaign for cancer fighters and survivors. Beat Stage 3 promotes cancer awareness and the restoration of inner and outer beauty for cancer fighters and survivors. Ms. Nathaniel spends much time as an advocate and volunteer with the American Cancer Society, Cancer Action Network, the legislative arm of the American Cancer Society, and recently as an ambassador constituent team leader. This is an advocacy role near and dear to her heart as a stage 3 colon cancer survivor. Ms. Nathaniel also has become involved with the American Association for Cancer Research, having participated in the AACR Scientist Survivor Program and an AACR advocacy webinars. She has created and hosted several community events to support fighters, survivors, and caregivers who have been affected by cancer. These events were created with the purpose of inspiring, educating, empowering, and enlightening people about cancer. In addition, Ms. Nathaniel recently started an online talk show called Her Talks Today, Her standing for Health Empowerment Reimagined, that airs monthly, highlighting different health issues. I present to you, Ms. Nathaniel.
Hello, everyone. I'm sorry, Dr. Williams. I felt myself getting ready to cough and I was like, oh no, don't cough. So yes, wear blue. It's Colorectal Cancer Awareness Month. So I'm so glad to be here this morning. I want to say thank you to everyone for the invitation. Normally, this is an interactive slide where I ask the audience, what do they see in this photo? And I guess I'll have to answer because we're in webinar mode. I'll tell you some of the answers that I normally get. I promise it's not here because I'm vain. But most people see this photo and think I look healthy, I'm smiling, I'm dressed well, I have hair, I'm in a beautiful park of some sort, I look bright. But I show this because in this photo, I was actually sick with cancer and did not know it. So this photo was taken August 2013. I received my cancer diagnosis March 7th, 2014. At age 44, my son's 12th birthday. And on Sunday, we will celebrate his 19th birthday. And I say I'm 7 years old. So I'm 7 years Ned on Sunday. My treatment involved surgery to remove the cecum portion of my colon, 14 lymph nodes, my appendix, I had a port installation in my chest, followed by 8 months of chemotherapy, 12 rounds, 48 hours every 2 weeks. So all of this for a preventable disease. 90% of colon cancer cases are preventable. Again, I'm a stage 3 colon cancer thriver. I'm a wife, married for 28 years. I am a mother of 3 children, Jasmine, Jalen, and Josh, 26, 23, and 18, soon to be 19. I'm an educator. You guys heard a little bit in my bio, and I mentioned all of these things simply because I'm encouraging doctors to know their patient. I know sometimes you get the patient for the first time, so you don't have all of this information when a new patient is coming in. But once you are seeing a patient, and a lot of times you see a patient one time, I promise you, if you take a little bit more time to get to know your patient in a more personal way, I think that the treatment process of why you want them to live and when becomes a little bit different. I'm asking, or all these things, but most importantly, see us as a human being. I have been to some physicians who just see us as the next big break in science. So it makes a difference whether a patient has a follow-up visit and or see that their health behavior needs to change, might be based on whether or not they feel the doctor is even interested in knowing them. Pre-surgical testing for a labrum tear in my right shoulder is what actually indicated that I had a blood loss issue. And I shared that part of my story because who would even think that the shoulder had anything to do with what was going to come next in my life? And because I had the pre-surgical testing, they were able to find that my hemoglobin level was in single digits, between 4 and 6. And although I was not having a bloody surgery, they thought that that was definitely something they didn't want to chance because it seemed odd that it would be so low. So they postponed my surgery for like 2 weeks and had me see a hematologist where I received iron infusions for an iron deficiency. And if that didn't happen, I might not be here today. So some symptoms that I probably was feeling related to actually being sick were, and not limited, but these are my symptoms. I had chronic constipation, I had severe fatigue, I had an unintended weight gain and a weight loss. So I gained like 20 pounds and then rapidly just lost 10. I had chronic bloating and indigestion. And by the time I really found a doctor, because I had this cold that wouldn't go away, I had rectal bleeding before I could actually see the new GI physician. So I wanted to share that part specifically with communities of color. These symptoms are kind of like normal in our culture, and like most families or most cultures, your family says have some ginger ale, take a Tums, a Gas X, let's just go get some castor oil, all these holistic remedies that we used to use when I think our diets or the food that we're eating was much different, not so genetically modified. We were able to take those things and have some relief. But because I was 44 and these symptoms, for some reason, no one dug a little bit deeper. I am adopted. I didn't come in with any family history. So I would ask, I love Dr. Marcia's, Cruz's, and Dr. Baptiste's presentation about who to include. Please include people who don't know their family history, should be prioritized as well. Or we definitely should have a little bit more investigation into what would be bringing on these symptoms if you know the person isn't of age, plus they don't know their family history. And I just feel like if someone dug a little bit deeper, I might have had a different outcome a lot sooner, in that I was investigating some of these symptoms when I was 34. So if we know that a polyp takes 10 years, 7 to 10 years to develop, I certainly was probably sick longer than, obviously longer than when it was discovered. And as a Black woman walking in multiple times complaining about those issues, mind you, the labrum tear is what actually had them discover this, but I actually complained about those specific GI symptoms that nobody addressed. I was sent away with omeprazole. I was sent away with antacid medication and told that, maybe I'm just too stressed out based on the job that I have. never had blood work follow-up that indicated something else until finally one doctor did listen. So I felt unheard, I felt dismissed, I felt not taken seriously, and like no one was listening. And at that time, I didn't know about cultural, environmental, social determinants. I learned all of this, you know, as I became an advocate after becoming sick. So I think it's important that as we do continue to look forward to closing disparities and gaps within the community as we build health literacy through education, it is definitely going to be important to do that before people are sick. It was late at that point, but I mean, I could use my testimony and story now to help other people. So being proactive and preventative is why I'm an advocate. But I can certainly tell you that this continues to go on today as I'm dealing with the cough that I have right now. So I still feel unheard. I still feel dismissed and not taken seriously. And because COVID is the thing right now that everyone is focused on, because it obviously is a global pandemic and colon cancer is not, or other issues that have been disproportionately affecting folks of color have been, they're not in the limelight anymore. And I would just encourage everyone that, as has been stated, that we continue to make sure we're doing preventative care, because COVID is going to further widen the gap for disparity or for sickness to occur. I deal with community members every day as I'm a counselor for a lot of people. And we've had to have forums with doctors to come on and speak with our school community to encourage families to still take their children to the dentist. So there is still this level of fear around COVID and how it's transmitted. And we're still working to build all of that health literacy, but people want to feel comfortable. They want to feel heard when they go, and they don't want to feel dismissed, because it all will be a deterrent for them to actually go in and get the help that they need. So cultural, environmental, and social determinants must be considered and practiced if you truly want to reach a patient. It is essential in a patient's decision to follow up with the health issue. The birth of B stage 3 came about because I was looking for support groups. And I promise you that every support group that I joined, I won't mention any of those names right now, were very sad, very depressing, very anger filled. And that isn't what I was looking for. Was looking for a way to converse with someone who might have the ability to share some, what are we going to do when we get through this? You know, what dreams do you have? What aspirations do you have? You know, how do you share this information with your friends? And you know, what can I do to make sure that now my friends can go and get screened and don't feel so ashamed of it, and talk to men about it? You know, men are not going, right? And through that, the birth of B stage 3 came about. My friend and I created this specific organization to have these community talks in an innovative way to reach the community. I think we have to meet the community where they are. And first, you have to know your community. So your target population, I feel like, again, marginalized communities or people of color, the policies that have been created for us really don't even include us from the beginning. And so when we're asked to participate in the process, it's usually when it's, you know, affecting everyone else. But as it relates to just us, sometimes we feel overlooked and we don't feel heard again. So we wanted to figure out a creative way to bring our community in and mix it up a little bit, bring in our medical community of doctors and bridge that gap and let them know that everybody is here to work together, to partner, to increase positive health outcomes, and to make folks feel comfortable about taking responsibility for their health. So we've hosted a few different unconventional ways to do that, and they have really been well attended, both by doctors and the medical professionals and the community. And so you can see what our purpose was for, and I'm hoping that we're making a difference. So my side effects are long-term neuropathy in my feet, mouth sores, anything too hot, too cold, leg and foot cramps still, and I'm infertile. Not that I was having any more children after these 3. I'm just saying, bottom line is it was preventable. You know, so what if I did want to have more children? So I have become infertile because of my chemotherapy treatment. And the good thing, my diet has changed. You know, I'm not eating meat. I'm really practicing more of, I'll do fish, but a more plant-based diet. No more dairy. I mean, prior to becoming sick, I tell everyone I love Nathan's hot dogs. I loved a good Sprite. I loved sleeves of Oreo cookies and Entenmann's pound cake. So all make for a horrible diet. However, my diet has changed, and right now I'm currently enrolled in the 21-day plant-powered jumpstart for Brooklyn's Black community leaders at SUNY Downstate. So if you don't know about that program, it is absolutely amazing, amazing, amazing. They've partnered up with Forks Over Knives, Farm to People, Fresh Direct, and our cohort, the first cohort, is having an amazing time. And I'm also sharing that information with my friends and community. So we'll be looking to do some sort of group work where we can turnkey the information so more people can be involved in changing their diet. The diet has everything to do with how the colon works or how it doesn't work, and digestive issues and gastric issues. And all of us as we get older are having all these problems. So it's a wonderful way for me to also get some information out. And cancer gave me the inspiration to create Be Stage 3 in the first place, but we also wanted to focus on the inner and outer beauty and motivate cancer fighters and survivors to share their stories and take back their lives. I certainly advocate for quality healthcare. I feel like that is one of the biggest problems I have. I have professional friends who don't have good quality healthcare. I won't name the healthcare system that they chose or organization that they chose, but I will say that we're teaching people how to advocate for themselves and how to change when your doctor's not giving you what you need, when they aren't treating you with respect, and vice versa. Right? You go into a place and you feel like, you know, I'm not going to be my best self here. Then it's time to part ways and learn how to research, you know, for a better doctor, or, you know, how do you look at different healthcare programs that will best fit you and your family? All those things are going to be extremely important. And so these are some of the upcoming events we have. Yes, it says booty call. No, it's unconventional, but that's what it is. And it is going to be a day where we have some screening initiatives around colon cancer and prostate cancer. Will include men. Cognac and Conversations is our men's conversation that we have, where it's just men. And the cognac I'm not promoting, but it's an attention grabber. And churches as partners, where we're partnering up with churches to make sure that we get those people involved to host some screening days for us. And then the Smoke Freeze, where we're not just dedicated to colon cancer awareness, but all cancer awareness. And so we'll be doing some things with some young people regarding vaping and smoking. And lastly, this is new, I Love Yourself baskets, where we're going to be giving out really nice baskets to folks going through chemotherapy and radiation. So it's like a gift basket of love for them. And if I could just add these last few notes, just please talk with the community, ask them what they need and lack, know the community you serve and meet them where they are, build health literacy through education, refrain from shaming people for being sick, improve healthcare messaging, and work with community partners to build health equity. So thank you.
Thank you very much. That was very nice. Now I open the floor for questions. We only have a short period of time, so if you can throw out the questions really quickly. We have one actually that is for Ms. Nathaniel. Someone wrote in that you have spotlight what so many patients express: unheard, dismissed, not taken seriously. No one is listening. What else can be done to increase the sensitivity of those in cancer care, and how do we hold them accountable?
Oh, I say you have to call it out when it happens. Right. So we often we sit and we don't say anything. We kind of take it. And it's how we are raised to respect doctors. That medical field is the most revered field in the world. Right. So if I go into my doctor's office and I'm ready for you to save my life, I'm going to listen to what you say. I'm going to wait the 2 hours to see you for 15 minutes and still walk away sometimes not feeling like I got what I came for. So you call it out. And I have done that. And if you still don't get your result, I would just tell you to research another doctor. I find that people Google typical phones. We go research the best phone, the newest model, everything, Jordan or shoe that's coming out, the latest bag, but we won't do that for our doctors. So I think that that's what you need to do. Call it out and move and figure out if you need to move on.
Okay, great. Is there any other questions that someone wants to throw out?
I have a quick question for Dr. Cruz. And that is I was wondering, the participation rate for Latino in some of the studies that you mentioned is quite low. And of course, it's the same thing for Africa, but it's much lower in Latino populations. What is the explanation for that?
Thank you, Dr. Sharifa. That's really a puzzle, but the way that the TCGA was set up included large centers that were disproportionately focused in non-Latino communities. So just by selection of the sites that were part of this, it created this imbalance. And I think sometimes this is really a subconscious problem, right? Some people talk about bias. I don't think that it was that Latinos were not asked to participate. In fact, the biggest barrier for participating in clinical trials and clinical studies and research for communities, diverse community, is that they're never asked. And then they're not asked because the community physician, where those communities are being seen, are not part of the networks. That's why I think it's so key that, you know, the science needs to go hand in hand with the community. You know, and listening today to Diane, this is the reason why we do science. Science has no meaning if we're not able to translate, right, the knowledge to provide better care, to, you know, have access to therapies and to really move the needle forward. Otherwise, we just are bench researchers. And, you know, with all due respect, that doesn't save lives. So we need to work with the community.
Okay, Dr. Cruz, there was a question, a real quick question. How would you tackle discussions about unpacking race and ethnicity in the healthcare professionals and trainees you work with, especially in such a blended society in Puerto Rico?
Oh, thank you. I think the first thing is being aware, right, of cultural differences and the fact that, you know, if we don't talk about, you know, the differences and we don't talk about the respective needs and cultural needs from our different patients, then we just don't see the big elephant in the room, right? And we become oblivious. You know, sometimes there's a theory of the whole unconscious bias, right? That you don't even know because it's you know, you were raised, you know, we're a product of our society, right? So, you know, who are to blame? Well, the whole society. So then we need to be conscious about it. And the way we do it is that we incorporate, you know, from the beginning, you know, the differences so that we understand the cultural differences and even, you know, socioeconomical, you know, differences. Some people say, oh, they didn't study or they didn't do X, Y, or Z. Guess what? He or she didn't have that opportunity. That for us is like so easy. So then they don't undergo screening, right, to focus in this, or they don't participate in a clinical trial because they were never exposed to that. So, I mean, it's just, you know, you have to realize that there are differences and be open about it and, you know, educate people. Education is key for all of us.
Okay. Dr. Baptiste, just real quickly, we have made strides in increasing screening among the underserved populations prior to COVID, minor but somewhat. What effects on race and ethnicity groups are we seeing after COVID? How bad have we suffered because of COVID?
Hello, we unfortunately it's still early, and we usually have these data, usually there's a delay. So we don't have race and ethnicity data broken down by race and ethnicity yet. We are hoping that usually there's about a 2-year delay in cancer screening data nationally coming out. So we're hoping that in another year or so, as time goes on, we will get that data. But unfortunately, we are just now extrapolating based on what we're seeing in terms of resource allocations and what that usually means for the medically underserved community and minorities. So we are hoping that when the results do come out, they're not as bad as we think they might be. But unfortunately, we don't have data that's race specific at this time. Though there may be some on the local level, I just have access to national data at this time.
Okay. I'd like to thank all of our speakers. You did a great job, very informative and very insightful. Thank you very much.
Thank you for the opportunity.
Thank you.
Thank you very much. That
Thank
was
you.
a great session. We're going to take a short break. We ran a little over, so let's all be back around 10:15 to begin our next session on pancreatic cancer.
David Tivison, Professor and Director of the Cold Spring Harbor Labs Cancer Center. I've already introduced him, and I think I don't want to take any more time because he's quite known in the field. So Dr. Tivison would be moderating the session. Please take it from here and run.
Okay, thank you so much, Dr. Salifo. Welcome back, everybody. So the second part of the symposia, as you heard, is around the disease pancreatic cancer, which is a very serious gastrointestinal disease, and it disproportionately affects people of color, particularly African Americans, as well as Hispanics, either in increased incidence or worse outcomes. And therefore, we seek to understand that. To understand it, we must roll up our sleeves and look deep into the molecular biology of the cancer, but also think about the patients who are getting this cancer. Is it possible that there are conditions that they have that make cancer more common or responses to our medicines less frequent? So I'm very pleased that we have two speakers that will speak specifically to this topic today. I know them both very well because I got to meet them right when I was entering the field some 20, 25 years ago. They will both give short talks, and so come up with your questions. You won't be able to ask those questions though until we do the roundtable. So formulate your questions, send them in the chat, and then we will be certain to address them. The first speaker that I'm pleased to introduce is Howard Crawford, who's an old friend of mine, who currently directs the Henry Ford Pancreatic Cancer Center, which you may know is outside of Detroit in the state of Michigan. Howard trained in the state of New York at Cornell and then went to UT Southwestern for his dissertation work, followed by a postdoc with Lynn Matrisian at Vanderbilt University, which is how I got to meet him. Because when we made the very first mouse model, we were looking for all the various targets which are expressed in pancreas cancer, including MMP7, and Howard himself to help generate these animals. And so if I remember correctly, he actually is a co-author on that very first paper. And so we got to talking way back then, and then Howard became independent quite quickly, landing his first faculty post at Stony Brook University, where he continued to study pancreatic inflammation and its role in promoting pancreas cancer, so meaning pancreatitis going into early pre-invasive cancer. He made some real seminal findings about the molecular and cell biology of that transition and continues to actually study that theme today. In addition to these etiology questions, he himself was actually very interested in understanding new therapeutic avenues for pancreas cancer patients and is invested also in determining new diagnostics. He had a very influential paper about studying a role of a different protease, ADAM17, in promoting mitogen signaling through the EGF receptor while he was at Stony Brook, which is very well known in the field today, and I suggest you read it if you haven't yet already. And so Howard, as he's transitioned academically through Stony Brook and then Mayo, Florida, and then running the pancreas disease program at Michigan, and now landing this new inaugural director position at Henry Ford, has always had a very influential role in the field. And so I was very pleased that he's gravitated to this topic, to understanding why is it that African Americans have more pancreas cancer, and potentially why is it harder to treat them. And so he's initiating a new project in this space. He doesn't have lots of publications about this yet because it just started, but I'm really pleased that he's here to serve as a role model for how one would conduct these studies and for us to learn from him today. So I've eaten into 4 of his 20 minutes, which he's going to penalize me for. So I'll give him back 2 minutes. So we'll start the moderation session 2 minutes late, at least at this point. Howard, take it away.
Okay, thank you, Dave. Let me share my screen. Hopefully everyone sees that. Yeah, very kind introduction, Dave. Yeah, it's a great field to be in, everybody. I mean, we're all good friends, and I'm glad to see also Brian coming up right after me, who I haven't seen in a while because we've all been locked down. I'll point out that I wouldn't change my gray jacket for a blue jacket to be in solidarity with my colon cancer colleagues for today, at least. And I think we'll just go ahead and get started. So make sure I can advance. I have no disclosures here. So yeah, to introduce pancreatic cancer, it's currently the 3rd most common cause of cancer death. You can see that the longest far and above the worst killer, colorectal, as we've heard about this morning, is number 2. But around 2016, pancreatic cancer surpassed breast cancer, shown here in the pink line, to become the 3rd most common killer. And it was projected around 2020 that it would become even the 2nd most common killer. What threw off those stats was what we heard about a little bit today, is when younger people were starting to get a large number of diagnoses for colon cancer. So that crossing of the line has been somewhat delayed. Let's see if I can put on my laser pointer. I've got too many screens up, so it's hard to see. I'll forget it. You'll also have to follow my arrow. Okay. So again, the stat that we often talk about is the 5-year survival rate for pancreatic cancer. It very recently, about a year ago, crossed the 2-digit boundary to 10%. So this is one of the worst possible cancers. It's not the most common cancer, so a lot of times it's not funded as well as some of the other cancers because it doesn't affect nearly as many people, but virtually everybody who gets it dies, not just within the first 5 years, but generally within the first 9 or so months. So it is quite a terrible disease. The highest risk factor for pancreatic cancer is age by far. You can see this striation here from SEER that shows that most pancreatic cancer patients are above 65, and you can see that incidence is rising. But there are younger cohorts that are getting it. Most of those are stable, but I have seen plenty of pancreatic cancer, more than I care to talk about, pancreatic cancer patients who are under 40. So it does hit all ages. And of course, what we're here to talk about today is, as Dave mentioned, it's the incidence within the African-American community is about 20% higher than it is in the white community, in the Caucasian community. Even though incidence is rising in the white community and slightly getting lower in the Black community, it's clearly, there's a huge, I mean, it's very significant difference between these populations. So when I took the job at Henry Ford, this was back in December. So as Dave mentioned, I don't have a lot of data, but hopefully I can give you a compelling talk nonetheless. But it was pretty obvious, even before Dave got on the phone, when he heard I was taking this position, that health disparities had to be something we looked at. And the main reason that is that unlike most of the hospitals and institutes that do a lot of pancreatic cancer surgeries and diagnose a lot of pancreatic cancer patients, you can see that a large proportion of the patients, maybe not surprisingly in Detroit, actually are African American, and that gives us a very rich cohort of patients to study both historically and prospectively as we move forward. So how do we plan to study these differences? Well, one is going to be genetics. I think both Dr. Bruncardi and Dave have made a point of it, that obviously cancer is generally a genetic disease. Something that has recently come on the scene, molecular subtyping, which I'll talk about in a little bit. Also, to use the phrase of the moment, multi-omic analysis, that is to say, using single cell sequencing and various other techniques to immune phenotype these cancers, because the immune system, as Dave mentioned, is highly involved in promoting pancreatic cancer as well as other cancers. And then what I'm most expert in is disease modeling. So I'm not throwing out the baby with the bathwater here. I'm going to try to do all of these while I'm here at Henry Ford, and hopefully with merging and melding and marrying the data together to get the most full story we can about why this disease is affecting African Americans more commonly. So just a word about genetics. This is a word cloud that Andrew Biancan put together several years ago. This is showing the larger the word, the more common the mutation is that's found in pancreatic cancer. You can see the biggest word here is K-Ras. This is a gene that is an oncogene that is mutated in essentially 95% or more of pancreatic cancer patients, and followed by mutations in tumor suppressor genes such as TP53, CDKN2A, and SMAD4. These are the top 4. There's a lot of other genes that can be mutated. About 15% of pancreatic cancer patients have a familial risk for pancreatic cancer, and those mutations generally arise in the DNA damage repair pathways. So the same mutations that would, say, BRCA1, BRCA2, that would put a patient at higher risk for breast cancer, ovarian cancer, also puts them at higher risk for pancreatic cancer. So besides the top 4, there are other genetic risks for pancreatic cancer. And one of the things that we'll be doing with our historical cohort of patients is simply doing the sequencing of the whole genome for these patients to see if there's some sort of genetic predisposition that has been lost by only, I wouldn't say only, but primarily studying Caucasians, this disease. And of course, any kind of insight we find that's novel there, I guarantee you will have an impact on the entire population of pancreatic cancer patients, not just the higher risk African Americans. I went and did a PubMed search when I first started this, trying to do the best I could to see how many papers are out there looking at the genetic risk for African Americans and for pancreatic cancer. And there was about 5 papers on top that showed up. This was one of them. That, remember the CDKN2A, some of you might know this as P16, that African Americans have a high propensity for a particular rare germline mutation. And that was about it. It was funny, about the 5th or 6th paper, it starts talking about prostate cancer, as if pancreatic cancer, because it starts with a P, it must mean prostate cancer in some people's minds. So there really isn't a lot of literature out there on this. And so it really needs to be studied more carefully. I mentioned molecular subtyping. This is data that's come from or studies that have come from essentially 3 to 4 large groups of researchers. This is from a review paper that looks at all of their different molecular subtypes. What the 2 molecular subtypes that in general have been falling out of this, I think we now call, generally by the Moffitt criteria, classical and basal. The basal type, relatively undifferentiated tumor type, has a worse survival rate. And whether you call it basal, or whether you call it squamous, or whether you call it quasi-mesenchymal, that's what all of these different subtypes are mentioning, is that type is more deadly. And we, again, don't know whether there's any propensity for African American patients to favor any particular molecular subtype. So that's something we're also going to look at. The way we're going to be able to look at that in relatively high throughput is using multiplex immunofluorescence. This is some data that I borrowed from my colleagues at Dana-Farber, where they've designed a panel of panel of markers and having appropriate antibodies where they can just do multiplex staining. And you can see primarily by looking at, for instance, this red TFF1 is marking the classical tumor. It's not really there in the more aggressive basal tumor, which is more prominent for keratin 17, S100A2. And then they're also finding several tumors that have a mixed phenotype here. So that's something that they're exploring very heavily, and it's something we're very interested in seeing what our patient population shows here, whether they favor to have not just a higher incidence, but as Dave mentioned, a more aggressive cancer. So don't have data yet, but we're doing this next week. Our machine gets installed and we can start doing this. And in a study that my colleagues at University of Michigan and I co-led, what we did was a multi-omic analysis of 16 pancreatic cancer patients at the University of Michigan in Ann Arbor. So you can imagine probably not a big stretch to imagine that those are mostly Caucasian patients. Actually, they're all Caucasian patients. And so what we want to do is expand that database that we developed for those patients, where we looked at the gene expression, therefore the quality of cells within the tumor microenvironment, primarily immune cells, and found really interesting data that suggested that pancreatic cancer patients, for instance, were never going to respond to the typical immune therapies that have been applied to them, but potentially there are other targets in that space that they will respond to. But anyway, the point of this is not to go back over that paper, but to apply high-level mass cytometry, where we can look at a bunch of different immune populations, both in the tumor, in the metastasis, and in the blood, which has been very informative, I must say, as well as single cell sequencing to and overlay these data again with multiplex immunofluorescence to really understand the immune and stromal and landscape and how that's communicating with the cancer. So we're very excited to expand on that database, including now several African-American patients. So one of the things that we found, I'm going to do a little science now, so forgive me, that one of the genes that we found when we did that study was a gene that many of you might know is associated with Alzheimer's called ApoE. This is apolipoprotein E. This is a carrier of lipids and cholesterol throughout the body, and particularly in the bloodstream. But what we found is by looking at the cells within the pancreatic cancer, that this was highly overrepresented compared to the adjacent normal tissue that we found in other patients, or some of the same patients. And then some of these patients were also had intestinal cancer that didn't have any pancreatic disease. But so you can see this highly elevated. What we found was that that most of the expression didn't come from the tumor cells, but from the stromal cells surrounding them. And by virtue of knowing that it's in the reactive cells, we then looked at the blood in pancreatic cancer patients and healthy patients. In this case, the healthy patients were usually the healthy caregivers, so we could control a little bit for environment. And then comparing again, what we saw that the pancreatic cancer patients, even in the blood, so therefore in a systemic change that's happening in these patients, that ApoE is again overrepresented compared to the controls. And then by measuring the protein in the blood by ELISA, and then looking at the data from several patients, these are hundreds of patients in this case, what we found was that ApoE, when it's high, definitely correlates to poor survival. So that brings me to disease modeling. This is going to be very basic. So we could very easily acquire the ApoE knockout animals. They've been around forever simply because they are involved in cholesterol metabolism, and now we know with Alzheimer's. So we just bought those animals, and what we did is we put syngeneic tumor cells implanted into the pancreas of these animals, and then just let the tumors grow for over a period of time. And what we found is that when you knock out the ApoE gene, that the tumors that form at the endpoint are much smaller, significantly smaller. Correlating to that, we saw that that the immune response was quite different. Particularly pay attention here to the cytotoxic T cells that would be responsible normally for controlling the tumor. And you can see that cytotoxic T cells, the CD8 T cells, are higher in these tumors. And this is visualized here by immunofluorescence. And you can see the wild type animals with tumors implanted have much fewer CD8 positive T cells than the ApoE knockouts. When we would just do in vitro experiments, taking the tumor cells and treating them with recombinant ApoE, we could see a lot of gene changes, very black and white here, no pun intended, but between vehicle and ApoE treated cells, and you see a lot of gene changes, but particularly we were interested in a couple that would associate with this lack of T cell response. This is CXCL1 and CXCL5. And we didn't see a big dichotomy with CXCL5 by itself, but even with CXCL1 by itself, this also correlate the levels that we found by mining the ICGC database correlated to poor survival. And then doing experiments where we would take macrophages, macrophages being one of the primary sources of the ApoE, along with fibroblasts. Sorry, I didn't want to put too much data in here, but the macrophages are a primary source of ApoE. We take wild type macrophages and we take the conditioned media from these wild-type macrophages and treat tumor cells with them, or from ApoE knockout macrophages. And what we could see was that by looking at CXCL1, this also applies to CXCL5, that wild-type conditioned media would induce CXCL1, ApoE knockout macrophages would not, and we could rescue that effect by adding recombinant ApoE. And you can see just by fluorescence that the CXCL1 expression is on in the wild type and really not present in the knockout, shown here by the green stain. And the reason I'm talking about this in this particular forum is because of these data. So ApoE interacts with a bunch of different receptors, including the LDL receptor. And we were surprised to find that if we could do it, we could only achieve a partial knockdown of this receptor in culture. What we would find is that LDL receptor signaling was really important for, so a partial knockdown lead to a partial loss of induction of the CXCL1 and CXCL5. So it seemed to be signaling through there. We attributed this because ApoE would induce the translocation of NF-kappa B, P65, to the nucleus in a manner that was dependent on the LDL receptor signaling. So this is the induction quantitated here, and then when we knock down LDL receptor, it's less. And just to finish off this story, if we treat cells with recombinant ApoE and use an inhibitor of the NF-kappa B pathway, that would indeed block the induction of, or partially block the induction of CXCL1 and CXCL5. So how's it relevant? Well, just give you the idea here. Macrophages make ApoE, signal to the tumor cells through the LDL receptor to activate NF-kappa B, activate CXCL1, CXCL5 signaling, which brings in what are called myeloid-derived suppressor cells, which are responsible for blocking infiltration of T cells into the tumor, going back to the original data that I showed you. So why is that relevant? So there, in humans, in mouse, there is only one ApoE, but in humans, there are 3 different flavors of ApoE, 2, 3, and 4. ApoE4 is the one that most avidly binds the LDL receptor, and it's also the most associated with Alzheimer's disease. So it's associated with changes in inflammatory response. Turns out that ApoE4 is overrepresented in the African-American community by about 1.5-fold. So it is one possibility of one of the reasons that the African-American patient population may have worse outcome is that they have a tendency to have ApoE4. So of course, now we're going back to the human data that we already have and the future human data that we will get, and just look in the genetic profile and in the blood to see if ApoE4 versus these other variants are represented in patients with worse outcome. And so we can do that by protein levels, and we can do it also by sequencing, as I mentioned. So with that, I'm just going to close. Hopefully I kept relatively on time. Just because I moved doesn't mean I can't acknowledge my colleagues at University of Michigan, particularly Marina Pascalomagliano, who was one of the primary leads on the multi-omic analysis, as well as the people that did a lot of the work. Eileen Carpenter, who's a GI doc at the University of Michigan, and Nina Steele, who I'm trying to hire at Henry Ford, and Sam Kemp, a student that Marina and I co-mentored and who did all of the ApoE work, as well as a lot of the single cell omic stuff. This is what we look like now. We're smaller. We look a lot more serious, but you can't tell we're smiling under these masks. But hopefully very soon we'll be able to have a real picture with all of our beautiful faces. And with that, I will be unsharing my slides.
Okay, Howard, thank you very much. And so what I would like everybody to do is write down your questions you have for Dr. Crawford, and then submit them through the chat so that they can be addressed in the roundtable. So thanks so much, Howard. It was really exciting to see. Now we're going to turn to our second speaker in the pancreas cancer part of our program. It's Brian Lewis. Brian is a professor, vice dean, vice provost at the University of Massachusetts. He was one of the first scientists that I met in the pancreas cancer field, and he's truly a peer of mine. We were both postdocs at the same time. The first meeting I went to where pancreas cancer was talked about was a small, almost group meeting that Harold Barmas had at the NIH. And I came down to talk about the approaches we were trying to generate in Boston in Tyler Jack's lab. And Brian was there as part of Harold's lab. And so we got to know each other then, and I've followed his work ever since. As a background, Brian was a college student at UCLA, set for his PhD at Hopkins, and then of course did his postdoc with Harold. With Harold, the approach to mouse models that was generated in the Varmus lab was to use an avian virus that infected only cells that express the avian receptor, and thereby come up with and would integrate. It was a retrovirus, and so you could develop these animal models without the risk of lentivirus infecting human cells and all of the rest. Is extremely clever approach that was generated by the Varmus lab, and essentially Brian developed it for pancreas cancer modeling, and had a paper about this using a variety of oncogenes to generate pancreas cancer models. Once he started his independent career, Brian has sort of perturbed multiple pathways that are likely important in pancreas cancer. The hedgehog pathway, he has some influential papers about dissecting how the hedgehog pathway stimulates actually in cancer cells, various pathways, as well as microenvironment cells. And then more recently, effectors of RAS signaling, such as the TOR pathway, with particular interest in TOR2, prior to any knowledge that TOR2 was actually proximally biochemically to quercetin RAS. So he actually had identified this before the biochemists got into it and showed that this was actually likely a proximal physical effector of RAS, which is very nice. And he's taking that data into developing better molecules to hurt pancreas cancer cells in a dish in a mouse, so that it can be translated into the clinic. And so he always thinks differently, which is what I like and admire about him. Very similar to Howard. They just think about the same problem very differently than I do, or people in my own laboratory. Brian also is committed to education. And so he's in charge of a training fellowship at UMass. And he's interested in training the next generation of graduate students and postdocs, but he actually even pays attention to the folks when they're still in secondary school. And I think this is a very important theme, for this conference, because I do believe this topic will be embraced most when the community is involved at all stages of education. And so again, I'm very pleased that he accepted our invitation to be part of this symposia today, kind of like Howard, because I talked about Brian. He has less time to talk a lot about his science, but I'll give him time back. So this power sharing type of thing. And so you have your 18 minutes, just like Brian. So thank you again for joining us. I look forward to your talk.
Great. Thank you very much, Dave, for that introduction. And thank you very much to you and to the other organizers of this conference for the opportunity to present at this meeting. I am going to attempt to share my screen. I always have to do something a little bit different here, but I think I'm now on point. So what I'm going to talk about today, as Dave mentioned, is talking a bit about our current efforts to think about how we could target Emptor signaling for effective therapeutics in pancreatic cancer. I should start by saying that I have no disclosures. So these are 4 individuals who we've lost to pancreatic cancer over the last few years. And this is a diverse group of individuals. But as you heard from Howard Crawford in the previous talk, this disease does not infect individuals from different backgrounds equally. So we have differences in incidence and differences in outcomes. They're very dependent on race, at least in the United States. And I think you heard very nicely from Howard some of the reasons for that disparity. But I also like to put forward that one potential contributor to this disparity is the absence of effective therapeutic approaches that can be applied in any clinical setting and irrespective of an individual's insurance coverage and ability to pay. So again, as you heard from Howard, pancreatic cancer remains a very intractable disease. And one of the critical reasons for that has to do with the late stage at which most patients are diagnosed. And so approximately half of pancreatic cancer patients are diagnosed when they have disease that has spread outside the pancreas and is in distant sites. And those patients have a very poor prognosis. Only about 3% of those patients will be alive 5 years after their diagnosis. But importantly, even those patients who are diagnosed with localized disease and who in this country predominantly get surgical removal of their tumor accompanied by chemotherapy, either in a neoadjuvant setting or an adjuvant setting, depending on institution, only about 40% of those patients survive for 5 years. And so this really highlights the ineffectiveness of our current chemotherapy regimens and really highlights the need for new therapeutic approaches that can be far more effective and therefore extend survival for patients diagnosed with pancreatic cancer. And so this slide sort of shows our current standard of care chemotherapy regimens. And you can see that for one of our current standard of care regimens, a combination of gemcitabine and a conjugated paclitaxel, that this results in a median survival of approximately 9 or 10 months post-diagnosis. And our second regimen, a 4-drug cocktail called FOLFIRINOX, likewise extends survival more significantly than our previous standard of care gemcitabine. But this extension, a median extension, is only about 11 or 12 months. And so this really, again, highlights the need for new therapeutics and new therapeutic approaches. And in particular, many of us are thinking about targeted therapies that go after specific alterations that are present within the pancreatic tumor. And you very nicely heard from Howard that we think we have a target, and it's this activated oncogene called K-Ras. And activating K-Ras mutations are present in about 95% of pancreatic cancers. And they additionally occur early within disease progression, suggesting that this indeed may be a very valuable therapeutic target. And very nice work from Dave and together with Sunil Hingorani demonstrated that if you drive expression of an activated form of K-Ras, in this case, a K-Ras allele with a glycine to aspartic acid change at amino acid 12, if you drive expression of this activated allele specifically within the pancreas, all of these mice develop precursor Panin lesions that over time progress to form invasive adenocarcinoma. And when these carcinomas form, they metastasize very frequently, most commonly to sites that the human disease spreads to, in this case shown in this particular image, to the liver. And so this is a really nice model and really, I think, reinforces the fact that K-Ras is an initiating and driving oncogenic lesion in this disease. So how does K-Ras act as an oncogene? So K-Ras is a GTPase. It's a small GTP hydrolyzing protein that is typically found in an inactive GDP-bound state. It can have a GTP exchange for GTP in a process that's facilitated by a group of proteins called GEFs. And then when RAS is bound in GTP-bound state, it undergoes a conformational change that allows it to bind its downstream effectors and then stimulate signaling downstream in those signaling pathways. Because it is a GTPase, it then hydrolyzes that GTP to GDP and then cycles back to an inactive state. And this is again greatly facilitated by a family of proteins called RAS gaps. And so the activating mutations that occur in cancer either impair the intrinsic GTPase activity of RAS proteins or interfere with its interaction with these RAS gaps, therefore resulting in RAS remaining GTP bound state for a longer period of time, leading to enhanced stimulation of downstream signaling. So together, this all says, right, that K-Ras is a great therapeutic target for pancreatic cancer. But unfortunately, at least at this time, we are not able to generate effective therapies, effective drugs that directly bind and inhibit activated forms of K-Ras. And so my lab and several other labs have then turned to the analysis of downstream signaling. And we've built a lot of our work on the basis of a very simple hypothesis. And the hypothesis is that, factors that are required for K-Ras to initiate this process then are potential therapeutic targets later on in the disease. And so what I want to do for the rest of the talk today is then just to talk about some of our data related to one of these targets that Dave alluded to in his introduction, and that is a serine threonine kinase called Emptor. So Emptor, as mentioned, is a serine threonine kinase. It exists in two distinct signaling complexes, Emptor complex 1, shown here top, and Emptor complex 2. There's several common subunits of these complexes, but just want to highlight two of the unique subunits that are specific to one complex or the other. And so for Emptor complex 1, there is a scaffolding adaptive protein called Raptor that's specifically found in Emptor complex 1. And in Emptor complex 2, that analogous factor is a protein called Richter. And so downstream of Emptor complexes, we get lots of critical signaling functions. We have impacts on cellular metabolism, whether that be translation of mRNA to protein, protein turnover, autophagy, and other metabolic functions downstream of Emptor complex 1. And additionally, downstream of Emptor complex 2, while less well understood than Emptor complex 1, we see regulation of cell survival and cell migration, features that are really important in pancreatic tumorigenesis. So of interest to us then was really to answer the question, if we could identify specific contributions of each of these signaling complexes, each of these Emptor complexes to pancreatic tumorigenesis. And so to do this, we specifically ablated this Emptor complex 2 subunit, specific subunit Richter, and asked, what are the consequences of genetically inactivating Emptor complex 2 on the ability of K-Ras to initiate and drive pancreatic tumorigenesis in vivo. And so the strategy that we took then was, again, to adapt that mouse model that Dave developed to drive expression in a Cre-dependent manner, this activated K-Ras allele within the pancreas, but then also to marry to that, then simultaneously, the deletion of critical exon 3 in Richter, leading to a premature termination codon and the absence of functional Richter protein. And so by doing that, then we can specifically inactivate Emptor complex 2 within the pancreas, but not elsewhere within the mouse, and retain function of Emptor complex 1. And so if we do that, we find that the absence of Emptor complex 2 activity, the absence of Emptor complex 2 activity leads to an impairment in the initiation of this process. And so in the mice that express that activated K-Ras allele, you can see very nicely within this pancreas the loss of normal astrocells and endocrine cells in normal ductal architecture. And you see that the pancreatic tissue is overtaken by vast amounts of these precursor pannin lesions and lots of deposited collagen around these pannin lesions. In the absence of Emptor complex 2, you do see some of these lesions forming, and you can see some of them shown here, but you can see that the extent to which they form is greatly reduced. And you can see also reduced collagen deposition. And so we can quantify this as shown here to the right. You can see again, in the absence of Emptor complex 2 activity, we retain a lot of normal astrocellular architecture. We get fewer pannins, and importantly, those pannins that are present tend to be at lower grade, at the earliest grade, pannin 1, whereas when Emptor complex 2 activity is intact, at this time point at 8 months of age, we're beginning to see a significant amount of progression to higher grade PANN2 lesions. So in addition to inhibiting initiation of the process, a deletion of Richter and therefore inactivation of Emptor complex 2 extends survival in a model of invasive carcinoma. And so here, this is a model driven by expression of that activated K-Ras allele and combined with loss of a single P53 allele. And here you can sort of see the survival of what we call the KPC mouse. So it's driven by K-Ras and P53 deficiency. If we delete a single Richter allele, there's no impact. But if we delete both Richter alleles, you can see that we significantly extend survival. And again, that's quantified here for you on the right. Now, we obviously in patients are not going to go in and delete alleles. We're going to give them drugs. And so we try to model that as well in the mouse. And here you can see that here is our survival, again, in this KPC model. And if we give mice a combination of an Emptor kinase inhibitor that will inhibit both Emptor complexes, both complex 1 and complex 2, and we combine that with gemcitabine, that we can significantly extend survival in this model. And so what these data suggested to us is that inhibition of Emptor could potentially be part of an effective therapeutic regimen in pancreas cancer. Now, what's important to note here is that even though we significantly extended survival, these mice all died, and they all died from pancreatic cancer. And so this really led to some outstanding questions. And today I'm just going to touch on one of them. And one of those questions, how can we improve the effectiveness of Emptor inhibition? So can we identify drug combinations that are far more effective than the ones that I showed you on the previous slide? And we always anticipate that there will be resistance that will occur. And so what are the mechanisms of that resistance? And so the approach that we took to begin to address this was to screen a small molecule library for drugs that might cooperate with Emptor inhibitors. And so the strategy, again, was to use a 96 well format. We tested our screen in a single human pancreatic cancer cell line. We utilized an Emptor inhibitor, AZD2014, screened a couple of relatively small drug libraries, and we screened for two data outputs. One is cell viability. And so we had to have more than a twofold reduction in cell viability relative to the DMSO control. And then we wanted to have what we called a high cooperativity value. And that is, we wanted the reduction in viability of our candidate drug plus AZD2014 to be greater than 1.5 times the viability reduction observed with the drug alone. And so through that screening process, we got 16 candidate compounds. And today I'm just going to touch on one of them. And so one of those drugs that we found was an inhibitor to another protein kinase called MEK. And MEK is a kinase that is in that RAF-MEK-ERK MAP kinase signaling cascade that is activated downstream of K-Ras. And so nicely color-coded here are 4 different pancreatic cancer cell lines, but the results are essentially the same for each of these. And so here's the viability in our DMSO control, and that's set to 1. And then the relative viability when we treat with either the Emptor inhibitor, the MEK inhibitor, or the combination is sort of shown in the subsequent bars on the graph. And you can see that when we combine both the Emptor inhibitor and the MEK inhibitor, we get a nice cooperativity that significantly reduces viability. And you can see for all the cell lines that we looked at, this interaction is statistically significantly better than either drug alone. So we've also gone ahead and done drug concentration titrations on this. And really, mostly what I want to show you here are 2 things. One, that even at relatively low concentrations of these drugs that begin to enter into the space that would seem to be physiologically relevant to give to an intact organism, whether that be a mouse or a human, that we can see significant reductions in cell viability at those concentrations. And we know that some of these concentrations, for example, 200 nanomolar of the Emptor inhibitor AZD2014, very effectively inhibits signaling through the Emptor kinase. So not only do we see an impact on viability, but we see very high cooperativity or synergy between these two drugs at these relatively modest concentrations. So this is a synergy score generated. This is a Bliss or the Bliss method using an algorithm called CompuSign. You can again see that at relatively modest concentrations of AZD and selumetinib, that not only do we get significant reductions in viability, but we get very high synergistic interaction between these compounds. So finally, we can model this in cell lines, but if I had $1 for every time that we've cured cancer on cell lines, I would have many, many dollars, and I don't. And so we wanted to test this in systems that are far more representative of the human disease. And so we actually turned to a nice collaboration actually with Dave Tuvison and Dennis Planker in his lab. And so a few years ago, Dave and his group had described human tumor organoids for pancreatic cancer. And these are just some images of these organoids here. So you can see normal pancreas epithelium forms a nice sort of hollow sphere in this three-dimensional matrix, whereas tumors are far less uniform, and you'll see infilling of that lumen and invaginations into that lumen, and sometimes that even fully closes. There's no visible lumen in that setting. And then each of these organoids is derived from a particular patient specimen and recapitulates sort of the genetic and epigenetic features found in those tumors, and therefore represent really nice models for screening potential therapeutics. And Dave's lab and Hans Cleaver's lab have both demonstrated that you can use tumor organoids in that fashion. And so together with Dennis Planker and Dave's lab, we did a very small pilot where we screened a small number of human tumor organoids. I'm just showing you a couple of examples here. And so we can identify organoids that are essentially completely resistant to the MEK inhibitor selumetinib and relatively resistant to the Emptor inhibitor AZD2014. And we don't really see any reduction in viability here until we get to very high drug concentrations. We can identify other organoids that are sort of intermediately responsive. And so we can begin to see reductions in viability as we moderately increase the concentrations of AZD2014 and selumetinib. And then we can identify organoids that are highly sensitive to the interaction of these two drugs. And as we moderately increase AZD and selumetinib concentrations, we see significant reductions in viability. And that's accompanied by high synergistic scores and readout in these assays. And so what these data suggest to us is that combination of AZD, an Emptor inhibitor, and a MEK inhibitor could potentially be efficacious in human pancreatic cancer patients. And we're beginning to explore this in a greater number of cell lines in additional organoids. And we hope in the very near future in an intact genetically engineered mouse models for pancreatic cancer. And so this is what I've told you today. And what I hope you'll take away is that Emptor inhibition could be a component of therapeutic strategies for PDAC. And hopefully if we can get more effective targeted therapeutic approaches, we can potentially begin to reduce some of the disparities that we see for this disease. And so I'll just close again by thanking the folks who actually did the work, because I don't do very much of it myself. And I do want to give a very special shout out to Dave, both for his invitation to speak today, but for also our very enjoyable collaboration, in particular, Dennis Planker and this group. And so with that, I will stop sharing and I will take questions. Thank you.
Okay, thank you very much, Brian, for that terrific talk, and Howard. So now you have entered into the roundtable portion of the symposia. And since you have your veritable cup of hot beverage in front of you, and we all know each other well, I was hoping that we could touch on a few points that would be of interest for the audience to hear us discuss. And maybe you can kind of stretch the boundaries of what you're doing now, but what you would love to do if you had the time, the manpower, and woman power, and et cetera. And so a question that I get a lot of times from folks about pancreatic cancer and thinking about different populations, different races, ethnicities, et cetera, is, are we sure it's that much different across populations? Since, as you've shown, both of you nicely, epidemiologically, it's a slippery slope disease no matter who gets it. There really is not a form of pancreatic cancer that is slow versus others. There's kind of fast and faster. And are we really learning a lot by studying the disease per se, or should we be studying conditions that set us up for the disease, which does vary, I would say, across races and environments, et cetera. And so I'll come back to something that, again, Howard started his career on, which is inflammation of the pancreas. Inflammation of the pancreas is common. We probably, all of us, have it subclinically pretty often when we get a little too celebratory. But we can also, besides the occasional alcoholic beverage, there are other reasons that one gets pancreatitis, related sometimes actually to phlegmon that come down from your gallstones that are tiny, occasionally physical trauma, and then all types of rarer causes. When people look for genes involved in pancreatic cancer, they frequently come up with genes involved in pancreatitis. Not uncommon, right? And so I guess one thing that I've always wondered is, maybe this question, we have it focused on the wrong problem, and we should ask the pancreatitis or inflammation, whatnot question across populations, across various genetic groups, et cetera, because we do know that inflammation varies based upon where people were born and then moved to another environment where the food is different, that their germline is not used to processing, all of that, and has, nothing to do with exotic other things. So I'm just curious how both of you think about that as something that potentially doesn't deserve, some attention. It's kind of like our polyp, it's maybe something that's not anatomic structure, but rather a state of the pancreas. So I'll go to Howard first, but don't say everything. Give Brian a chance to say one thing, because I know you're
kidding me. I'm going to let Brian talk. Yeah, no, it's a great question, Dave, and I'm going to try to take some of the chat questions and try to incorporate into the answers as well. So absolutely, the idea, for instance, of diet, changing the microbiome. A lot of what we talk about when we talk about alcoholic pancreatitis is an increased permeability to bacterial access to the pancreas, and so what the microbiome that's there in the first place could have a very profound influence to that. And of course, that comes from diet and environment quite a bit. We're also interested in the Detroit area, that there seems to be an uptick in certain regions that are associated with certain defunct chemical plants, and so that also can change. What I would agree with you, it's very early stage pancreatic cancer, but we usually just call chronic pancreatitis. So all of that can be an influence, and I think it's probably going to be one that we have to pay more attention to. One thing that I found early in my career, before I hand it off to Brian, is that when I went into normal pancreas samples to try to use as controls for some of the things that I was doing, as you mentioned with MMP7, I kept finding, there's MMP7, my whole hypothesis is ruined, blah, blah, blah. And I take it to the pathologist and they would say, oh no, that's just a little pocket of pancreatitis. This normal patient has this indolent pancreatitis, never diagnosed. So a lot of us, as you know already, and maybe not everybody, we are walking around with benign disease all the time, particularly, no coincidence, associated with age and associated with diet. And I think that both of those are going to have a profound effect. We just have to be able to have enough patients for a long enough time to look at retrospectively at some of these issues. So Brian, if you want to take it.
I will take it only to say that, I called you Howard.
Not the first
not
time.
Harold. You're much younger than Harold. So Howard gave, I think, a really excellent answer, which is that all of these things are going to contribute, right? So, for example, Harold, Howard showed a very nice data on ApoE in receptor, right? And there may be differences between populations related to that. But that's also going to intersect with things like, diet, and some of that's cultural, but also some of that is sort of systemic, right? Which is that people's diets are influenced by where they live and, what grocery stores and produce and so on are available to them. And so, it is not surprising that these things will all sort of come together. Howard mentioned, looking in the Detroit area to defunct chemical plants, right? And there's a correlation with that. So I think all of these sort of environmental things will come together with diet and potentially genetics. They'll also come together with access to healthcare, right? A single episode of acute pancreatitis is, not that bad. Chronic pancreatitis is a lot worse for you in terms of the potential to transition to pancreatic cancer. And so if you don't have appropriate access to healthcare, then that also has an impact. And then I just want to, close by going back to the point I sort of made in the early part of my talk, right, which is that, if you don't have effective therapies that can be implemented in any medical setting, right, then you're also going to see significant disparities, right? I think it is not, I sort of showed a picture of Alex Trebek in one of the early slides. He was diagnosed with stage 4 pancreatic cancer. I think it's not necessarily surprising that he significantly beat the expected median survival of a stage 4 pancreatic cancer patient. Right. And that's obviously something that's not equivalent across our society.
Yep. Okay. Good points out, both of you. Just to finish with that point, I mean, when you take populations that do carry known alleles affiliated with pancreas cancer, one of the most telling observations I saw from the epidemiologists like Gloria Peterson and Meg Mandelson and others is that in that subset, if they were to then smoke cigarettes, their risk of developing pancreas cancer was almost like exponentially higher.
Right. There's no single risk, but when you start combining and overlaying the risks, everything goes up, like you say, exponentially. And I think that's really important.
And if you ask the geneticist, is it because there's a tobacco signature in the tumor? It's pretty hard to find that tobacco signature in pancreas cancer.
Right.
So, the supposition is that it promotes more inflammation, et cetera. And there probably are multiple other things at play. As Brian says, until we end up with some effective therapies to essentially take the edge off pancreas cancer, we're in a tough spot. And so he's really spent the better part of his career looking for, sort of the right uppercut into pancreas cancer. And again, as I pointed out, when he stumbled on TORC2, that was actually quite interesting to me because that is the piece of TOR that is proximal, physically located next to RAS, because SYN1 or MAPCAP1 actually has a RAS binding domain, and that's pretty exciting from a biochemical standpoint. But to actually come back to the human standpoint, which is the purpose of this conference, in addition to the really interesting cell biological approaches that Howard's using to try to understand disparities, I think at some level, the molecular biochemistry of the things that Brian is talking about itself will actually play a role in how there's differences in this disease across populations, across races, et cetera. And I use the term modifier genes, I think earlier this morning, I don't think with you all in this part, but I suspect that we're going to find modifier loci as really the underlying basis of the differences across populations. Loci that modify RAS, the RAS pathway, and all these vectors of RAS. And so,
I totally agree. I think that you could even put ApoE4 into that bucket.
Yeah, no, that's a really cool new observation. I hadn't heard that one before. I like that new story. And so, yeah, I think that if we could collect dozens, hundreds of samples of different races, of Asians, of Native Pacific Hawaiians, of Africans and African Americans, Caribbean Americans, et cetera, just like build it out, I suspect we will learn things.
Yeah, and what we're doing, by the way, for that control is that we have a young investigator here, that Evelyn Giaghi, who's doing this in breast cancer, who's hooked us up with with pancreatic cancer patients in Ghana, so that we can truly compare, at least part of the African continent disease to the African American and to the Caucasian American.
Okay, so what I'm going to do is, so I have to introduce Nico pretty soon, but Nico, I'm not going to introduce you for just hold on. Because he's the last speaker. I'm gonna give you guys 5 more minutes, because I'm gonna actually ask you the questions the panelists have posed, because I promised that's how this was gonna work, instead of going off the cuff of my cuff. So we have some interesting questions. One of the questions, I'm going sort of retrograde on this, is whether we have drugs that actually can target the processes in pancreas cancer that aren't gonna, go to the rest of the body. To me, this is a simple question. It's kind of the kind of question I would get at the dinner table, but it's a question us scientists have never addressed properly. And I actually write about it in a review article, which hopefully will get accepted and published soon. That's our job when we make these models in animals and organoids and whatever, is to come up with better ways to deliver our therapies. So I'm going to turn this over to Brian, who's going to combine a bunch of drugs and make cells go away in a dish. He's going to try to do that in the mouse without the mouse having a lot of other issues. We know we have that problem in humans. When we take an AKT and a MEK inhibitor, you can't do it, in humans. So Brian, this is your turf. How are we going to do this?
Yeah, so, it's an excellent question. So whoever asked, thanks for that question. So, I think the way that we are going to have to do this, right, frankly, I think we can already do a lot of it, right, is to use refined nanoparticles that give us, 2 things. One, better targeting, so we can better concentrate a therapy in the pancreas and not, affect other tissues throughout the body, but also give us, potentially better penetration into the tumor. And so a tumor like pancreatic cancer is very hard to penetrate. And so nanoparticles can potentially provide, opportunity to, get better delivery, better penetration, and potentially, frankly, carry a higher payload. Because again, if they're being targeted, getting a lot of clearance through the liver, for example. So, I think what we are doing is early stage, right? The question is, does the stuff have a chance to work? And if we think the answer is yes, right, then I agree with you, Dave. It is our responsibility to figure out how to best effectively deliver this so that we get the best impact for the patient.
Okay. All right. Well, thanks for the answer. I look forward to seeing your data on this. I mean, in theory, Abraxane is a nanoparticle, but it's really it's a formulation. It's not really a nanoparticle. It's just kind of, you can solubilize it with aqueous solution. It's not stuck, really to the albumin. It's kind of in a groove. It falls off right away. But if you could take that concept and do what you're saying, that'll be great. And we look forward to seeing the results. The next question is from Antonia Baines, a great participant in this conference, speaker at this conference not long ago. Why is there not more focus on prevention of pancreas cancer? We just had cool talks about colon cancer. They have survivors that can participate in this conference. They talk about colonoscopy, all this kind of stuff. We don't do any of that stuff in pancreas cancer. We just we're behind the curve on this whole thing. Why don't we work more on prevention? Or is there a whole prevention group and they don't get invited to this conference because I don't know them? Howard?
Yeah, just put me in the hot seat. So, well, you've already mentioned that as we said, smoking by itself, diet by itself, these things don't have like a tremendous impact on risk for pancreatic cancer by themselves. But when you start combining them, then you have that risk. And so right now, I would say the irony is a lot of the risks for pancreatic cancer are risks for other cancers. And there's no reason for us to say that we're of course, we want to prevent pancreatic cancer. It's very relatively in the population, very rare already. So that might be part of the reason we don't talk about all these things about don't smoke, don't drink too much, and don't have a terrible diet. We associate those with the more common cancers, but that behavior change would also help prevent pancreatic cancer. So I agree that we don't pay enough attention to it. And until we know more about what is causing the risk, being in a susceptible population and monitoring that risk in particular. So there, like I mentioned, genetics susceptibilities, as you mentioned, modifiers. Those people in particular, we should be absolutely coaching them that you need to have behavior modification to prevent the risk for pancreatic cancer.
Okay, now that was a really good answer. I think, it comes down to we don't know what to measure.
Yeah.
So it's colonoscopy, you see it. It's like right in front of you. We just don't know what to measure in pancreas cancer. If the tumor got as big as a polyp in a colonoscope, it's way too big.
Yep.
Right? It's like the patient usually is progressed by then. We need to see it before you can see it with your eyes. And see it quotation fingers. We need to sense it somehow, and we don't have it. Okay, so I'm running out of time, but I'm still going to try to ask one final one. And this is, I guess, to the essence of why this conference. And I apologize for being redundant with Tony, but Tony Baines is asking this question: why do we think that African Americans haven't been more of a focus in the past when it comes to research? In pancreas cancer, we don't own this question, right? This is not, we have a lot of problems in pancreas cancer, but it is part of, studying it. And I'm actually going to ask my panel to respond to this. Why is it that research has not involved cancer research has not involved African Americans in the past on an equitable level?
Brian, I'm booting this one to you, but I have an answer, but I want to hear you.
Yeah, sure. I'll take first crack at it, right? So, again, I would say that these, as you mentioned, Dave, these are not things that are specific to pancreas cancer, right? These are sort of issues related to the structures of the system, right? And so, if we look across many diseases, right, there are disparities in terms of participation and enrollment in clinical trials, recruitment into clinical trials. And there are disparities in terms of, even sort of our modern approaches like genome sequencing, right? Sort of ensuring specimens were collected from a diversity of individuals was not a priority in these early phases of these studies. And what's happening now is we're essentially going back in and sort of backfilling that deficiency, right? So that's the phase that we're at right now, is sort of backfilling that deficiency. And so the work that Howard talked about, for example, is a way for us to do that. But again, we look across several things. But we look across gender, right? This was an issue for many years as well, right? And we obviously recognize at some point, right, that there are sometimes differences between men and women. And so we've begun to incorporate gender, and now we're doing that for race and ethnicity.
And I'll just re-emphasize one thing in particular that Brian mentioned is that, when we try to consent African-American patients for just being able to study some of their tissue, that the take rate for that consent is much lower for obvious reasons that are history long before us, it's, I would say, well earned. And so it's really up to us, and it's really up to the greater community who we talk to. We talk to patients and their families all the time to really emphasize that participation in these trials is important. It's critical. For the most part, pancreatic cancer patients, I'd say, compared to other cancer patients, are pretty participative. They know how bad this disease is, and they don't want to see anybody else have it. But it's still a much lower take rate for when we try to consent in that population.
I mean, what I try to do from my vantage point on this topic, and this will be the last point we make before I introduce Nico, is I try to encourage the local sites to establish centers of excellence so that the problem is studied in that community. And then the community can participate in studying the problem, meaning the community owns the problem. It's not just sort of shipped to Washington or wherever. And I'll use the organoids as an example. I'm really happy that, Brian is starting a collaboration with us. I hope it means he can set up an organoid, shop at UMass, and the same is true for you, Howard. It's the tissue of your patients. And, people love to hear that their tissue is being studied, and then they could see it under the microscope, and that the information might help explain to them maybe why their relative has cancer, but also might explain why their family doesn't get other diseases. And actually the thing that has always been the surprising thing that I've found is that when people hear that by studying their tissue, they're going to help other folks who actually get it much worse elsewhere or something else elsewhere, everyone wants to be part of that. And anyway, that's how we're trying to do it with various groups in Hawaii and this and that, is trying to help them set it up so that they ask questions relevant for their population. And, I mean, back to Tony's question, I think that we just have to concentrate on it. We just have to work at it and involve people in it. It has to be a community effort. So look, I want to thank Brian and Howard for participating in this part of the symposia. If you're able to stay on for Nico's talk, that'd be great. He's going to go on for about 15 minutes. I'm just going to introduce him right now, though, if that's okay. There are questions we couldn't get to because you have a poor moderator. What's going to happen is they're going to make a list of the questions, and if they can figure out who sent it, they'll put the person's name and email, and then somebody will send you an Excel spreadsheet. And if you're able to talk to the folks, that would be much appreciated by me. But again, thank you very much, both of you. You both have massive day jobs and your thought leaders. If you're a trainee and you want to work on TOR signaling, or you want to work on understanding the genetics and molecular biology of pancreas cancer in African Americans, you should write to Brian or Howard and go do a postdoc with them. And they would love to welcome you. All right, so now we're going to go on to Nico Robin, who I've gotten to know very well at the New York Genome Center. And so Nico is a computational biologist who actually spends a fair amount of his time on the topic very germane to what we're discussing today, on understanding the molecular biology of cancer across different races. And so I've gotten to know Nico over the past, 5-6 years, when I became participating in the New York Genome Center conversations about how could multiple, ivory tower cancer centers and cancer hospitals in the greater New York City area, how could we work together on a problem that no one site could handle by themselves? And so again, I work at Cold Spring Harbor. You've heard about it. Some of you visited it. It's a beautiful, small basic science cancer center on the North Shore of Long Island. We don't have a hospital. We work now with Northwell Health, which is a large healthcare provider, which is opening our eyes to many things that we can work on, including this one. But at that time, 6 years ago, or 7, when I started going to the Genome Center for these conversations, like everyone was looking at each other from around the table, and they all thought they could solve the cancer problem by themselves. And so the topic was suggested that maybe studying cancer in specific racial groups, of which every hospital had a few patients, would be a good collective project. Harold Barmas is the chair of the discussion group and has been for the last 6, 7, 8 years. And again, Nico's head scientist at the Genome Center. So he watched this concept evolve to the point where people were interested enough to return the following month to talk about the topic. And this conversation went on forever. So you heard from Dr. Salufa about how our relationship started all those years ago, which led to a P20 grant and, et cetera. This was similar, but like on a bigger scale, because I had, Memorial, NYU, Columbia, Cornell, Sinai, like all of them coming to this thing, Stony Brook, downstate, Cold Spring Harbor, et cetera, coming to this place asking, what are we all going to work on? What can we not compete on? What do we have to work on together? So it actually became studying cancer across races, where hospitals would actually pool their patients so an answer could be obtained. The problem is not the number of questions. The problem is the number of patients. There just aren't enough, even though New York is a very diverse place, for one hospital to ask this question. And so Nico really has been the scientist at the Genome Center who's pulled it all together. We've started this thing called the Polyethnic 1000 Project that he will present to us today. He's going to start his presentation 13 minutes late, which means he's going to go 13 minutes late, which means you get 13 minutes less of your green, healthy salad. And I apologize for that, but you can just say it's on me. So Nico, please take it away.
Thanks, Dave. Thanks for the organizer. Can you hear me and see my slide?
Yeah, we can.
I'll take that as a yes, and I'm very happy to present you an update on Polyethnic 1000. So for the regulars of this meeting, I came last year, and I think that was my last last event before being sheltered in place. And I gave I presented a poster on the stage of Polyethnic 1000, and I'm happy to present the updates. And there's been many things going on this year. So obviously, I will skip that slide very quickly. We all here in this audience know about cancer health disparities. It's really coming up in the news, and it's a recent focus. And I would say to the previous conversation that it is not a problem that is only for cancer. We have the same disparities and the same lack of representation in other diseases as well. The problem we have in cancer genomics is illustrated here when we look at the main public database for cancer profiling. So we've done cancer profiling for about a decade, where we sequence tumors by various experiments, by whole exome in things like TCGA, by panel sequencing in various hospitals, and some of them have grouped their results in a portal called AACR Genie. You see that in both of those cases, the majority of the samples are coming from patients of European ancestry. And by majority, I mean above 75%, which is clearly not representative of the general population, either in the US, in Europe, where those samples are coming from. And so that's something we really need to address. And the way we've done it, and Dave started to explain the concept and how we came about. We are located in Manhattan, and we have partners in different hospitals, different centers. We were created around 2011 by 16 university and hospitals who created the New York Genome Center for large-scale genomics and bioinformatics. But we really wanted to expand our network and work with a lot more diverse sites, have a lot more sources of patients. What you see on this map is the great diversity of the New York region, and that's colored by the census group, and that's a map from 2010. So we had a census last year. I need to update this map, but the situation is still the same. We have a lot of diversity that's not across the entire region. We have different neighborhoods that have diversity, but we have really the greatest diversity in New York of the entire United States, and we need to take advantage of that to offer cancer profiling and to study cancer in different population, people with different ancestry. How did their ancestry affect the way they present with cancer, and the landscape of somatic variants, every information we can have using the tools of cancer genomics. And so we have established this network really under the leadership of our senior advisor, Harold Varmus, Charles Sawyers, and Dave. So we did the first phase in 2019. That's what I presented last year, where it was really a pilot phase. We collected 160 samples from 13 institutions. All of them were self-declared non-white, and so we had African American samples, Asian samples, Latino samples. We did a whole exome sequencing and RNA sequencing on the tumor. And what I'm presenting here on the left of this slide is the genetic ancestry estimation. So we do whole exome sequencing, and we can establish what's the percentage of the genome that correspond to the African population, or to European population, or to Asian population. What we see in the bottom track is a little bit more granularity in the population level, and we use the reference population from the Southern Genome Project, and we can really start to establish the composition of the genome for those patients with more granularity. And you see that there is a lot of signal in those information. There really, when we say African genome, it really comes from different African population, and same is true for the European composition of those, and for the Asian origin of those samples. So we really can establish a quantitative information about the ancestry of those patients that supplement the self-declaration race or ethnicity that people declare when they come to the hospital and when they agree to participate in research. So we've done all of this work with archival samples. We share the data in a local CBio portal. We share with the consortium, and we really establish a group of scientists that are interested in those study, and that consortium, can grow and can expand. And I encourage you to contact me after the talk if you want to participate and know more about the project. In 2020, we decided to go for the next phase of our project, and we launched a request for proposal for which we received 21 letters of intent, people that told us that with access to diverse samples, they would study this or that particular question. Obviously, we had a little bit of delays as everybody else. We established a review board represented here, and I would indicate that we were, it was a great panel. We had great discussion. And we were, all of these individuals are fantastic, and they really help us a lot. But I will point out Otis Brelli, who is giving a talk after the break. And so we established project in two different categories: the major project and the startup or supplemental project. And I will go in a little bit more detail about each of the projects we selected. The source of funding was the Mark Foundation for the first phase that I talked about. We had various philanthropic donors. The New York Community Trust helped us, and we had great contribution for the sequencing part of this project. We also had contribution from Weill Cornell, Columbia, Cold Spring Harbor Labs, and Northwell Health to complement the budget. And we selected 7 projects that are now starting. So the first one is focused on bladder cancer, and our collaborator have a great hypothesis on the effect of HLA allele that have, of course, a lot of diversity between European populations and African population, and may play a role in explaining why bladder cancer is so much more aggressive in African American and much more deadly than in patients of European ancestry. And that's a project mostly led at Weill Cornell and using the patients from the Presbyterian Network. The second project is very relevant for the session, and obviously is led by Dave Tuveson and Alex Krasnick, with support and help from Laura Martello-Rooney and Jeff Boyd at Northwell Health on pancreatic cancer. And what will be done there is both whole genome sequencing, RNA-seq, but also organoids development, and the ability to perform drug screening and functional study of those. So the project will help to have a biobank that contain tumors from African-American patients with pancreatic cancer. We will also have a project on both breast and prostate cancer, and the commonality here is the hypothesis of homologous recombination deficiencies in African-American and Hispanic patients. That's a project with Weill Cornell and Mount Sinai and Columbia, and we're very excited for those projects. The fourth major project is on multiple myeloma, which we all know is one of the poster child of cancer health disparity. There's very clear risk factors and the effect of or the presentation of the disease in African American needs to be studied. It's a project that was launched by Memorial Sloan Kettering and NYU, and as some of you know, Ola Landgren and actually Francesco Mauro as well moved to University of Miami recently. But we will take this project anyway. We have then 3 startup or supplemental projects. The first one is on lung cancer, and it's actually the only project that we are doing that will be focused on East Asian American. And the idea here is to really look at pre-invasive and invasive adenocarcinoma and establish differences between patients of European ancestry and patients of East Asian ancestry for this premalignant lesions. The project on colon cancer will be led by Samir Bayaz at Cold Spring Harbor, Laura Martello-Rooney, and Jeff Boyd. And again, we'll use whole genome sequencing, RNA sequencing, and organoids development with some hypotheses around chromatin structure and the control of beta-catenin. And finally, a project on endometrial cancer with New York Presbyterian, Northwell Health, and Cold Spring Harbor, again with organoids and with sequencing of data. So we have 7 projects listed here. We have a great network of institutions that will contribute. We have a great network of PI that will contribute. We will sequence up to 1,000 samples in the next 2 years. There will be a mix of retrospective and prospective samples. And we will always do tumor normal whole genome sequencing at the New York Genome Center, as well as tumor RNA-seq. Some of the project will have organoids development, will have some other experiments, but not all of them will have that. And it will be research samples that are consented for data sharing. So the goal is to have more diversity in the public database for cancer genomics, but also to learn a lot about those different cancer types. This is the bioinformatics slides here. It's a summary of what we do with the whole genome sequencing. Really, we try to extract as much information as we can: single nucleotide variant, indel, structural variant, copy number variant, purity and ploidy estimation. We have classification of the structural variant, microsatellite instability. So do we see more MSI high samples in a particular population than what we had currently in the database? What are the HLA types that we have in those samples? Mutational signatures. Do we have a difference again that could connect to some germline composition in the different populations? Homologous recombination detection, and of course genetic ancestry, as I illustrated, both at the global level but local level. So along the chromosome, do we have some haplotype coming from a particular ancestry that affect the risk for the particular cancer, or that affect the mutations that we observe? And we will collect clinical information in a REDCap database that will be linked with all of the different sites where the samples are recruited. We will generate the data. We'll have a small embargo period where the data will be shared with the investigator in charge of the project, but then have it more larger and accessible to everybody in the consortium so that more people can access the data, perform analysis, contribute to the analysis of the data. And ultimately, the goal is to have the data in a controlled access repository that could be ICGC Argo, that could be an equivalent, but it will be shared with the larger scientific community. The next step of the Polyethnic 1000 project is to hire 2 ethnicity and cancer scholars at the Genome Center that will be announced very soon. We really want to do a large effort on patient and community outreach, explain our project, contribute to explaining the importance of participating to research project. We really also perform clinical sequencing, return of results to patients that cannot be done at the current phase, but that's really a direction that we want to take. And we hope to continue those projects in more minority populations, not simply or not only African-American population, but there is a lot of diversity in New York, and there is a lot of smaller populations, smaller minorities that we are very interested in working with. And we will expand to additional cancer type. And so, we listed some here. There, all cancer type can have some diversity that or will need to be studied under the same idea of looking for diverse samples and establishing the viability of those cancer type from a cancer genomics point of view. So these are the acknowledgements, the people that are working with me in my team, the people at the New York Genome Center, all of the PI, the steering committee, the support that we receive for this project. And obviously, I want to thank all the patients and the participants to the Polyethnic 1000 studies. I'm happy to take any questions if I'm on time. I think I am on time.
Thank you, Dr. Robin, for informing us about this really important initiative that our groups are involved in. And now we will go to the—
Laura?
Yes, sure.
I'm just gonna, Nico, this is me, Dave. I don't know if Howard's still on the phone, but he might be. And so my question is, so Howard Crawford is gonna go ahead and generate a Henry Ford hospital version of this, at least for pancreas cancer, but they'll probably have him do other cancers too, but hopefully he'll focus on pancreas first. And he's gonna get all kinds of data. Are you willing, is the New York Genome Center and Polyethnic 1000 willing to interface with other academic efforts that actually yield data sets and then attempt to compare things from different parts of the country or different parts of the world, such that much more expeditiously knowledge can be generated about the relevance or lack thereof of various alleles, VUSs that are found, et cetera?
Yeah, I mean, all of those projects are, I mean, yeah, it's always underpowered. So we hope to have, statistical power to answer some of the questions, but the more granular we get, the more we need more samples. And so that's one of the spirit of sharing the data with the larger scientific communities to, enable other people to access the data and aggregate them with their own data and reach some stronger conclusion. So in spirit, yes, we're interested in interfacing and sharing our data. As you know, in practice, we'll have to make it work. And I can't commit right now, but I think in spirit, we are very interested in interfacing and collaborating with other people interested in those questions.
Okay, and we just had one quick question from Dr. Melissa Davis. Will polyethnic 1000 study social determinants?
Yeah, so that's not exactly our core expertise. We are, of course, interested. It requires to obtain very detailed information about the patient and about the particular samples we're sequencing. So if we have access to this data, yes, we can have it, and we can have the data being shared by our consortium and have more experts, taking advantage of that data. Yeah, so it can be done. I don't know if it can be done on at the scale that we will do. I said we will have 1,000 samples overall for the project, but if we split into the 7 project, at most we'll have maybe 200 samples per cancer type. Is that enough to study social determinants for cancer? As far as I know, I would imagine that we need more data. We need larger sample size to really study that carefully.
Great, thank you. I put in the chat the link for evaluating the morning sessions. If everyone could take some time between now and the start of our next session, I'd appreciate it. I think to try to keep us on track, we're gonna go ahead and shorten the lunch break and come back at 12:30 for our keynote talk by Otis Brawley.
Senior Associate Editor for Gastroenterology, the highest impact GI journal. He completed a 2-year appointment on the National Commission for Digestive Diseases, a U.S. Congressional Commission, after his appointment by Elias Zerhouni, MD, that is the director of the NIH at the time. He was also elected member of the American Society for Clinical Investigation, and also elected a member and past president of the American Association of Physicians. This is just to name a few. So it's just amazing. Last year at SUNY Downstate, he was the first recipient of the John G. Crowell, MD, PhD Distinguished Mentor Award from our campus. So it's just a distinguishing career, and what he has done to trainees across the country, the impact he has had is just tremendous. So it's just a joy and pleasure to always have him with us, and he will be moderating this session. So please join me in thanking him and welcome him to this conference.
Thank you, Dr. Salifou. That was a kind introduction. I feel like I have to give the keynote speech now. I'm gonna introduce my friend, and it's been great being associated with the P20, and I want to thank you and certain Dr. Martella Rooney for your efforts for improving disparities across all aspects of lives, particularly with colon and pancreatic cancer. I am thrilled to moderate this session and introduce my good friend, Dr. Otis Brawley, who is currently the Bloomberg Distinguished Professor of Oncology and Epidemiology at Hopkins. He is a board certified board certified medical oncologist and epidemiologist. He's an authority on cancer screening and prevention and leads a broad research effort of cancer health disparities at the Hopkins School of Medicine, the Bloomberg School of Public Health, and the Sidney Kimmel Comprehensive Cancer Center. And I can tell you, I had the pleasure of giving a talk down at the Bloomberg School of Public Health, where we discussed some things on my presentation. He focuses on how to close racial, economic, and social disparities in the prevention, detection, and treatment of cancer. And prior to that, for almost 15, about 12, 15 years, he was the chief medical scientific officer for the American Cancer Society. He is a recipient of the U.S. Public Health Service Meritorious Service Award, the Department of Defense Distinguished Service Award, and the 2019 American Medical Association Distinguished Service Award. And he is also elected member of the National Academy of Medicine. So I am thrilled to introduce Dr. Brawley, who's going to give the keynote speech today. And I'll try to moderate the questions after. He's going to talk about cancer control in the 21st century and disparities in health. Welcome, Otis. Welcome, Dr. Brawley, to this conference.
Thank you very much. And can you see my slides?
Yes, we can see it.
Perfect, perfect. Well, Zoom is wonderful when it works. It's really wonderful to be introduced by John Carruthers, who is a good friend and has done so many just absolutely amazing things. Both of us grew up in Detroit, although I have to admit I'm a little older than John. What I want to talk to you today is really talking about cancer control. One thing that and when we talk about health disparities, it's special to me because I worked for David Satcher when he was Surgeon General, and he first started talking about health disparities. Prior to that, we talked about minority health and special populations health, but he really named it what it was and made it hard for politicians to be against programs to reduce disparities in health. First, my disclosures. I work for Johns Hopkins. I consult for the government and for Genentech. I've also written a book in the past. None of this talk is really about those things, but I should disclose those. I'm going to talk about trends in cancer death rate over the past 3 decades, define race and population categorization, define disparities as we see them in the 21st century, and discuss some approaches to overcoming those disparities. First, these are the death numbers from 2019. This is the number of people who died from heart disease, cancer, accidents, so forth in 2019. I just want to acknowledge that if I were to have the 2020 data, coronavirus, something we didn't even know existed in 2019, would be the 3rd leading cause of death in the United States. And indeed, it is rivaling cancer right now. Hopefully, the pandemic is starting to wane. Now, cardiovascular deaths have been declining over the last few years. Cancer death rates have also been declining. Cardiovascular death rates have been declining faster. Within the next 5 to 10 years, the leading cause of death in the United States is going to be cancer and not cardiovascular disease. It is already the leading cause of death. Cancer is the leading cause of death in several populations: Hispanic women, Black women, for example. Now, I'm an epidemiologist and a medical oncologist, so I'll use that as license to show you some slides, some graphs with data. In 1900, the death rate from cancer was 64 deaths per 100,000, age adjusted, removing the aging of the US population. By 1991, the death rate was 215. That is more than tripling of the death rate throughout the 20th century. We've now had a 29 to 30% decline since 1991, a good thing. And I'm going to assess why that decline and how we can make it better. When we use racial and ethnic categories, and these are the OMB racial ethnic categories, by the way. Since 1991, you can see Black or African Americans have had the largest decline, but they started out larger or with a higher death rate than any other group. There's a disparity between whites and Native Americans, Hispanics, and Asians as well. And one can actually extrapolate this graph and kind of imagine that sometime in the near future, sometime late in the 2020s, we may actually have no Black-white disparities in death rate anymore, something that would be nice to ponder. Now, the most common causes of cancer death are shown here. Everyone knows that. Race is defined by the US Office of Management and Budget. Most folks don't know that. Every census, there's racial definitions published about 2 years before. The last time we had racial definitions published was 2018. And as that would imply, race changes over time. A little bit about that. The definitions literally change. Now, in the United States OMB, they only have 2 ethnicities, that's non-Hispanic and Hispanic. But these are the 5 races that they collect data on. Now, this definition, which changes every 10 years, is socio-political and not biologic according to the OMB definition. And indeed, race as a concept has been rejected by anthropologists as being non-scientific. When we talk about race changing over time, by the way, according to the 1970 definition, an 8-year-old boy named Barack Obama was white. According to the 1980 definition, an 18-year-old boy named Barack Obama was black. If you know anyone who is from India, if they've been in the United States since 1950, they have been 3 different races. They were Caucasian in 1960. That actually makes a little sense if you know where the Caucasus Mountains are. Now, there's a lot of discussion about diversity in clinical trials. Much of that discussion, not all, but much of that discussion is political and non-scientific. Indeed, the NIH Revitalization Act of 1993 calls for valid subset analysis in our clinical trials. It assumes if you have a 100-person clinical trial and 12% of the population is black and you put 12 blacks on that trial, you can look at those 12 blacks and see differences between the whites. And what I've just said is, race in itself is socio-political. Now, we'll talk a little bit about how to categorize populations in a second. Now, and also, don't take from this talk that Otis Brawley is against clinical trials participation. Indeed, diversity in clinical trials should be encouraged because we've got a lot of data to show that doctors who participate in clinical trials take better care of all of their patients, not just the 2 or 3% they put on trial. And one of the things I want you to get from this talk is there's a lot of problems in getting people good standard care. So race is not a biological categorization, it's a socio-political construct. Now, area of geographic origin can be a biologic categorization, but Ancestry.com, 23andMe, those of us who send our blood off, can tell you that's really complicated because of admixture. So race is a broad category. Black is not one biology. White is not one biology. And we need to be careful when we deal with these because we can propagate institutional racism. Some slides on that in a little bit. Area of geographic origin is much more specific than race, a better way to categorize populations. But again, admixture, the fact that we're all mixed up, complicates things. These are some of the 109 areas of geographic origin in Africa. And according to Ancestry.com, I am the top 6. I'm a mixture of the top 6 and 8 areas of geographic origin in Europe, by the way. So admixture complicates things dramatically. There are 840 areas in Europe, 56 in Asia and so forth. That's because Europe has been better studied than the rest of the world. That does mean one thing that we do need to do is better study anthropology in other groups of people beyond Europeans. Now, when we talk about variation by area of geographic origin, most of the folks in the audience who are medically inclined know about G6PD deficiency and actually know that there are certain types of G6PD deficiency and they tend to center around certain different areas of the world. The HLB1502 allele is more common among people living within 100 miles or 150 kilometers of the Thai-Burmese border. People who have that allele, if they get the anti-seizure drug Tegretol, they develop Stevens-Johnson reaction. They get a flu-like symptom, a raw mouth, and their hands and feet start peeling. It's a very scary thing. But it's predictable among the 20% of people who live among the Thai-Burmese border. Now, if you have someone who's from Thailand or Burma, you might want to do a little bit of benign area geographic profiling and testing for this if you're going to have to give them Tegretol. But again, this is not a marker for Thais. This is not a marker for Burmese. This is a marker for people in that one area, not Asians. Remember, Asians include nowadays Indians and Koreans, as well as people from this area. And my favorite, the sickle cell mutation has a prevalence in southern Italy, southern Greece, going into the Middle East, higher prevalence in sub-Saharan Africa. Now, if you go to South Africa, where there's a lot of sickle cell disease, if you follow those people's background, their relatives came from up north. You see, the original peoples of South Africa, there's no sickle cell disease. I just defined for you Black people who don't have sickle cell disease and white people who do, yet we in our racialism tend to think of sickle cell disease as a disease of Black people. We need to get away from some of that sort of thinking. Now, we're developing a lot of tailored drugs that target specific mutations or specific targets. We're using 30 to 50 person phase 2 studies to go to the FDA and get approval for these drugs. In the future, we need to worry much more about the target and the drug and how the drug is metabolized. And we need to study populations, appropriately labeling them, and realize the distributions of the target and the distributions of the enzymes that metabolize them so that we can make treatment much more applicable to an individual. So much talk has been made about generalizability of findings from clinical trials. We need to talk about, are the findings applicable to all people? Now, I showed you the decline in death rates over the last 30 years. That was due to wise early detection, and there is unwise early detection. We waste a lot of resources fiddling around with screening. It doesn't matter. Improvements in cancer treatment are a big part of this, and prevention, especially tobacco control and smoking cessation. We could save a lot more lives with tobacco control still. Now, cancer screening can be harmful, can be beneficial. It's often both. We need to follow the science. I have some examples of that in a little bit. This is Graham Coldit's list of the causes of cancer. Look at the second column. You can ignore the rest of this. A third of all cancers are caused by smoking, 20% by obesity, 5% diet, 5% exercise. Lump them together to energy balance and think of them as a three-legged stool. It's not just obesity. It's consuming too many calories, not burning them off with exercise, and storage of too many calories or obesity. It's a three-legged stool. It's not just obesity. Obesity is a convenient marker to look at populations. Now, taken together, energy balance is the second leading cause of cancer, right behind tobacco. Also look at the other things, occupation, viruses. By the way, if we were in Africa, viruses would be at 25%. Here, we're just talking to hepatitis and HPV and some H. pylori. I have to mention H. pylori with John Carruthers in the audience. Alcohol is a cause of cancer. UV ionizing radiation, we now estimate that about 1% of all cancers are due to medical radiation, another reason to be careful with screening. Now, this is smoking in the United States from the mid-century onward by gender. 55% of men smoked in 1955. That's an easy way to remember it. You can see the decline. It was 35% of women in 1965, and you can see the decline. You can also see the women's rights movement here with the upsweep to 35%. Tobacco is still the leading cause of cancer, but energy balance will replace it in the future. Lots of lives can be saved with tobacco control. Smoking prevalences by gender. By the way, this is not a misprint, but however, it is a curveball. It seems that Native Americans who live in Arizona and New Mexico in the Southwest, very low smoking rates. Native Americans who live in the Dakotas and Montana, extremely high smoking rates. And this is the average. When you average a low group and a high group, this is what you get. Note Black males, non-Hispanic males, non-Hispanic whites around 17 to 20%. This also is smoking by educational status, and the GED number is also not a mistake. For some reason, people driven to get a GED, very, very high smoking rates. People with graduate degrees, very low tobacco usage rates. This is smoking in the United States in 2013. Keep an eye on these countries in the South. For the next 15 minutes, we're going to spend a lot of time focused on this area. Note smoking rates in Utah and California are very, very low. Smoking rates in the red states are very high. Smoking now in California today is at about 10%. Of course, when I'm talking about California and smoking, I have to stress, I'm talking about tobacco smoking. Cancers caused by infection in the US, hepatitis C, which is treatable and curable, and you can prevent liver cancer. Hepatitis B, which is vaccinable, and you can prevent liver cancer. Indeed, tremendous data from Southeast Asia, especially Taiwan, on the decline in liver cancer death rates because of hepatitis B vaccine. And then head and neck cancers, and cervical cancers, and 4 other genital cancers that are due to hepatitis, human papillomavirus, HPV. And we could do far better with HPV vaccination in this country. One of the slides, which I don't have today, talks about how the prevalence of HPV vaccination among teenagers in Rwanda is higher than the prevalence among teenagers in the United States. All right, energy balance, I've already talked about. Huge amounts of obesity in this country, and it varies by race. With the decline in tobacco use, energy balance is going to become or energy imbalance, I should say, will become the leading cause of cancer in the United States. Obesity, we've gone from 15% of Americans obese in 1970, this is adults, to over 35% today. Compare it to some of my favorite countries here. This is an amazing American problem. The solution to this is to examine how we live. This is going from every family wanting a car in the 1950s to every family having 2 or 3 today. This is the development of the refrigerator, the development of processed food, the microwave, the 2-income family, and the decline of people eating dinner as a family at night. By the way, the refrigerator replaced the icebox and allowed us to store a lot of this high-calorie processed food. This is obesity in non-Hispanic Black women. It's about 60% of Black women adults are obese. If you were to throw overweight into this, we're at 80%. This is the rise amongst Black men and white men and women. Everybody's going up, but Black women are going up especially bad. This, by the way, affects the biology of a number of diseases. The high rate of uterine cancer in Black women is directly tied to the high rate of obesity. Some of the biology of breast cancer and some of the difficulties in treating breast cancer, highly related to obesity in the Black community. Now, let's talk about breast cancer. These are the numbers from the ACS for 2019 to 2016, last year that we got good data, 40% decline in age-adjusted female mortality. Almost half of that is due to screening, a little more than half of that due to improvements in how we treat the disease. When we talk about Black-white, remember it's a socio-political categorization. There's 7 states where there's no Black-white difference in breast cancer death rate. 6 because they're very low, and then there's West Virginia where everybody has high death rates, but there's 6 states that have low breast cancer death rates and Black-white differences do not exist. Indeed, by the way, there are 11 states in the United States where the white breast cancer death rate is higher than the breast cancer death rate for Black women in Massachusetts or Minnesota. We'll talk about that in a bit. This is death rate for breast cancer from 1975 onward using those racial ethnic categories. No differences in Blacks and whites. Then we learned how to treat the disease in the late 70s. We learned how to screen for the disease in the late 70s. And you can see the death disparity for Blacks and whites got worse in the 80s and 90s. Death rate for Black women actually went up. We have started collecting data on the other groups in 1990. That's why there's nothing over to the left here. And you can see the disparity for breast cancer. But I really want you to appreciate, we learned how to screen and treat for the disease, and Black-white disparities went up. It's a socio-political phenomenon, and you can see that with a number of diseases, both in cancer and out of cancer. Now, we talked about the 40% decline in mortality in the United States, and I hinted at this earlier. The United States was a very homogeneous place in 1980 or so, and this is from 1988 onward. The purple states are the states that have had a 20 to 29% decline in mortality. The dark blue states, 41 to 51%. You see, I'm going to tell you one of the punchlines. For years, we've been talking about Black-white for disparity, but in the 21st century, we're going to start talking about Mississippi versus Massachusetts a lot. Where you live is going to define whether or not you suffer from disparities more and more into the 21st century. Race as a socio-political category will still be there. Rich, poor will be there. Rural, urban will be there. Now, one of my favorite slides, when I was at the National Cancer Institute in the 90s and the American Cancer Society in the teens, I had to deal with a lot of people who were hell-bent in advocating for breast cancer screening. Now, of the 45,000 or so women who die every year from breast cancer, the NCI has been able to figure out that of the 45,000, 10% or so, 9.5 to 11.3%, died because they did not follow accepted screening guidelines, or the mammography was misread, or they didn't get the mammogram, or what have you. 21 to 27% of the deaths occurred because people did not get adequate or appropriate treatment. The lack of treatment in the United States was 2 to 2.5 times more important a factor in death of women with breast cancer than failure to screen. One thing we need to do in cancer control is stop all these people saying, get a mammogram, get a mammogram. If they're going to say anything about screening, it's get into a program of high quality mammography, because quality is an issue for a lot of poor people. A lot of poor people get mammograms, but the quality is poor. A lot of people don't get mammograms, of course, as well, or they get into a one-off situation. High quality mammography involves the mammographer having the woman's mammogram from last year and the year before to compare. It's not one-offs. I hate mammogram vans, by the way, because most mammography done in mammogram vans are one-offs, and that by definition is giving the people who go to the mammogram van less than optimal care. We don't hear politicians say get adequate care, but they need to, and they need to do something to help people get adequate care as well. Colon cancer. These are the American Cancer Society numbers. They break out colon and rectal for incidence, and they combine colon and rectal when they talk about death. There has been a halving of the colorectal cancer death rate since the early 1980s. About the time John Carruthers decided to be a GI doc, death rates started going down. Now, screening is attributed to about 2/3 of that decline. This is the same thing I showed you in breast cancer, but now this is Black and white women. no difference in the 70s. We learn how to screen and treat. The disparity starts. The disparity now starting to close. This is the other three groups. This is for women. This is for men. Very similar patterns. In colorectal cancer, one can envision the disparities are starting to go away. One can see, I hate this analogy, the light at the end of the tunnel. Hopefully the light at the end of the tunnel is not a train coming toward you. Now, this is a slide that my epidemiologist prepared when I was at the American Cancer Society, and we prepared it in a effort to bolster the argument for the Affordable Care Act and for everyone having insurance. We don't care about universal insurance. We just want everyone to have insurance. This is 5-year survival statistics. It's rare I show 5-year survival because so often people misstate 5-year survival statistics. It's a statistic that's not well understood. But this is 5 years, 60 months on the x-axis. 0.6 is 60%, 0.8 is 80%, 0.9 is 90%. Stage 1 in red, stage 2 in blue. The solid lines are insured. The dotted lines are uninsured or people who were uninsured and got Medicaid after the diagnosis of colorectal cancer. They did not have Medicaid during the period of time when they should have been getting screening or during the period of time where they might have realized they had rectal bleeding or they had a problem in terms of the caliber of their stools or they had some kind of abdominal pain or symptom. They only got Medicaid after the diagnosis of colorectal cancer. So here you can see 5-year survival of stage 1 uninsured patients or people who got Medicaid after diagnosis. It's about 80%. 5-year survival of stage 2 insured patients is closer to 90%. I prepared this slide to show that insurance matters. At every stage, stage 1 or 2 here, and if I showed you 3 or 4 in those stages, the insured do better than the uninsured, even for stage 4. And in the United States of America, around 2010, you were more likely to be alive at 5 years if you had stage 2, the more advanced colorectal cancer with insurance, versus stage 1, the less advanced colorectal cancer without insurance. Now, I talked about 50% halving in the death rate since Dr. Carruthers went in the gastroenterology. The United States was very equal for death rate in 1980, but the purple states are the states that have had a 12 to 31% decline, and the dark blue states have had a 55 to 63% decline. Here we're now talking not just black, white, we're talking Mississippi, we can throw Louisiana and Alabama in there too, versus Massachusetts. Now, I mentioned earlier we have to be careful not to allow racial observations to become institutional racism. This is a study, it is an immaculate study, lots of words there. Let me just explain it very quickly. It showed that Blacks tended to have pathology not assessed as well as whites. And as a result, there were a lot of Blacks who are labeled stage 2 colorectal cancer, who, if properly assessed, would be labeled stage 3. And there's a lot of whites whose pathologist really spends a lot of time analyzing their pathology. And there's a lot of whites who just barely are called stage 3 because they have 1 out of 18 or 20 lymph nodes positive. And a lot of Blacks who are called stage 2 because they looked at 5 or 6 lymph nodes and all 5 or 6 were negative for cancer. Now, when we see a bunch of stage 2 Blacks relapsing, and they relapse at rates close to the rates of stage 3 whites, sometimes more than stage 3 whites, we start saying colorectal cancer is more aggressive in Blacks than whites. Now, the truth be told, I don't have the slide here, when we look at colorectal cancer in an equal access system, equal treatment yields equal outcome among equal patients. There's some little differences that can be talked about, but the problem is many Blacks don't get the surgery or don't get the drugs dosed appropriately or don't get the drugs at all. And that's the major reason for colorectal cancer disparities. Now, causes of colorectal cancer disparities are differences in all of these things, including quality of screening. It's not, do they get the screen? Do they get it well? It's, does the colonoscopist who screens the poor person or the Black person or the rural person, are they as gifted at doing colonoscopy or skilled at doing colonoscopy as the person who is wealthy? Differences in diagnostics and pathology, differences in the quality of surgery, and there are differences by race, socioeconomic status, and region of residence. Lung cancer. Here are the numbers from the American Cancer Society for lung cancer. And by the way, I don't show you 2020 data or because I have no idea what happened during the coronavirus epidemic. These are the numbers for men and women. About 154,000 deaths. This is lung cancer mortality. I showed you a slide from about 10 years ago. If I had gone 20 years ago, smoking by state, those same states are always red. That's where the highest amount of smoking is. And you can see California and Utah out here with very low lung cancer death rates. Here, we want to start talking more about disparities by state. The death rate in Utah, the death rate in Kentucky, 195 per 100,000 versus 125 per 100,000 per year. Now, this is all cancers, heavily driven by smoking in Kentucky and the fact that Mormons in Utah don't smoke. So heavily driven by smoking, heavily driven by lung cancer, but this is all cancers. State by state disparities. Lung cancer screening. This is the lung cancer screening trial. It was the first study to show that lung cancer screening with spiral CT saves lives. This was highly lauded. There had been studies of chest x-ray versus no chest x-ray that actually suggested, they didn't prove, suggested increased death rates in the people who got screened versus the people who didn't. 54,000 people at high risk because of age and smoking history and reasonable health, randomized to spiral CT versus a sham chest x-ray, done at 30 of the greatest hospitals in the world. Analysis 10 years from the start, 20% reduction in death rate in the people who got low dose CT. There were 350 deaths on the low dose CT arm and 437 deaths in the sham chest x-ray arm. 27,000 or so in each arm, 437 versus 350. Your 20% was that 87 who didn't die in the low dose CT arm. That's how you do those screening trials. Now, that was the New York Times headline. Let's unpeel the onion and go into what us nerds look at. For every 5.4 lives saved, 2 people got sent to an intensive care unit after evaluation of a spiral CT, and 1 person died within 60 days of that invasive procedure. 87 lives saved, 32 who went to an ICU, 16 who died. The study was done in 30 of the best hospitals in the United States. And so those of us who are screening experts, we worry, how's this going to play in Peoria? I shouldn't say Peoria, they have some good hospitals in Peoria, but how is this going to play in, mid-America? Results can be different at other facilities. One of the problems with this study is if screening were done at the quality in these 30 hospitals, instead of about 160, and it was done for all people who qualified for this screen, and was done throughout the entire United States, at the quality of those 30 hospitals, of the 160,000 Americans who die now, 8 to 10,000 per year would not die when we got to steady state, but 1,500 to 1,850 additional people would die as a result of invasive procedures. And by the way, of the people who died in the National Lung Cancer Screening Study, a third of them did not have cancer. They had false positive CT scans. Now, this has led 6 respected organizations to say that if someone has good spiral CT and good pulmonary medicine, including thoracic surgery, available to them, and they understand the risks and benefits, and they qualify for this test, they should get it if they want it. Somebody has to be informed decision-making is the key here. Indeed, Medicare will not pay for spiral CT screening for an eligible beneficiary unless they have been billed for a 1-hour counseling session that has to do with informed decision-making. Now, one of the problems with spiral CT, and this is one of our increasing problems with healthcare in the United States, is there's a lot of hospitals that are adopting spiral CT. There are hospitals that are adopting lung cancer screening, and they don't even have thoracic surgeons on staff to treat the lung cancers. There are hospital administrators that are thinking, I might be able to make some money off of this to defray other costs. And so they're sacking mammography screening programs and cervical cancer screening programs that can actually save lives in order to implement these sorts of programs. Very expensive, high resource intensive programs that take away from quality of care in other areas of the hospital. And sometimes the programs that are taken away are not cancer programs. Sometimes it's programs in teaching young mothers how to feed their babies or other things that can be useful. So how can we provide adequate high quality care to include preventive services to populations that often don't get them is one of the most important questions we can ask, including how not to give unnecessary care or even some necessary care that is high resource, which is going to rob the institution of abilities to provide care that is going to save more lives. And they're going to be increasing state by state disparities with the Affordable Care Act. Now, in keeping with my theme of maps of the United States, the orange states here are the states that have not expanded Medicaid. These are the states where adults age 18 to 65 still have difficulty getting insurance if they can't get it through their employer or pay out of pocket through the exchange. These are people who are starting to have more and more difficulty accessing high quality care. We have studies, indeed, the epidemiologists at the American Cancer Society have published a number of wonderful papers that unfortunately show that the early markers for mortality, the number of people who are getting screened for colorectal cancer, the number of people who are getting follow-up for an abnormal mammogram, the number of young women with cervical dysplasia who are getting surgery with the intention of preserving fertility, increasing in the blue states, not increasing in the orange states, and some orange states actually going down. The lack of Medicaid expansion in these states is increasing state by state disparities. Now we're going to finish off with a couple of slides looking at what the true cost of healthcare is in the United States. You know, we spend 20% of our economy on healthcare now, 19 to 20%. The other countries we compare ourselves to spend 10 to 12% of their economy on healthcare. Now, it is a fact, I showed you this a little bit from the smoking stuff earlier, that college-educated Americans have a much lower risk of cancer death compared to non-college educated Americans. This is true among all races and ethnicities. College education does something to lower one's risk of getting and dying from cancer. Now, it's estimated that about 600,000 people are going to die from cancer in a given year in the US. That's an American Cancer Society standard line. How many would die if every American had the risk of death of college-educated Americans? This is not giving a new treatment. This is not new research with a fantastic drug or breakthrough drug. This is just getting everybody what college-educated people get already. Whole spectrum: prevention, lower smoking rate, screening, appropriate screening, and appropriate workup of abnormal screens, and appropriate diagnosis, and appropriate treatment. Let's give them what college-educated get. Turns out 22% of that 600,000 would not die. 132,000 American lives would be saved if everybody got what college-educated people get. Think of that, 132,000. What breakthrough in American medicine has saved 132,000? Couple, maybe. Smallpox vaccine, maybe. All right, now, of that 132,000, who are they and where are they? Well, it turns out the majority, 80,000 of the 132,000, are white people. They live in every state in the United States. Their prevalence is higher in those southern orange states that I showed you, interestingly. You know, when I started in health disparities, it was called minority health. Then we started calling it special populations research because we realized there were some socio-political issues, and there was really socio-demographics had a lot to do with risk to cancer. And David Satcher started calling it disparities in health, trying to get politicians to invest. You know, it's kind of hard for a politician to say, I am against programs to reduce disparities in health. I am against equality. Not even today can you get politicians to say that. But we could save so many more lives. So the control of cancer should focus on prevention. And prevention really gets the short shaft. A lot of people are in the treat or screen and treat. Not enough people are in the prevention. Diet and exercise, alcohol avoidance, appropriate vaccination, and then getting optimal basic care to people, appropriate screening, appropriate treatment. Now, population disparities always increase when there's scientific progress in medicine. This was seen when there were improvements in screening and treatment for breast and colorectal cancer. I showed you that. It's occurring as we move into the era of precision medicine. Now, new preventive interventions are less likely to cause disparate outcomes, but we need to focus on all of those things. We need to focus on area of geographic origin and differences amongst populations, and we do need to study diversity amongst various populations. We need to keep an open mind and look for trends and look for differences, but many of the things that we see that we attribute to race are actually attributed to environmental factors that are caused partially by the socio-political definition of race. This is one of my favorite slides. There are some populations, as we strive for equity, who are going to need more than other populations to get where we all want. In some instances, the folks who need the 2 boxes are going to, or 2 crates, are going to be Appalachian whites. In some places, they're going to be Black Americans or Hispanics. And we need to look at every population, look at every disease, and figure out what the population needs to get where we want to go. I always like to end with this picture of the old Johns Hopkins Hospital. This is a wonderful place in history. Sir William Osler used to practice there. The hospital rooms are in a circle under the dome here. And Sir William Osler used to walk around and visit the patients every morning. And that's where the word rounds come from. We as doctors round in the morning because Sir William Osler used to walk around under the dome. And the young doctors who came to work with Sir William Osler, he gave them rooms up in the tower. And the nurses referred to them as residents of the tower. And that's where the word resident comes from in our training to this day. And so I just like to show that picture and show folks in medicine a little bit of where our roots come from. Thank you. It's been a wonderful opportunity to talk to you. I'm humbled by the honor. It's especially an honor to be introduced by somebody like John Carruthers, who, even though he's younger than me, I look up to.
Thank you, Dr. Brawley. That was a great talk, very comprehensive. And I think based on some of the comments in the chat that said you were spot on, a historical talk. So thank you, wonderful. We probably have time for one question. I have nothing in the QA right now, although someone asked one in the chat. What are your thoughts about pancreatic cancer and health disparities? You mentioned lung and colon and breast, so
yeah,
similar pattern.
Well, interestingly, even though I kind of hit doing black-white stuff, I still do black-white stuff because black-white matters sociopolitically. In Maryland, I just looked at this data last night. In Maryland, blacks in Maryland, Maryland's 30% black, by the way. It's one of the, it's highest proportion of blacks in a state other than the District of Columbia. The black death rate from pancreatic cancer is 80% of the death rate of whites. I don't know why.
Okay, that's
I don't know why. And so it moves around. You know, my personal view, and you're a GI doc, you can comment on this better than I. My personal view is that some pancreatic cancer is due to some environmental factors, some pollution. There's been a lot of talk recently about, does diabetes cause pancreatic cancer, or does pancreatic cancer cause diabetes? You know, about 1% of people who are diagnosed with diabetes are diagnosed with pancreatic cancer within the next 5 years. So I don't know. You know, I'm showing you my approach to every population difference. I'm always trying to figure out what the influences are that cause the disease and how those influences might differ by our accepted categorizations, be they race, gender for that matter, rich, poor, rural, urban. And so I'm starting to lapse into giving you a Washington answer, so I'll stop.
Well, I'm going to give you one last question. This will be our last question. It's in the Q&A. You mentioned several things about the importance of screening and then quality of tests, you know, the quality of colonoscopy, the quality of mammograms, et cetera. So this person asks, does provider attitude have an impact? So the attitude of the provider have impact on quality of tests performed, and does that quality impact the results?
I suspect the answer to that question is yes. Now, in the case of mammography, keep in mind the mammographer very rarely even sees the patient who's getting the screening mammogram. And, you know, I'm talking about the attitude back there in the dark room while they're looking at all the film. Actually, the film there's no more film. They're all on video screen now. My suspicion is that there are some providers who don't try as hard as they should. And sometimes they don't try as hard as they should because they're overworked. You know, the pathology example that I gave was correlated with Black people tend to get their care in hospitals where the pathologist has 6 cases a day to deal with, and white people tend to get their care in hospitals where the pathologist has 1 or 2 cases per day.
Yeah.
And it was the pathologist is overworked because, by the way, little tidbit of unknown, 80% of Black people get their care in 15% of the hospitals in the United States.
Yeah. Yeah. So thank you, Dr. Brawley. I'll just say that, even within the field of GI, there are times of the day, for instance, the morning is better, and you have higher adenoma detection rates in the morning versus like in the afternoon. It's kind of interesting. And so sometimes the timing of your appointment may make a difference in addition to the person's attitude. Well, I want to thank you for a wonderful and powerful talk. And thank you for the breadth of your knowledge and the disbursement of information in regards to multiple cancers here. So I really want to thank you for a wonderful talk, Lotus.
My pleasure. My pleasure.
Okay. All right, Laura. We can go to the next segment.
Yes. Okay. Thank you, Dr. Carruthers, Dr. Brawley.
Thank you. It was wonderful to talk.
Thank you both. Yes, thank you very much for a wonderful keynote speech. Okay, so we are up now to the section for the AI and machine learning, and it's a pleasure to introduce Dr. Shiva Kumar Vignesh. He's Associate Professor and Chief of the Division of Gastroenterology at SUNY Downstate. Before coming here, he had some spectacular education. He came from India after distinction from his high school and medical school, came to Robert Wood Johnson Hospital for internal medicine residency training. After that, he did his fellowship at the Albert Einstein in Jefferson University in Philadelphia for GI fellowship. And after that, he went to Yale for his advanced endoscopy training, which is spectacular. And then he went to Medical University of South Carolina for his, endoscopic ultrasound training for GI. So this made him one of the highly sought advanced gastroenterologists in our area. I got to know him through one of our former GI chiefs, and we tried so hard, but finally he came to Downstate. And so he's been leading all the advanced techniques in GI. Basically, he does everything advanced. He's like a minimally invasive surgeon. We're so proud of the work he does. He's very nationally known. He participates in all these endoscopy training courses around the country. He's very passionate about endoscopy training and the quality of endoscopy training. And he's part of panels around the country to do that. And some of them have actually been international panels to teach how to do high quality endoscopy, and we're so proud of that. Anyway, today he's going to be moderating the session. So please join me in thanking him and welcome him to the session.
Thank you, Dr. Salifu. Can all of you hear me well?
Yes.
That was a very kind introduction. And I want to thank all of our speakers and organizers. So far, I've really enjoyed the conference and I've learned a lot. So hopefully you're all enjoying the conference too. I'm quite excited to be part of the 6th Annual Healthcare Disparity Symposium, which is a nice collaborative effort between SUNY Downstate, Stony Brook, and Cold Spring Harbor Laboratory. As you all are well aware, March is Colorectal Cancer Awareness Month, and racial and ethnic disparities continue to exist in this disease, and this is a very timely conference. I'm a gastroenterologist with a strong interest in GI cancers, and so this is very close to my heart. I'm very excited to be able to moderate our next session, which I believe is the future of healthcare. This is going to focus on machine learning and artificial intelligence, or AI as it is popularly known. So what is the role of AI and machine learning, and why is it relevant to us? You'll be surprised to hear that there's been a lot of work on the role of AI, not only in medicine, but within gastroenterology. And we have some excellent speakers who are going to shed light on their work and as it relates to GI cancers, and hopefully, there's some work that translates to solving our healthcare disparities. So briefly, for those of you who wonder, like me, what exactly is machine learning and AI? AI, basically, the simplest way to put it, involves computer programs that perform functions we typically associate with human intelligence, such as learning and problem solving. And machine learning involves more computer science and statistics, where a machine performs multiple iterations of models and specifically focused on performance of a task. It produces algorithms that analyze data and comes up with predictive models. And then you have deep learning, which is based on more complex neural networks. And this term was frankly new to me. Convolutional neural network is a deep learning model that has actually been studied in GI for simple things such as image analysis of endoscopic images. And there are some good studies that have shown that it improves polyp detection. So this has already been demonstrated to improve detection of polyps. So it's very, very relevant to us, very relevant to cancer screening. And many predict that AI is going to completely transform the healthcare landscape, all the way from access, hopefully improve or reduce disparities, and then of course improve diagnosis, and then all the way to the other end, treatment, predicting response to treatment and prognosis. So in this session, we're going to have 3 speakers. I'm excited to introduce our first speaker, Dr. Zhufeng Wang, who's from the Moffitt Cancer Center and Research Institute, where I used to work 6 years ago, 6.5 years ago, and I was there for about 6 years. So it's great to welcome you. Dr. Wang is currently an associate faculty member in the Department of Biostatistics and Bioinformatics, and a member of the Immunology Oncology program at Moffitt Cancer Center. His interests include biostatistics, statistical genomics, and computational biology. And his group is working on machine learning methods such as deep learning, kernel learning, and they analyze data in genomics, drug development, and personalized medicine to improve and focused on survival in cancer. He's involved in a variety of collaborative research projects in cancer immunology, epidemiology, and specifically cancer disparity research. And today he'll be speaking to us on statistical and machine learning approaches to dissect socioeconomic disparities among head and neck cancer patients. Dr. Wang, thank you for speaking to us today, and we look forward to hearing your talk.
Thank you for the introduction. Can you hear me very well?
Yes, we can hear you.
Great. Thanks for the introduction, and it's my pleasure to be here. And it's really a wonderful symposium, especially I learned a lot from our keynote speaker. So today I'm going to talk about a recent effort in applying statistical and machine learning method to dissect healthcare disparity in head and neck cancer, which is really switching gear from GI cancer. So it is joint work with Dr. Cruz et al. He is a physician scientist in the area of head and neck. And my expertise before doing this project is more in the molecular genomics and population area. And this is actually my first project working in socioeconomic factors. And I definitely learned a lot from Dr. Patel, and also learned a lot from our keynote speaker today. And so I have nothing to disclose. I don't need to educate this audience about this unmet needs for health disparity in this country, and in particular in Florida state. And we have a huge population, of course, and because of that, Moffitt Cancer Center is third largest cancer center in terms of patient volume. And we have a lot of big proportion of Black and Hispanic population as well. But unfortunately, we are not doing a good job in health disparity research. That's why we want to expand more efforts into the area. And particularly head and neck cancer is one of the important cancer in our catchment area. So there's a lot of efforts going on at the Moffitt Cancer Center, and this is part of the effort. So again, as I mentioned, my area before was more in the molecular part, because I worked with a lot of investigators, even in this audience, in GI. We look into the methylation, gene expression, and look into the disparity between racial groups. But until I worked with, in this project, I realized there are actually more disparity from for all areas is multi-faceted research, and translated into statistics is multidimensional. There's disparity in cancer treatment, surgery, and there's different access to clinical trials, and of course, social determinant factors. I think is totally understudied in the area of head and neck cancer. And compared to other common cancers like colon cancer, breast cancer, head and neck cancer is relatively rare. It is only 9th most common cancer in this country, but it is a tough disease. So the 5-year survival rate is still less than 50%. And looking into the history, this survival rate hasn't been improved for the past decade. So there are traditional risk factors, including smoking, alcohol, and HPV, like that. And also there, in this, in the Florida state, in the Moffitt-Kitchener area, it is understudied, and we are expanding our research effort in this area. So this project is only part of our big effort. This talk, we're going to later focus on that health disparity factors contribute to the survival outcome. And we're more focused on the socioeconomic. It's kind of hybrid or hypothesis-driven and a data-driven approach. We're interested in race factors, insurance that I didn't know before. And again, I learned a lot from keynote speaker about that factors. I have slides for, only have one slide for that. I learned that insurance is by reviewing head and neck cancer data set, especially the Medicare expansion after ACA, it is this definitely increased access, but also there is actually there's a non-expansion state and expansion state, and it actually exacerbate, even increase disparity in terms of regional level. And when we look in the data from in the context of state and different states, we also see there is very widely in terms of insurance coverage. And the question is, how can we do our research and think of disparity? As I'm not the epidemiologist in the disparity, I'm more interested in how can we take into consideration all these factors into other research like biomarker discovery, which is my area. And of course, the race is the important factor. And on the left panel, as shown here, is I'm more familiar with. This is showing the heat map is methylation biomarker, more race relevant methylation biomarker, and the red one is hypomethylation, and the yellow one is hypomethylation. As I can show here, head and neck cancer share a lot of methylation factor, even with UAD. They share some epigenetic factors, but also we have a separate project working on head and neck cancer. We're looking for specific factors, including methylation and gene expression level biomarker that are more specific to the prognosis of head and neck cancer. And also we have two big groups, HPV positive and HPV negative patients have totally different immune background. So we always separate them in our analysis. And on the right panel, this is our start based on the preliminary analysis based on SEER and ACDB. Head and neck is ranked third in terms of hazard ratio for the risk factors. So this is only marginal. That's a starting point for discussion. This is just not a ranking of how the risk is more important in this cancer. It's just by a statistical model, by hazard ratio, marginally ignoring our factors. This, by our eyes, this is ranked number third. And then our method is really focused on a deep analysis on NCDB, also covered very well in the keynote speak. National Cancer Database is one of the largest clinical oncology database so far, and it captures approximately 70%, which is amazing, all the cancer diagnosis. And even for head and neck, which is a relatively rare cancer, we already collect more than 400,000 patients from 2004, 2013, and with all the follow-ups, and which is, I think it's an amazing data set. Previously in my area, my experience with TCGA, we always play with like hundreds of patients, and we're always underpowered to detect any vectors. That's one of the reasons we, in other molecular biomarker discovery, we tend to use hypothesis-driven, because I'm a statistician. I know each features you want to include in the model, you need a 10 degree freedom, which means that you need a 10 sample size. If you have 10 biomarkers, you need 100 sample size. But in reality, we don't have that much. So, but that's one of the motivation I want to apply machine learning method, because machine learning is really data hungry, including deep learning. And with limited sample size, probably you won't doing a better job than even simple linear regression or logistic regression. So this huge sample size really give us opportunity to do a top-down discovery based on machine learning method. And like other machine learning people, before that, we always, this is almost like a figure one in any publication for racial disparity. We look at the Kaplan-Meier plot comparing different racial groups, and you can see that apparently the red line is Black group and has a much worse survival marginally. And interestingly, Hispanic patient has only relatively better survival, which is in the long run. Actually, we look at the short-term survival, it is similar, but still Black patient group has worse survival. But the next step, as a statistician, we would always do a nature extension. We would ask if this is marginal, what will happen if we put that into multivariable Cox regression by adjusting all clinical covariates? So given this huge sample size, my intuition was there must be significant, because I know that p-value doesn't mean anything. If you have like 500,000 patient sample size, any factor can be, you should have significant p-value. But what shocks me is that no, in some models, race factor is not significant. That totally depends on how many features you throw into your model. That's really a discussion point. I think we can come back. So we all start out with this black box. Actually, black box actually we're trying to turn into gray box. So black box method is, we all start out from, we find out the import, and import is, we focus on NCDB, all the head and neck cancer we curated from a database. And then output is a predictive model, and we're trying to validate on the validation data set. And my lab has been working in this area for a couple of years with 2 PhD students from Stony Brook University. They are graduated now. And one challenge is in the machine learning toolbox, most of the method has been developed for binary outcome. So it's 0, 1, dogs, cats. It is not really well developed for survival outcome. And some people, in order to apply machine learning method, they dichotomize survival outcome into binary. Like it's more, sometimes they use a milestone, but most people just use arbitrary cutoff point, which is not very good. And also, that means you have to ignore censorship, which will introduce bias into your model. So we have been working in this area by extend and also more rigorous testing the statistical property or adding the survival model. And by integrating in this paper, we are close to publication that we are trying to combine survival model, including Cox model and AFT, which is the 2 commonly used method in both model and survival model, with XGBoost, Latitude, which are very latest advancement in the gradient boosting, which is always win all this data science competition. And this is the basic idea is based on ensemble tree. It is like ensemble learning that you combine the weak learner become a very stronger learner. And it is like there are a lot of small decision tree or like committee members. Each committee member give you answer, and we combine it with make decision for a final decision. So by that, we have a better prediction. But again, in this tree, we're not only looking at the binary, we are taking into consideration the survival outcome, which is a major contribution of all this effort. And we call it XServe because it's part of it comes from the XGBoost, and also Marcin told me that because my first name started with X, we want to torture people with this pronunciation. They don't know how to pronounce my first name with X, which is very common in Chinese names. So this is actually a bad example, but it's a good bad example of the typical results. And this literally the results I sent to Dr. Patel once I get results, which shows the importance, which is the only output of the by tuning of this predictive model from gradient boosting. You get an important score from all the features you show in the model. And although in many publications, you will see the data plotted like in this plot, ranked by importance score. So, but that's pretty much it. You don't have other further information. Only you know that they are ranked by the feature ranked by importance score. And that is what machine learning designed for, was for prediction. So you can find a very good predictor. But as we know, for example, we are interested in racial disparity. If you look at these top predictors, it's age, it's insurance, and again, it's another bad example, good bad example about I'm using the code name, not using the real name, because a part of the name was we're following convention from NCDB, so we don't want to change the name. And there's another name added by my student. This is a better example, but since it's a very complicated analysis, we have been keeping using this convention for a while to be just simple. So you can see that the age insurance is huge, which is also shocked me because I didn't know that insurance can be that big predictor in the top. But when you look at the rates here, race is really in the middle here. So it looks like the rate is not top predictor. And compared with other data sets, it is very common that it is almost consistent that it's not top predictor, but we know that it's an important factor to how can we put into the context of interpreting machine learning model. That is another discussion point. So again, go back to our model. In order trying to make it more gray or transparent, we also we have another function in our package that we can make the results more friendly to physicians that are more familiar with decision tree, because that's how physicians give predict prognosis. By they do this tree kind of determination. They first determine by the grade and the all kind of clinical factors, and then they assign patient into different subgroups. And by feeding all these important top features trained from our X survive, and we got this decision tree based on recursive precision learning. And interestingly, the insurance factor, it is the top one in very top. So this method really just separated patients into two groups by private insurance and non-private and non-insurance people. And then they further divide people into by T stage in TNM, and another group they think that analytical stage is more informative. And then interestingly, they also separate patients by stage 1 and 2, and here it's by T1, T2. And then we got this subgroup. Again, this is really data driven. So in reality, we wouldn't do something like that. We will, when you keep growing the tree, that is another step after we feed in the tree is that if you wanted more better feeding, or if you want to put variables, we call it growing the tree, and you put more, you will see a bigger tree. In here, the model picks age as the next factor that can more informative in separating patient into different prognostic group. And you can see here that it's almost ranked very well from patient group with very good survival and to very bad survival by age here. And again, the caveat is that if it didn't do the XG boost or light GBM before, just feeding the this tree using all variables, you will introduce feeding very well, because as you can see here, you can arbitrarily introduce some cutoff point to get give you the optimal results, but it will be most times it's very hard to validate. And in reality, we would use a more, for example, in these two groups, I would use a similar cutoff instead of 78, 76 here. I would use something more consistent to overcome the overfeeding. So how can we interpret the race disparity in this context is we cannot even keep growing the tree. Again, race is not top predictor. So, but we can really interpret in the context of the subgroups by looking at in the beginning, we have figure 1, then this can be read out figure 2, is if we look at all these different subgroup population within these subgroups, we can have a better insight how the ratio can be different per different rule. For example, in group 1, in subgroup 1, Black people still have the worst survival compared to Hispanic and white people group. And interestingly, in group 3, it's very interesting that Black people and Hispanic is actually doing much better compared to other 2 groups. And in group 2 and 4, is more separate. Again, this is it's very relative. It's not doesn't mean that Hispanic has better survival. It's only relative. It's still a tough disease. The median survival, 5-year survival rate, it is still less than 50%. I'm going a little bit, in interest of time, I'm going a little bit fast. If I have time, I can go back to this interesting plot because there can be a lot of interpretation when you look at this plot, especially how can we, especially for insurance, and there's other location factors we haven't considered. So actually, we have a more comprehensive analysis by considering all other socioeconomic, socio-political factors. But here we only focus on the top factors. So we can have enable this top-down approach. But if you have any hypothesis, actually we do have some hypotheses, we can do the bottom-up approach by combining these factors. But what is the point of machine learning is we hope that we can leverage the huge data set, let a machine learn what's the most important predictor for us, right? So that is, we have to combine these 2 steps together. So again, in order to increase interpretation of our results, one thing we did further in our toolbox in the XServe is that we added we modified the shape plot, which is important score, more informative for the contribution from each feature. So if you're familiar with, like for survival, we usually do Cox model, and in most publication, we will do the forest plot by plots the hazard ratio. We will rank the hazard ratio. You can see the forest plot from top to bottom. But if you do the gradient boosting, you won't see something like that because first of all, there's no p-value for machine learning. There's no effect size for machine learning. But we're trying to mimic that we can do that by the shape plot. All this showing which is the density and distribution of you can think about it as the effect size for each observation. And by this pattern, you can say relatively know better than important score which one is more important in predicting the outcome. So I'm going to skip that because this is really I'm only going to show the idea, but the real interpretation is more involved. The machine learning has a very good advantage in my ways. If you check this plot here, there's some gray dots there. There are missing values. Although we have a huge data set, but there's missing little values here and there. If you only want to apply the traditional method, you have to either impute or just exclude them. Because let's say you want to include all the features into the model, you can only use the observation. They have 4 observations in all these features. So you will exclude a lot of patients, but actually, again, this is missing the here and there. So what machine learning method can really leverage all this non-missingness. So what about interaction? Actually, machine learning is also good for, actually, in the very beginning, we think that machine learning complement traditional method by traditional, let's say, Cox model, you can only look at the linear effect. So by looking at the tree, it actually implicitly incorporates the interaction effect into account. But unfortunately, you cannot visualize that interaction effect generated by a machine learning method. So we can still rely on the traditional method. So a very long time ago, this is my PhD work with my PhD advisor 10 years ago. We proposed this idea to interpret. This is not a new, this is old pattern, but we're trying to we don't have a name before, but now we call it divide and conquer method. It looks like in recent years, it has been used in many applications, including, for example, here in this paper, they use this similar concept to find a biomarker that can have interaction in fact with immune condition. Here is in myeloma. The example given here is TGF-beta1. We know TGF-beta1 is inhibiting the immune function. So if you don't have, forget the TGF, if this for TGF-beta low, you can see that like tumors with higher immune ability have better survival, or immune features have better survival. But interestingly, in the TGF-beta low group, high group, that you don't see the separation of survival anymore. So that is a factor we are very interested in. We want to see which factors are really inhibiting the immune condition and which factors are really in boosting. It's similar to antagonistic and synergistic effect. And we put that concept in the survival model, we actually can use strategic model testing the interaction effect by just doing the Cox model, by just doing interaction effect. If the interaction effect is significant, we can do for the modeling interpretation. And we're not doing this, it is more hypothesis driven. We already get some machine learning predictors and we put that into the picture and see which one is more important. But instead of looking at the immune, which ones have interaction with the immune condition, we're using this similar concept to look at which factor can have interaction with risk factors. And we don't have time to go into that details, but I only show the results here by applying that divide and conquer concept into the NCDB head and neck cancer. And we plot all the significant interaction, in fact, in this circles plot. And there's a lot of interesting, two very dominant observation is that, first of all these links here shows this significant interaction effect between factors, so between two factors. Here I plotted the Hispanic and Black. I use the Y group as the reference. So that's why we only have two groups here. And if you see a link here, it means the interaction effect is significant. And the weights, the band weights represent the effect size. And you can see that here there's a big interaction effect between sex and Black patient group, but not with Hispanic patient group. Here, again, we only look at the positive interaction because we're more interested in this synergistic, which is almost like double kill. So if you have two factors, you combine, they have a worse survival. So the gender, which if it's male, it have much worse survival for Black patient. But for Hispanic, interestingly, it's not with sex, but with age. So older patient, we have worse survival in Hispanic. This is like interactome plot we got. And of course, we have been looking at all other factors, socioeconomic. There's a facility location. There's a lot of interesting interaction with facility location and other factors. I don't have time to go into the details, but this is just an example. But of course, you will see a lot of interaction with clinical covariates, which is true. And we have tons of next steps going on. We will hope to also examine the short-term survival outcomes. We want to include other important covariates in the model, and we can use this model to mimic intervention effects. And for head and neck cancer, we are looking to the next using if the sample size is huge, we can look into the subsize like an oral cavity because we found two different results in terms of top predictors. And then finally, we're going to validate it on the CL database. So in terms of lesson and conclusion, first of all, I think this set of methodologies is useful, and it will give us insights into high risk population and target intervention targets for policymakers. And we can also look at, for my own interest, we can look at the molecular biomarker in the context of these subgroups. And then in terms of AI machine learning, I think I would argue that we could separate model training and model interpretation. Model training is machine learning method has a better advantage in that area, but we can integrate them both together. They can complement to each other. And then traditional method is still, I think, still useful. And as statistician, the final advice is that don't be discouraged if your risk factor is not significant. First of all, you can look into the interaction effect. You can look into other factors that might encapsulate the racial factors into that. So in statistics, if it's significant in the multivariable, it means that it is independent covariate. But actually, no, we know that race is not independent covariate. It is highly closely correlated with other factors, right? So, and finally, remember that our ultimate mission here is to reduce and to remove racial disparity. So that the non-significant model also give us insight into how we can remove disparity. So with that, I want to thank you all for your attention, and because this is a very integrative science, I'm looking forward to our collaboration with people from different expertise. Like I learned a lot from Dr. Patel in this area, and also for trainees who are interested in using quantitative method, I have a postdoc position opening in my lab immediately. So if you are interested, please email me. This is my email address. Thank you.
Thank you, Dr. Wang. That was a very interesting talk. And I just wanted to remind the attendees, the audience, to hold on to your questions for the panel discussion. And we will attempt to answer all of them if you type it in the chat box. It's my pleasure to introduce our next speaker, Dr. Olivier Elemento, who's professor and director of the Carroll and Israel Englander Institute for Precision Medicine at Weill Cornell Medicine. The Englanders Institute mission is to use genomics, AI, and other technologies to bring highly personalized medicine to patients at the New York Presbyterian Hospital. And the goal is to foster patient-centric basic and clinical research, again, in the areas of genomics, systems biology, AI, and data science. Dr. Elemento is funded by numerous NIH and other grants and published over 280 papers in these areas that I just mentioned. He's won innumerable awards. He's mentored several graduate students, postdoc fellows, many of whom have gone on to have very successful academic careers. He'll be speaking to us today on the potential and pitfalls of AI for overcoming cancer disparities. It's almost kind of laser focused on our theme today. Dr. Elemento, we really look forward to your talk today. Thank you.
Thank you so much. Thank you for having me today. It's a pleasure to be here. I think we're running a bit late, so I'm gonna just jump right in. I'm hoping that you can see my slides. Let me know otherwise, and I'm hoping that you can hear me. These are my disclosures. I'm gonna go fast on this. I have some potential conflict related to some of the things I'm gonna talk about today, but this is all disclosed, and there's one slide here. So I'm gonna talk about some of the work we're doing at Cornell. We're actually doing quite a bit of work in the area of AI and machine learning. A lot of it is applied to cancer. And we are very much aware that there's great issues of disparities in terms of medicine, and we are trying to address them using these tools. Precision medicine is using AI as part of what it does. It's a fundamental pillar of, if you want, of precision medicine. But genomics is also very important for what we do. So this talk is also going to include quite a bit of information about genomics. You may wonder what exactly is the definition of precision medicine, and I think there are different definitions depending on who you ask. My own definition is that essentially it's a way to enable a more personalized medicine driven by technology. Medicine has always been personalized, but with technology such as sequencing, which you see on the left, such as AI and machine learning that you see on the right, we can make medicine much more personalized than what it's been in the past. There are opportunities in that goal to bring essentially a more efficient medicine, but there are also risks, and one of them is to increase disparities, and that's something that we keep in mind and we want to address sort of head on. I want to remind everyone that precision medicine is indeed the ability to individualize medicine, but it is based on the fundamental idea, which is that we can learn from many, we learn from very large cohorts, like the ones I'm going to talk about today, and we apply what we learn to each individuals. So there's really a fundamental idea of learning from large cohorts in application to one. And that's going to come back in the next few slides. From a practical standpoint here at Cornell, the way we deliver precision medicine is through, for example, if it's applicable to cancer, and we do this across all kinds of disease, but if it's applicable to cancer, what we do is do biopsies of cancer patients. We extract the DNA, the RNA from these from the tumor cells, and we sequence the genes and sequence the entire genome of these cancer cells, and we compare that to the normal genome from the same person. That allows us to create a report that contains all of the mutations that are found in each individual patient's tumors. And this is what it looks like here. It's like essentially a multi-page type of report that has, mutations that are found within individual patients. And two patients with the same type of cancer, for example, two patients with breast cancer, will actually, typically have a very different report. The mutations that we'll see in each individual patient will be very different. And that is the driver for personalized medicine, because the different mutations cause cancer in different patients. We have to tailor the treatment to the mutations that we find in each individual patient. That's a fundamental tenet of precision medicine. And this is working really well. These are examples of where precision medicine has been very helpful. We scan the entire genome. This is a patient here with bladder cancer, metastatic bladder cancer, scan the entire genome, find interesting mutations. Some of these mutations can be targeted using existing drugs, not always the drugs that have been approved for this particular disease. They may have been approved to target this mutation in a different disease, but using off-label prescriptions or using other approaches, we can sometimes give these drugs to those patients. And this is an example here where it's been working in a wonderful way. This patient here, as a result of having a genome scan, as a result of finding an unexpected mutation, got a treatment that was tailored to that patient's genes. And worked really well, as you can see on the right side, was able to obliterate the tumors that were found before the sequencing. And that's the same, just an example here, how we found the same kind of mutation in a patient with a different disease, a different type of cancer, but also responded exactly to the Herceptin, the drug that I was telling you earlier, because of the presence of that mutation and because that patient's tumor was driven by this mutation. So an example also about how we're starting to think about cancer, which is not so much about where it is found in the body, but actually more about what kind of mutation is actually driving the cancer. And that's a fundamental principle. I just want to say again, we are like trying to be as sort of creative as possible when it comes to delivering precision medicine. Another approach we're taking is to take patient tumor cells, to grow them in a dish, and to make a lot of mini tumors. That's what you see on the right side here for each individual patient. Once we have this, we can use robotics as a way to test different drugs in each of the tumors that we grow in the dish. We can do this for all kinds of tumor types now. We've done this for about 21 different tumor types. These are examples here on the left side of melanoma organoids, just examples, but on the right side, you see results that you get from another type of cancer, endometrial cancer. Now, again, we can do this across the board. And we have a robotic system that allows us to test different drugs on each individual patient using the patient's cells and essentially find, what each patient is going to respond to using this ex vivo system. So that's a wonderful approach because in my view, I think it really has actually the potential to maybe lead or give rise to a more equal medicine because it doesn't make any assumptions a priori about what kind of treatment or drugs is likely to work in a particular patients and in a particular group of patients. So I think this is essentially kind of an empirical approach to finding out, what is likely to work. And I think in my view, if it were to be deployed at scale, may have the potential to offset some of the issues that we've been seeing in terms of response to treatments. One of the issues fundamentally is that some treatments are tested in one particular population. The efficacy is well known in the population, but may actually differ in a different population. And so by doing this empirical testing here, we have the potential to maybe help mitigate some of these issues. We're thinking about this kind of technology here as allowing us to do almost a mini clinical trial of 1,000 different drugs, if you want, the combinations for each individual patient. So that allows us to find a lot of potential options. So that's just to give you a sense of some of the things that we're doing, but I want to tell you more about the machine learning projects that we have. We have been embarking into multiple projects actually to try to find out whether we can use machine learning as a way to predict who is at risk of developing cancers. And we've been doing this across multiple types of cancers, as you will see. We're leveraging very large cohorts to do this. The largest cohort that's available to us is a cohort that's called the UK Biobank. This is an amazing cohort that's available from the UK, where 500,000 people have been enrolled into this cohort. There's genomic information about these patients. We know, quite a bit about their life, what happened to their life, to their care, what kind of disease they got. For example, we know that many of these patients at some point got cancer, because it's a longitudinal cohort. We know everything that happened, to some extent before they got cancer. So it's a nice opportunity to understand what are the factors that may contribute to predicting who's at risk of developing cancer based on all these measurements that are done on these patients. So I'm gonna show you some models that we're developing. I do want to highlight something that's fundamental in machine learning that I think you may have heard about. I just want to reiterate the importance of this. This is the area under the curve. This is how we measure the performance of a machine learning classifier. This is essentially looking at this area here under the curve. Essentially, it's looking at the trade-off between the sensitivity of a machine learning model and the specificity of a model. The trade-off between true positives and false positives. And the idea is that if you have an AUC, an area under the curve that's 1, it means that you have a perfect classifier, perfect sensitivity, perfect specificity, the ideal classifier. But obviously doesn't happen very often in the field. But this is how we measure the performance of classifiers. So that's going to come back a few times in the next few slides. So this slide here is the work of Cl Lim, a grad student in my group, who's been applying machine learning models. Some of them are simple, some of them are complex, to the UK Biobank with the specific goal of predicting who is at risk of developing cancers. And as you can see here, we looked at multiple types of cancers. And this is a number of cases that we had in the UK Biobank. You see that's typically a few thousand cases, lots of controls who didn't get this kind of cancer. And the most important column here of data, so I'm sorry, this is a lot of information here, but the most important column is this column here, which is the performance of the classifiers that we built using 10 features in UK Biobank and our ability to predict who's going to get some of these cancers. So as you can see, this AUC varies quite a bit between people, between cancers. Bladder cancer is just an example of a cancer that's actually quite predictable. This is a very good AUC, very close to 1. Some other cancers, are less predictable, but this, just gives you a sense. Now we looked at what are the features that are predictive of what are the reasons why these classifiers are so predictive, and there's a variety of different sort of reasons. And just before we get to this, so this slide is actually about making the case that machine learning is actually able to improve how we predict cancer over existing models. So there's a well-known model called Q cancer that's been trained on lots and lots of different people as well. As we can see here, and this is the red line here, the machine learning models that we built, which are the other ones here, are typically more performant than these existing models that are very simple. So machine learning is actually helpful in terms of predicting cancers. But one of the things that we see, and you see that also in this comparison with Q cancer. But one of the things that we see is that very complex machine learning models, such as XGB, this is a gradient boosting type of model, is actually frequently not actually adding much in terms of productivity compared to the very simple linear models that we also use in the same study. So machine learning can help predict cancer, but it doesn't necessarily help to have a very complex type of machine learning sort of type of model. This was the feature analysis that I was telling you about. This is looking at what kind of features are helpful. There are different types of features that we use as part of these predictive models. Some of them are coming from questionnaires, some of them are coming from the medical record, some of them are coming from measurements, test results, if you want. Some of them are coming from the census, and there are additional things like genetics that are also helpful. And as you can see, some features actually, there's a broad variability in terms of what features are very helpful in terms of prediction. For example, in prostate cancer, some of the previous medical condition that the patient has were actually quite helpful. But for example, sort of measurements, that are obtained from patients are not as helpful. So there's really, broad sort of a broad sense. These are interactions between features. I'm going to skip this. And this is just showing the difference in importance of features depending on the complex versus simple models. So one of the things that we are very interested in general is, the extent to which genetics is helpful in terms of prediction of disease risk. As I told you earlier, we are using genetics in some of these models here. But this is a very important sort of question, right? The extent to which genetic analysis of patients is helpful in terms of prediction of disease risk. We've done an analysis that's not only focused on cancer, that's actually applied to 23 different types of disease, but is showing very broadly and without any ambiguity that in most disease, adding a genetic component to these machine learning models, to the scores that I showed you so far, is actually helpful in terms of improving our ability to predict disease risks. So that's, I think, a very conclusive, sort of approach. But the last slide that I want to show before concluding is this. We've been looking at the performance of these scores in different groups. And I think that's a very important slide. So here, this is comparing males versus females. Are we able to predict this disease equally well in males and in females? And as you can see here, the answer is basically no. There are certain situations where we have a better AUC in females versus males, and sometimes you have the reverse. But there's actually quite a bit of variability in terms of our ability to predict risks in different groups. This is comparing old versus young people. Likewise, quite a bit of difference. This is comparing higher versus lower income. Quite a bit of difference in terms of predictive model accuracy. And this is looking at sort of the density of population. One important plot is this one here. It's our ability to predict risk disease in different populations that are characterized by different ancestry. And we're comparing British ancestry, this is coming from UK Biobank, to, for example, African ancestry, Asian ancestry, and other European ancestry. And as you can see, there's actually quite a bit of difference, right? For example, in, let's say, we can look at prostate cancer, right? For example, here, our ability to predict prostate cancer is actually substantially lower in Africans or people of African ancestry compared to the other groups. So again, I think this is an important slide, and something that is important to keep in mind is that we have to test the accuracy of these models in different groups, whether it's different populations, different genders, different strata. So that we understand, ahead of time, upfront, the performance of these models. And I think this is something that is probably not done enough and really needs to be emphasized, very importantly. My last slide is really about, again, emphasizing the risks and the opportunities for precision medicine in addressing cancer disparities. I think there are some fundamental risks. The ones that I haven't, I guess, touched upon too much, but I guess you got a sense from UK Biobank, which is primarily Caucasian, is that very often the data that's used to train machine learning models is very biased towards one particular group. And the idea is that if it's trained on a particular group, it's not likely to generalize very well to other groups, and that's something that is fundamental. Biases in data can't be avoided. I think really the important message here is that biases always exist, and I show you a bit of that in the previous slide in terms of accuracy of classifiers or predictive models in different groups. But what we need to know is what biases exist. Ideally, we'd be able to compensate for these biases, and the validation of predictive models in different groups, different populations is really absolutely fundamental and not done enough. There's a fundamental issue in terms of precision medicine and genomic medicine, especially, is access. A lot of hospitals, for example, in the community setting, do not have access to the technologies, to the knowledge that is required, for example, to be able to use some of the genomic tools that I talked about at the beginning. That's a major issue that also is really important to address. But honestly, there are also some major opportunities, right? I mean, in my view, by focusing on causal mechanisms of disease, right, the concept of precision medicine should help improve response rates. I think what I showed you about tumor organoids, where we can test empirically all kinds of different therapies without making any assumptions ahead of time, and see what works and what doesn't on each individual patient, in theory, there's a chance that this could down the line also help address some disparities, in terms of where certain treatments have been tested and or less tested. And I think the last point is that there's a major opportunity in terms of precision public health, which is essentially applying precision medicine not to individuals, but to populations. Because now using data science, using some of the tools that I showed you, machine learning, for example, we can identify disparities at the population level, by capturing information from, populations, from, questionnaires, and census, and so on. So that allows us to potentially understand the causes of disparities, and therefore potentially to tailor interventions at the population level towards these populations. And I think, again, this is something that, especially with COVID, in my view, is going to really have a great potential to be able to hopefully address some of the disparities that have been seen at the population level. So I will stop here, and we'll be looking forward to questions.
Dr. Alimento, thank you for that excellent overview. I'm sure we all have questions. Again, we'll remind everybody to hold on to their questions for the panel discussion. Our next speaker is well known to me and is a gastroenterologist, is Dr. Pratik Sharma. Dr. Sharma is a professor of medicine, a director of fellowship training at the University of Kansas School of Medicine. He is world renowned for as an educator and for his research in esophageal diseases, particularly Barrett's esophagus, diagnosis with advanced endoscopic imaging and therapy. He has been interviewed by the Wall Street Journal and Newsweek and has over 400 publications and book chapters. He recently hosted the Global AI Endoscopy Summit and has been named the chair of the American Society of GI Endoscopy's Task Force on Artificial Intelligence. Unfortunately, because of family reasons, he's unable to join us live today. However, he has sent us a recorded lecture, which we will play. And one of his mentees will be a panelist after this session, Dr. Parasso. So now, Dr. Martello Rooney, can you please play Dr.
This is Pratik Sharma from Kansas City, and it's my pleasure to participate in the 6th Downstate Annual Health Conference with a focus on GI cancers specifically. My task is to discuss the role of artificial intelligence for colon polyps and colorectal cancer. And while we don't have specific data on AI for health disparities, we can easily assume that these technologies would be helpful across the different sectors, and that we can use this technology to bridge the gap in GI cancers as well when it comes to health disparities. My thanks and congratulations to Vignesh and his team for putting this together. So let's start off by just sharing certain basic definitions of the terminologies which are used in this field. Artificial intelligence, in simple terms, is a branch of science that performs tasks requiring human intelligence. Machine learning is a subset of artificial intelligence, and it deals with computers that are able to perform tasks by analyzing data and then generating decision-making algorithms. And that is a term that you will see very frequently used in endoscopy and colonoscopy specifically that we'll be discussing today. And deep learning is a further subset of machine learning. And what that does is allows computation of multi-layered neural networks. And a number of the studies done for computer vision in endoscopy uses deep learning algorithms as well. So this is just a primer on these different terminologies on artificial intelligence and endoscopy. One of the things to remember is that we are seeing this huge surge of artificial intelligence in medicine, and you have to wonder why and how is this happening. And of course, costs as well as healthcare dollars spent on medicine, which is $4 trillion annually, is of course a major driver for this. And this has been increasing, you can see, from the 1950s up to the late 2018 of how much money is spent in healthcare. The United States currently ranks 38th in the world in life expectancy, and these are all reasons of how AI is being utilized in medicine. And we focus mainly on the clinical aspects: imaging, patient intake, remote health, in-hospital care, precision medicine. But you have to also remember that a number of the AI uses on the admin or the administrative side will also be as important, if not more important, than on the clinical side, to make things much easier as well as much more efficient for us to perform endoscopy in our suites. So what are the potential for machine learning, and why should it be used? It can reduce delay in diagnosis. Automation of tedious and repetitive tasks should be done by the computer. It can expand access to screening services, for example, and it has the ability to deliver faster and consistent diagnosis. And so if you put all of this thing together, you can easily see how we can apply this to endoscopy, specifically colonoscopy. So what are the potential applications in endoscopy and in image recognition? Polyp characterization, polyp recognition, looking at abnormal areas within any lesion, and defining the extent of the lesion. So let's go over each one of these and see whether colonoscopy is able to meet up with these challenges using artificial intelligence today. All of this starts off by using a case study. And in this situation today, it will be colonoscopy, and which means a good bowel prep colonoscopy. So that's the use case. So the computer then collects all this information, which has been collected by still images or by videos, and that's the ground truth, which is then assembled in there. And then by using machine learning, deep learning, and the CNNs, the computer gets trained, retrained by using several thousand images and videos until it is able to now, become smart and start doing tasks which you assigned it to do. So this is how for colonoscopy it would work. Let's see an example of this. Polyp detection during colonoscopy. Here's a colonoscopy being performed during the withdrawal phase. You can see that as soon as the machine is turned on, as it is in the AI mode, the bounding box appears, and it starts telling you where the polyp is. In this situation, you can see a small flat polyp, which is being recognized by this GI Genius device. What's the evidence that we can have computer-aided diagnosis of colorectal neoplasia? This is the initial study, an Asian RCT of more than 1,000 patients in China that underwent and were randomized to a high-definition colonoscopy versus a high-definition colonoscopy in conjunction with a CAD-E device. And this is the input, probability map, as well as the output of what the polyps were. And what this study was able to show that there was a significant difference in finding ADRs between the two techniques. And this thing was shown also for specifically diminutive polyps, showing that in a randomized controlled trial in an Asian population, using AI was significantly better than non-AI or standard colonoscopy without AI. We now also have data from a large European randomized controlled trial, which was published in Gastroenterology by Alessandro Rapici and colleagues. And what this did is looked at close to 700 patients undergoing screening or surveillance colonoscopy. Average age was 60 years with half and half men and women. You can see the randomization between high definition colonoscopy versus the CAD-E device, which used the CNN algorithm of the GI Genius. Here are the results. Adenoma detection rate, adenomas per patient, or the APC, significantly different between the two arms, And they were also able to show that diminutive polyps as well as large adenomas were significantly higher in the CAD-E group or in the AI group as compared to the standard colonoscopy group. So we are to a point, at least for the real-time detection of colon polyps, that we have randomized controlled trial data. To put this thing all together, just very recently in endoscopy, the systematic review and meta-analysis was published, which used all the randomized controlled trials with 4,300 patients with undergoing colonoscopy, either screening, surveillance, or diagnostic colonoscopy. And what it showed was a significantly improved adenoma detection rate, polyp detection rate in the studies using AI as compared to those without AI. The mean APC, or the adenomas per colonoscopy for very small adenomas, in that AI was better than no AI, and they were able to show that as well. So even small polyps can be recognized with artificial intelligence. So this is what's there for CAD-E. Now let's look at characterization of polyps with the help of artificial intelligence. And this is looking at, this device, and it tells you that there's an adenoma in this situation. And the same thing here is that as soon as it sees a polyp, this is the GI Genius device, it sees it, it's analyzing it, and then it will spit out what the diagnosis is, and it says that this is a chance that this is a non-adenoma. So this was the second promise of artificial intelligence, is the characterization of colonic polyps and how will it work in this situation, and that's what we have shown you here. This is a publication from last year from the American Journal of Gastroenterology. This was by the DocBot device, a CNN-based optical pathology. And what they showed was looking at the PIVI criteria for the optical pathology performance for diagnosis and leave. This is the validation as well as the test image results using this algorithm. And then they also applied it for the resect and discard strategy. And they had excellent correlation between optical pathology and true pathology for the validation images as well as for the test images, showing that even for characterization, we're almost there using machines to help us and make a diagnosis of neoplastic versus non-neoplastic polyps. How about predicting curative resection of colorectal cancer? For curative resection, you need well-differentiated adenocarcinoma with less than a millimeter of submucosal invasion and without lymphovascular invasion. And this was also recently published, looking at more than 8,000 images of large colonic lesions in the training set, and then they had a validation set of more than 500 images, and they used the ground truth as the histopathology. They used both white light imaging as well as narrowband imaging, and you can see that the accuracy of NBI in this situation for determining curative resection and predicting the depth of submucosal invasion was extremely high in this initial study which has been published. So we're getting there, in which we can help have the device find more polyps, tell you what kind of polyp it is, and then perhaps also guide us in resection of these polyps. So that's what it's doing here. There's certain challenges with false positives using the CAD-E device, which is, you may be able to have the endoscopist alerted to images incorrectly. And this was evaluated in an Italian study by Cesare Hassan and colleagues, in which they looked at close to 1,000 false positives which were identified. And what they were able to show was that the majority of these false positives were either from the bowel wall or from the bowel content. The majority from the bowel wall and minority from bowel content. And what they were able to characterize them more so was that the majority of them needed less than a second for the endoscopist to, ensure that this was a true false positive. In only 23% of them, they required more than 3 seconds to do that. And the rate of false positive per minute was about 2.4. And it was higher for the bowel wall as compared to the bowel content. And this is important for us to recognize. And these are the images. So for example, a fold can look like a polyp sometimes, or a bounding box can come there, sometimes even the normal mucosa. You could have stool, suction mark, bubbles, water, mucus, etc. looking at it. But the good news is that this, in the majority of the studies which have looked at this, it's only for a few seconds or less than a few seconds and does not distract the endoscopist that much. But again, something for us to be cognizant of as we do with this. So what's the promise here of artificial intelligence in colonoscopy? We can look at a number of these quality metrics. Pre-procedure, what's the adequacy of bowel wall preparation? And machine learning should be able to allow us to do it. How much and many times are you reaching the cecum intubation rate? The machine can now tell us whether the cecum was reached or not, and can automatically calculate the cecum intubation rates from all our procedures, for example. We've talked about ADR, improved ADR characterization and calculation, complete resection assessment and calculation, complications, which is also a quality metric. We haven't gotten into that. The patient experience, which is again outside of this. But you can see that if you look at the majority of the quality metrics which are listed here, in a number of these, AI can play a major role in the endoscopy suite when we start looking at this. Appropriate post-polypectomy surveillance can also be something which EHRs can be involved in and can be looked at in the future as well. So when you are faced with a number of these studies, these are the things that you should be looking at. What performance metrics do the authors report? Does it compare AI to a clinical gold standard? Is external validation being done? And is the system benchmarked against human subjects? So, we will be bombarded with a lot of studies on artificial intelligence, and we should be aware of all of these policies. Here are some of the limitations of artificial intelligence in endoscopy. There's lack of consistent evidence majority of the time. However, for CAD-E, we are getting a lot of evidence. Few studies with external validation, as I said. And of course, we need better patient and health services outcomes as we look at AI studies in the future. So to conclude, what I've shown is that this is the promise of AI in colonoscopy. It will help us gather information on the patients, on the bowel prep, on the indication for the procedure. It will enhance diagnosis and also establish better treatment plans or curative resection for the polyp. And finally, it will lead us to improve patient outcomes. So again, thank you for inviting me to this wonderful symposium, and thanks very much for your attention.
Thank you. Dr. Sharma's presentation was very, very focused on colon cancer detection, and hope we'll have some questions on that. I think it's time for our panel discussion, and I would like to introduce Dr. Shravanti Parasa, who is a mentee of Dr. Sharma. She's a gastroenterologist and clinical researcher at the Swedish Medical Center in Seattle. She has a background in epidemiology and biostatistics, and her current work involves population health and epidemiology projects using machine learning techniques. She's partnering with multiple institutes on the topic of artificial intelligence and uses of AI and how we can implement them in clinical practice. So we're excited to have you as a panelist, and we'll jump right into the panel discussion. If I may start off with a question, and I would appreciate if all panelists take a shot at this. Obviously, there's been a lot of interest and even a lot of research on how AI can help, cancer detection, diagnoses, and so on and so forth. And my question is, tie this to today's theme of healthcare disparities. What do you think are some of the applications that are ready to implement to reduce healthcare disparities? Will AI help improve access to these underinsured or uninsured populations, specifically with GI cancer screening? So can each of you answer this? And whoever wants to go first in no particular order.
So I can start. The question is, how do we reduce the disparities at a population level, whether it's GI cancers or any disease, right? So yes, machine learning can be used, and it's actively being used by different hospital systems. And the way the use case has been designed is using your electronic health record data, you can actually precisely know which patient is the one who might not show up for their screening testing, just because of access to care and stuff like that. And there is, once you are able to identify that high-risk patient from their genetic standpoint, the second thing is, and risk factor standpoint, the second thing is, how do we reach out to them to get them integrated within the system so that they can get the care? So there are a lot of digital technologies working to, bridge that gap when the patients are not being actively engaged within a hospital system or within a clinical system. For example, if I have a patient who saw me maybe like 3 years ago, and I don't have any connection with the patient on a regular basis, there are reminders that can go out to the patient to help with that. So putting AI for risk prediction and identifying the high-risk patient and using the digital technologies to kind of bridge that gap to bring those patients back to the care that they need is something that's been working, that's many institutions are working on.
That's really great to hear. Thank you for that answer, Dr. Barasa. And I want to give an opportunity to Dr. Wang and Dr. Elemento, if you want to comment on that. Does your work focus on addressing or reducing disparities and access to care?
Well, I can just comment. I think it's very clear. I think from what we've heard today, and I think from what we read, that there's tremendous potential for AI and machine learning to impact clinical care, and I think that is going to happen at some point. But I do think that we have to be realistic about the fact that it just has not happened. There's basically essentially zero application of machine learning now in the real world clinical care. And I think that there needs to be a bit of reckoning about that, and I think a bit of soul searching maybe in some ways about what are the reasons why that hasn't happened. I think part of the issues is essentially the electronic medical record that was just mentioned. At least up to now has not been very compatible with essentially the integration of AI in the system. I think that's changing. There are some standards that are emerging, like FHIR, that I think is starting to make that possible. And I think in the near future, I'm hoping we'll see a lot more integration. I do agree that essentially the route to success there is the integration of machine learning and AI into the electronic medical record. And I think this is something that is now enabled by the more recent sort of development, new generation type of medical record systems, and the standards that are emerging like FHIR. But I think there is, again, as I said, there has to be a bit of reckoning that it just hasn't happened yet. I think there's an implementation gap. There's there's issues about trust between medical systems. Certain things that are developed in one medical system sometimes are not trusted in a different medical system. That's, obviously speaks to the fragmentation of the healthcare system in the US. So there are lots and lots of gaps. And I think that, again, I think that, maybe, building consortia and thinking about how to join forces between different centers is maybe the way to go to enable this better integration. Because again, it just hasn't happened. But I'd be interested to hear more about the panelists about, how they view the future of this, integration of AI, and what are the ideas to get to that point.
Thank you, and I really admire your honesty. And I would say from the user, the clinician, I would have to agree with you. It is quite exciting, though, the potential of AI. I welcome anybody else on the panel who would want to comment on that. Related question from our patient survivor, Diane, Nathaniel, is how available is machine learning in the Black and Brown community as we work toward resolving cancer disparities? Very, very similar question. So anyone else on the panel who would like to answer that?
I think it's a pretty simple answer. It's just like basically not available. It is a reality of the situation. I do think that again, I think if we think about what machine learning is trying to achieve, which is to learn from very large data sets, if we can, as mentioned in some of the chats, box here, think about how to diminish the impact of biases. I think there's a nice opportunity to bring some tools that clearly, at least in the research lab, seem to indicate some clinical utility. But I think one thing that needs to be done is a prospective validation of AI. I think the third speaker, had some really nice slides and vignettes around clinical trials that actually sought to assess the clinical utility of AI in the real world setting in some ways. And I think we need more of that. I think that there's too much. There's a lot of interest in taking shortcuts. In AI, it's like it's almost like AI is like a magical thing that allows you to take shortcuts. And you know what? That's just not going to happen. Just like any new technology, we're going to have to do the clinical studies, the clinical trials to assess the performance of AI in the real sort of clinical setting. And I think there are not enough of these studies. There should be more. And I think ideally those studies should also include, patient populations that have not been served well by the, the healthcare sort of system, so far. I think we have an opportunity, as I said, to do this well, but it will take a lot of work to get to that point.
Thank you, Dr. Almaner. Dr. Wang, I think you're wanted to say something to that.
Yeah, I think that's pretty much I want to say that first of all, I think there's a big gap in data is just not there. I only know NCDP has the sample size that big I can model. Other data set is very small, and most of the time in most current publication, we're still relying on the traditional statistical method because that is more hypothesis driven. So you already have your hypothesis and you model that and you have your conclusion. There's no such data available, especially in cancer. I also worked on GI, not only in head and neck. In GI, I worked a lot with molecular biomarker, and data is very limited. Most of the time, we cannot do the genome-wide scan. That's the hope. That is even more challenging than finding the important socioeconomic, because that's real high dimensional. You have, in order to screen all the gene, giving only like 100 samples, and in the pilot study only have 30 samples. That's almost impossible. So most time we reduce that to pathway and to some specific hypothesis. And I think that is still more realistic to do that in that way. Another thing is that I think for the thing I learned from head and neck, because it's much relatively real compared to GI, because even though we already know the disparity, but how to integrate disparity? It should be at the population level, which is more average effect, or at the personalized medicine level, which is more at it's actually too extreme. And in the treatment, actually, even we know that it exists, and we know in head and neck, we know HPV positive and negative, they have different risk outcome, but it's never, the treatment is still the same. So it can be a long way to really integrate, translate all the findings into the day-to-day treatment. But I think that needs more research in this area, definitely.
Thank you. if I might throw in another question, one of the biggest disparities that I see is socioeconomic, right? Uninsured, underinsured, and lack of access to even basic primary care. Is AI in the current stage sophisticated enough to function the tasks of basic primary care, or even patient education in terms of who they need to seek out first based on their symptoms? And I can think along those lines, it could potentially be used for educating patients about screening options, PrEP, and so on. Maybe Dr. Peraza, has it matured to that level?
So, so I think you asked two different questions in this. One is, has AI is at a point that it can be used as a clinical decision support tool, and can that CDS tool be independently deployed for underserved or some of those populations? The answer is no, not at this time, just because of the accuracy and, as it was mentioned before, the external validation of these kind of algorithms and the regulations around these kind of the performance of these models. So, but to answer the second question, can we give patient education snippets or some kind of bowel prep instructions, or how can we improve patients' access to our healthcare support systems for any questions? There are digital technologies, more so what we call conversational AI technologies, or in common language health bots that can be used for any, can be designed for any specific purpose. For example, in our institution, we use a certain chatbot that actually deploys instructions to patients for their bowel prep on a very timely basis, and that increases their incorporation or engagement with the system, actually.
Thank you very much. There's a question from the audience, kind of a general question. Does provider attitude have an impact on the quality of tests performed and the quality impacts the results? I don't know if it's directly focused on AI, but anybody who wants to take that question? It relates to provider attitude and impact and quality of tests.
Well, it definitely does, because it is how you engage with the patient, right? If the patient doesn't trust you with whatever recommendations you make, they are not going to follow up with you, or they're not going to take that recommendation. So the trust is the part that is most important, and how that trust is developed will definitely have impact on quality. And actually, that's why there are several studies looking at racial disparities and how Black populations do not trust certain kinds of physicians, and involvement of more Black physicians in their care has led to better outcomes for those patients.
Thank you. And there was another question: what's the role of robots in cancer performing surgeries? I can answer that to some extent. Many of us in medicine know that we do have robotic surgery available, at least for the last decade, for major operations, and it's not the robot performing itself, as many patients think. The physician is very much involved. It's more to improve your dexterity and precision, but I don't think it's yet in an endoscopic procedures or colonoscopy. There are prototypes that have been tested in Asia. So that's anyone else want to comment on that question?
I can comment, because we've been thinking about this. I think there is an opportunity that's not realized there, because I think that robotic surgeries, like you said, are being performed by the thousands or tens of thousands, and and I know that every time it happens, there are videos that are being taken. There's complete sort of monitoring of the robot and sensors across the board, and that data, as far as I know, is basically not used probably in a sort of most optimal way. I think it should be used to actually attempt to train these robots to perform certain things on their own. And obviously, we're not anywhere close to having these robots being able to replace human beings, but I can see how in some settings, maybe sort of certain simple operations like, I don't know, maybe not the right sort of one, but, removing polyps, for example, there may be an opportunity to automate some aspect of a process, or, just guide, the practicing clinician sort of better. So I think there's an opportunity to use that data that I think I haven't really seen yet, but I think the data exists, and, it would be a shame to not use it more.
Yeah, that's kind of fascinating to think. I would think that, I would want to see more basic decision-making first being implemented, because that's even more complex. That's a combination of both cognitive and technical decision-making, but it's exciting future. I have another question, which is very relevant to, I guess, all aspects of AI, cost effectiveness. One of the goals of AI is to reduce cost of healthcare and improve access. But is it really cost effective? How expensive are these technologies, whether it is, in the context of a colonoscopy, endoscopy, or genomic analyses?
Yeah, I think it's a part of the implementation. I think that, the issue is that the technologies that we use now, are probably not very compatible with AI, because you need to be able to, have images, you need to have AI that's plugged into the existing system. So I think, there's going to be a need for an investment up front to maybe kind of update and modify the systems that we use. But I think the idea is that once that's the case, there's a lot of things that are performed in a kind of repetitive, maybe take a lot of time, sort of way, and, could be automated and improved in terms of performance using AI. So I think there's going to be a need for an investment, but the idea is that investment should decrease the cost down the line. And again, we're talking about how, after doing the trials and everything, but, there's a great potential, in my view, for reducing costs, because AI is basically software, and software can be copied and can be distributed to 1,000, tens of thousands, a million people, all the night. So the potential for saving costs is high.
Great.
I want to add a comment that there's some smarter way to reduce cost as well. For example, at Moffitt, we a major cost for running deep learning is GPU cost. GPU is depreciating very fast, and buying a new one is very expensive. And on the other hand, we noticed that actually in the hospital side, they actually have very powerful GPU. So which is not used for deep learning. They actually use that just for remote desktop, but they buy very powerful GPU at Moffitt. So because they have many, like nurse have station, they want to log into the main computer, they need a powerful GPU. So actually, they do, in the hospital, they do have very powerful GPU that research doesn't know. But it looks like they have, the usage is very low during the nighttime. During the daytime, especially in the cancer hospital, during the daytime it's highly used, you don't want to mess up with that. But during the nighttime, they're just sitting there, not used. So we have been talking with them and trying to leverage that very $1 million GPU to do the deep learning training, because as we know that, but not for deep Bitcoin mining. A lot of people, if they know Bitcoin mining is that use GPU running to get the dollar, but that's the only most expensive way to get the GPU. So I think to leverage the resource that's also available at the hospital, we can do a better job in cost. Other costs will be including the postdoc, and that's pretty much it. And also another challenge is how to attract students to working in AI for health, not for finance. That is the trouble I have been struggling with. All my students graduated in the past 3 years, they all went to Wall Street. So because they get a bigger pay, but they don't want to work with me because I only give them NIH minimum. So how to deal with that? Can we then better way to attract AI students to work in this area? So that is another thought. Thank you.
Thank you, everybody. And I'm sure there's a lot more questions. We're unfortunately out of time, but please email any questions you have to me, and I'll do my best to forward it to the appropriate person, or you can directly email the faculty. Thank you all again for participating in this very exciting session. So now I'm going to hand it over to Dr. Salifu and Dr. Martello Rooney. Thanks again to all of you.
Very nice. What a wonderful, session. Thank you very much to all of you. We are deeply appreciative. Okay, Laura, let's play the video. Now, some of you may have heard.
Friends, Dr.
Okay.
Sally, Laura Mattello, Jean Paredes, and Kathleen Powderly. I appreciate you and the SUNY Downstate Health Sciences team for continuing this important conference. I look forward to this annual symposium, and as the grandson of Henrietta Lacks, I'm honored to leave you with these closing remarks. My grandmother was a loving wife and a mother that passed away from metastatic cervical cancer. Like so many, the cancer that ravaged her body left her 5 children, husband, her family, and the community mourning her passing, all too soon at the early age of 31. Yet, what was also phenomenal about our Henny was the healer cells that were taken unknowingly that would go on to impact the entire world. The woman in my family would always say she was an original Black girl magic. This year, in honor of her 100th birthday, our family launched the Healer 100 and Henrietta Lacks' centennial celebration. That celebration was CELL. We invited the world to support our mission to preserve Henrietta Lacks' legacy by educating future generations on the impact of her phenomenal healer cells while promoting health equity and social justice. It's been an incredible year, and we are grateful for the outpouring of support from our leaders and advocates worldwide, including the World Health Organization, National Women's Hall of Fame, the leadership of the Divine Nine, Miss America, ACS CAN, and many more. You can learn about our efforts and how to collaborate with us at healer100.org. Recently, we were proud to see the passage of the Henrietta Lacks Enhancing Cancer Research Act was signed into law at the end of 2020. This act honors my grandmother's name, and I was proud to begin this initial journey with our dear friend, the late Congressman Elijah Cummings. My family is also grateful to Senator Van Hollen, Congressman Antonia, and the patient advocates at ACS CAN who helped to make this law possible. The act calls for the Government Accountability Office, GAO, to complete a study that reviews actions taken by federal agencies to help to address barriers to participation in federally funded cancer research trials by populations that have been traditionally underrepresented in such trials. This would include a review of cancer clinical trials that are largely funded by federal agencies, including the NIH. Clearly, this is a long overdue step towards meaningful public policy change. As many of us here today know all too well, despite the fact that communities of color and other marginalized groups experience higher cancer rates and barriers to high quality care, we continue to face challenges when enrolling and participating in clinical trials. This act will help ensure all groups have more equitable access to potentially life-saving advances in cancer research, and is a worthy reflection of the impact of my grandmother's life. My family is proud that this impactful public policy change will continue the lasting medical and scientific improvements for all people in the name of Henrietta Lacks, the mother of modern medicine. Today, we've heard about the cancer disparities that persist, but also from incredible leaders and advocates that are closing these gaps. As we end today, I'd like to leave you with this. Just like my phenomenal grandmother Henrietta Lacks' resilient healer cells, we are greater than COVID-19, social injustice, and yes, even cancer. As we enter the next phase of scientific advancements in AI and beyond, let us remember my grandmother, her story, and my family's journey. That we honor her by putting all patients at the center of what we do and how we do it to truly advance health equity. On behalf of my family and my grandmother, Henrietta Lacks, we would just like to say thank you and God bless.
Okay, you just heard from Alfred Lacks, Alfred Lux is the grandson of Henrietta Lux. And Henrietta Lux's story was in 1953 or so when she was sick from cervical cancer. Her cells were, the biopsy specimens and the cells derived from the biopsy specimen became immortalized and became the foundation of research for cancer at the NIH and across the country and maybe across the world. Those cells became famously known as HeLa cells. Those HeLa cells have now become the foundation of research for many things, including, I believe, the discovery of polio vaccine. Anyway, so that is the story that he's giving. There was some vibrations. I want to make sure that everyone understands who he was. Anyway, we are now approaching the finish line. I don't think anyone wants to doubt that we should all have a standing ovation for Laura Martello Rooney, even though we cannot all be present, and the CME office for pulling this incredible task of putting everyone together in this beautiful conference. It is amazing what you can do with Zoom. We thought that life was easy, but with the Zoom world, it's become more and more interesting with all these new discoveries of doing things differently. Anyway, so thank you, Laura, for all you do and putting this conference together. I'd like to thank all the speakers. 3 beautiful sessions, one on colon cancer, the other on pancreatic cancer, the last one on AI and machine learning, all outstanding speakers, and the questions and answer sessions were all nicely done. And I hope that this is all recorded and we can play it over and over again and continue to learn from it. Housekeeping announcements. Please, we need everyone to evaluate the program. Don't forget to log in to do the evaluation. We did the evaluation for the CMEs. It will help us, find another reason to have this conference next year so that we can continue to address this topic. And finally, I'd like to thank the 4 institutions that have come together very well in the last 6 years to make this happen. That is SUNY Downstate, along with the Brooklyn Health Disparity Center, the Cold Spring Harbor Labs, SUNY Stony Brook, and the New York Genome Project Polyethnic 1000 process for making this happen. So once again, I'd like to thank all of you for participating, and we hope to see you next year.
Thanks to all. Thank you, Laura and Dr. Sully, for a really excellent conference. And I again want to thank everybody. Thank all the panelists and the speakers.
Thank you.
Thank you. And tentatively, we are set for March 4th, 2020, hopefully in person.
Very nice. All right, everyone stay safe, take your vaccines, and try to keep your social distancing and the mask until everything is boiled down to 0, and then we can have our lives back. So thank you.